Our first main agenda with Keynote Lecture 4, with topic the important role of primary healthcare. What can we learn from the COVID-19 pandemic? Will be moderated by Dr. Danasari Vidyawati, Master of Science, Clinical Medicine and Family Medicine, Primary Care Family Doctor Specialist. Dr. Danasari finished her study as a medical doctor in 1990 at the Faculty of Medicine, Universitas Indonesia. She then finished her doctoral program in medical science, Universitas Indonesia in 2014. She also finished her magister program in clinical medicine and family med, University of Philippines. Now she is currently active as a lecturer at Community Medicine Department, Faculty of Medicine, Universitas Indonesia. Ladies and gentlemen, please welcome Dr. Danasari Vidyawati.
Thank you very much, Dr. Amalia. Hello, everybody. Very good morning, very well this morning. We meet again here in the 6th of ICE on IMERI. So in this first plenary speakers for this morning is together with us, Dr. Indah Suci Widyahening, MS, MSc, CMFM, PhD. She's actually my junior in Department of Community Medicine, but we know from his career is very success in writing in medical writing because after he graduated in as medical doctor in University of Indonesia, she also graduated as Master of Science in Occupational Health and Safety, Universitas Indonesia, and after that she took another Master of Science in Family Medicine in University of Philippines together with me, and after that she took the PhD program in Clinical Epidemiology, Utrecht University. And we know she is a very wonderful as a writing ladies, and here she got the #1 in Sinta. Okay, so with no more longer talking about the COVID-19 that we all know, it's relatively new, but after the pandemic that we all include in that pandemic for these 2 years, now we know how the importance of the primary care. And this morning, we're glad to have Dr. Indah Suci Widyahening to talk with us about the important role of the primary care. Okay, what we can learn from the COVID-19 pandemic. Okay, please, Dr. Indah Suci, we would like to hear about your presentation.
Thank you. Thank you very much, Dr. Danasari, for a wonderful introduction. And I would like to also thank you, the committee, for giving me an opportunity to participate in this respective conference. Please first let me share my slide. Okay, so is my slides already up here, Dr. Danasari?
Yes, it's clear.
Yeah, so I would like to also say a good morning to all the participants and distinguished guests in this morning conference. So Dr. Danasari has already informed me that this morning, we will discuss about the important role of primary healthcare and what can we learn from the pandemic. The important role of primary care has been realized more than 40 years ago during a joint meeting of WHO and UNICEF at Alma-Ata in 1978. There, all the delegates and leaders of countries acknowledge that primary healthcare is the key to attaining health for all in 2000. It is further strengthened during the WHO annual report, the World Health Report in 2008, that primary healthcare reforms are an essential response to the health challenge of a rapidly changing world and the growing expectation of countries and their citizens for health and healthcare. So it is already 30 years from the first declaration at Alma-Ata. Hence, in 2018, still on a global conference on primary healthcare, another declaration on the importance of primary care has been conveyed. Yeah. So in that declaration, the Astana Declaration, it is stated that primary healthcare is a cornerstone of a sustainable health system for universal health coverage and health-related sustainable development goals. However, during this 40 years journey, despite all the declarations and efforts that followed, the global community still has not attained its goal. Yeah, whether it is the health for all in 2000 or the Millennium Development Goals in 2020. So, what went wrong? Yeah, in this primary healthcare development. So it turned out that what has been considered primary care in well-resourced context has been dangerously oversimplified in resource-constrained setting. So in primary care provides a place to which people can bring a wide range of health problems. Yet it is in low-income countries, it only deals with a few priority diseases. Primary care is a hub from which patients are guided through the health system. So it is not acceptable that in low-income countries, primary care would be reduced to a standalone health post or isolated community health worker. Primary care facilitates ongoing relationships between patient and clinicians, within which patients participate in decision-making about their health and healthcare. It builds bridges between personal healthcare and patients, families, and community. So it is also not acceptable that in low-income countries, primary care would be restricted to a one-way delivery channel for priority health interventions. Primary care opens opportunities for disease prevention and health promotion, as well as early detection of disease. So it is not acceptable that in low-income countries, primary care would just be about treating common ailments. Yeah. Primary care requires teams of health professionals, including physicians, nurse practitioners, and assistants with specific and sophisticated biomedical and social skills. So it is not acceptable that in low-income countries, primary care would be synonymous with low-tech, non-professional care for the rural poor who cannot afford any better. Primary care requires adequate resources and investment and can then provide much better value for money than its alternatives. So it is not acceptable that in low-income countries, primary care would have to be financed through out-of-pocket payments on the erroneous assumption that it is cheap and the poor should be able to afford it. Hence, in 2020, as a follow-up of the Astana Declaration, WHO defined primary healthcare components. It consisted of integrated health services with an emphasis of primary care and public health functions, which put people health needs through comprehensive, promotive, protective, preventive, curative, rehabilitative, and palliative care throughout the life course. Strategically prioritizing key healthcare service aimed at individuals and families through primary care and the population, with essential public health function as the central elements of integrated health services. The second component is multi-sectoral policy and action systematically addressing the broader determinants of health, including social, economic, and environmental factors, as well as individual characteristic and behavior through evidence-informed policies and actions across all sectors. The third component is empowered people and communities, where empowering individuals, families, and communities to optimize their health as advocates of policies that promote and protect health and well-being, as co-developers of health and social services, and as self-carers and caregivers. The Declaration of Astana defines the modern concept of primary healthcare, describe the components of a comprehensive primary healthcare approach, and outlines how they promote health, equity, and efficiency. The operational framework proposes 14 levers needed to translate the global commitments made in Declaration of Astana into actions and interventions. Such action and intervention can be used to accelerate progress in strengthening primary healthcare-oriented systems and ultimately lead to a demonstrable improvement in health for all without distinction of any kind. A theory of change also explains how primary healthcare align with and contributes to universal health coverage and the Sustainable Development Goals. Here, the 14 levers to primary healthcare are political commitment and leadership, governance and policy frameworks, funding and allocation of resources, engagement of communities and other stakeholders. And in the operational levers are the models of care, primary healthcare workforce, physical infrastructures, medicine and other health products, engagement with private sector providers, purchasing and payment system, digital technologies for health, systems for improving the quality of care, primary healthcare oriented research and monitoring and evaluation. So all the 14 levers that are needed to support so the primary healthcare approach could attain its goal of the Sustainable Development Goals. However, the pandemic, it is now deeply affecting the health of many people. And we know that it also have a potential to hinder our achievement of the Sustainable Development Goals in 2030. And we see that the pandemic is also deeply affecting the health of many people who are not infected by the virus due to disruption of healthcare. Here we see that how the COVID-19 pandemic have affected the global health priorities. We have from several reports we learned that an estimated of 12 million women were unable to access family planning services, potentially leading to as many as 1.4 million unintended pregnancy. The HIV testing also fell by an estimated 41% in 2020 compared to 2019. Access to life-saving health intervention for women, children, and adolescents in the world's poorest countries has dropped by 25%, amounting to 4 million women losing access to care during childbirth and 17 million children missing out on vaccination. Malaria diagnosis fell 56%, and malaria treatment services plummeted by 59% as compared to the 2019. Approximately half of countries reported one or more disruptions to essential non-communicable disease services, with significant disruption to mental health care. While we see that mental health also highly affected by this pandemic situation. On average, 44% of countries were experiencing disruption to neglected tropical diseases, care, treatment, and education, disproportionately affecting vulnerable population in high-burden countries. Outbreaks of circulating vaccine-derived polio are still increasing, especially in African countries, and about 1.4 million fewer people received care for tuberculosis in 2020, a reduction of 21% from the 2019. During this COVID-19 pandemic, especially in the early phase of the pandemic, we see that hospital preparedness was usually the focus of the national and local response to communicable disease epidemics during its initial stage. However, it soon became apparent that hospitals can easily be overwhelmed. We soon learned that policy cannot just focus on virus and hospital. The COVID-19 crisis demonstrated the importance of placing primary healthcare at the core of health system, both to manage an unexpected surge of demand and to maintain continuity of care for all. During and after the pandemic, primary healthcare can provide comprehensive and continuity of care. So here we see that the continuation of strong primary healthcare would be able to continuously provide routine care and continuity of care for chronic diseases, as well as managing the acute condition and providing vaccination, screening, and other disease prevention activities. Provide health education for self-management of chronic condition and community engagement. While during the COVID-19 crisis, it could also provide care for people experiencing mild COVID-19 symptoms, follow-up care and rehabilitation for patients who have contracted COVID-19, help in diagnosing, tracking and tracing of COVID-19, promotion of public health measures, supporting patients physically, psychologically, and socially in adapting to COVID-19 context. And after the acute phase of COVID-19 crisis, strong primary healthcare could also provide care for people who experience worsening of health conditions due to direct and indirect effects of COVID-19 crisis, as well as psychological and providing psychological and social support, social prescribing for those who need it following the crisis. A large proportion of COVID-19 patients will not need hospitalization, while with appropriate interventions outside hospitals, the need to access secondary and tertiary healthcare services can be reduced. Primary healthcare and community care can have a central role in relieving the pressures from hospitals and maintaining population health. Here, we see in this graphic that primary healthcare can provide comprehensive prevention care, from primary, secondary, and even during the pandemic and during the COVID-19 infection or post-COVID-19 infection. So there are several services that could be conducted by the primary healthcare, from primary prevention, including giving education, risk stratification of the population, prioritize high-risk individual, pharmaceutical controls of comorbidities, which are risk factors for COVID-19, reduce health inequalities, managing mental health effects, and also giving COVID-19 vaccination. For secondary prevention, several activities could be held by the primary healthcare, including establishing differential diagnosis between SARS-CoV-2 and other infection, testing and early identification of cases, contact tracing, providing supportive treatment, home care, triage, coordination, motivation, monitoring of case isolation, and also providing online consultation and or phone consultation and support, timely identification of worsening COVID-19 disease, managing mental health effects, providing domestic support, food and medication supplies for those in quarantine. And during the after COVID-19 care, primary healthcare could also provide rehabilitation, management of post-acute COVID-19 problem, community follow-up, management of mental health effects, and also it is important that primary healthcare could continue to manage other conditions like delivery of essential health services, provide vaccination for other health problems, and treating patients with ambulatory care in sensitive conditions. So strong primary healthcare is critical first line of defense and response for COVID-19. There are a lot of things that primary health workers can do, including diagnose COVID-19, treating or refer patients to specialized care, track and report case, slow disease spread, have communities image stronger, and now it also has some important roles in ensuring the COVID-19 vaccination for the large population. I would like to give you an example of how the primary healthcare doctors in Indonesia also involved directly in this pandemic response. Yeah. So in early 2020, where the pandemic is still in the beginning phase, the Indonesian Association of Family Physicians conducted a pandemic response program in primary healthcare. So it is about more than 600 doctors participated in this program, which can reach more than 60,000 patients in 20 provinces. The activities include individual and family risk mapping, family preparedness to take care of COVID-19 patients, monitoring of confirmed patients, and provide online education. This also marked a new milestone of the development of primary healthcare in Indonesia, where in 2020 it is finally acknowledged by the Indonesian Council, Medical Council, that the specialization of family medicine and primary care is established and acknowledged as a separate specialization. These are just very small examples of the various range of activities conducted by our doctors in the Indonesian Association Family Doctors, where lots of education online education has been provided to the population in their respective working area. We see also there's a change of modalities of care delivery in primary healthcare teams during the COVID-19 pandemic. This is a result of a study in Canada. Unfortunately, we don't have such a study in our country. That during pandemic there are transition in modalities of care delivery. So if prior to pandemic, in-person care is the highest use, but now it is replaced by a telephone care delivery through telephone, yeah, and also another means like a video call, yeah. While the in-person visit now, although it is still conducted, but it is not in the highest frequency conducted by the primary healthcare. So I believe that this is also happen, yeah, in our country. As we have also developed various telemedicine platforms for COVID-19 patients in Indonesia, especially during our latest peak of pandemic, yeah, last about from July, yeah, June and July, August, and this year, where we see that the Ministry of Health also have collaboration with around 11 telemedicine platforms to provide online care for COVID-19 patients in Indonesia, and even provide medication, yeah, through online consultation. In conclusion, the COVID-19 pandemic has physically, mentally, economically, and socially damaged the lives of many people and put immense pressures on health system. To effectively tackle these challenges, a comprehensive strategy to address all physical, mental, and social health needs of populations directly or indirectly affected by COVID-19 is needed. For health systems to be resilient against health crisis of this magnitude, Strong primary and community healthcare, the front line of all health systems, is essential. Primary healthcare delivers the first line of care in communities during acute phase of health crisis and help maintaining continuity of care for people with chronic conditions. Primary healthcare also reduces pressures on the entire health system by providing comprehensive and preventive care during and after the crisis. Thank you very much.
Thank you very much, Dr. Indah Suciwidya Hening. Thank you. What a presentation that illustrates us about how the importance of the primary care. And since you explained to us, beginning with the experience in low-income countries, that we have to improve the primary care in Indonesia, and you said about the impact of COVID, not only the long COVID or complication of COVID itself, but also the other health problems like family planning, HIV, malaria, polio, TB, etc. And it needs a stronger primary care for routine care, for continuity care, and also for during crisis and after crisis of COVID-19 pandemic, of course. So the comprehensiveness of primary healthcare is maybe the key, and not only to defense and response for COVID-19, but also other health problems. And it's nice example that family doctors of Indonesia have done, and also the Canadian transformation modalities of care delivery in primary care. So after this very wonderful presentations, I believe that from the audience, we would like to ask some question to you. Okay, please, if you want to. Oh, okay. Okay, so the first question, during the pandemic, the role of primary health care is very essential. What can be done to sustainably maintain and enhance the role of primary health care following the pandemic, not just regarding to COVID-19? Thank you very much.
Thank you very much, Dr. Danasari, for conveying the questions. Yeah, it is very important question. Yeah, so it means that after pandemic, so what can we do to continuously strengthen the primary healthcare? Yeah, so not just during pandemic, but I believe this pandemic give us a very good opportunity to strengthen the system, the health system, which is more focused, which is put more focus on primary healthcare. So the system is already aware of the importance, and several efforts already put into place. Yeah, like for example, lots of capacity building activities have been conducted for primary healthcare health professions, and also the strengthening of primary healthcare, including providing better facilities, yeah, and equipments for primary healthcares in all over Indonesia. So it is already, so when the pandemic is over, hopefully, yeah, very soon, that those efforts could also will be also used to further strengthen the primary healthcare. So I think that many activities have been done, yeah, especially by the Ministry of Health, and also as a response for this pandemic, and it already gives a better capabilities of the primary healthcare to manage health problem in the community better with higher quality.
Okay. And because it's no other question from the audience, may I have a question for you, Dr. Indah? Okay. What do you think about the chance of Indonesia, who has more than 10,000 puskesmas and more than 40,000 clinics as a primary care? What is the chance of Indonesia to make a better quality in primary care?
Well, I think if everybody have a good chance, yeah, to improve the strength of their health system, yeah, through primary health care. So if we talk about Indonesia, our big population, the number of doctors, but still we see a bigger number of doctors in another country as well, and they are also in the way, like for example, in China or they're also in the way of improving the primary healthcare. So it is, I believe that if we commit to the effort, then we can achieve it. And this pandemic has given us a very, very good opportunity to improve and to strengthen primary health care. Yeah, because we learn from from a lot of countries in the world. Yeah, how it could be done. And also lots of lesson learned that we can have from another country as well, that could be implemented in our country.
Okay, thank you very much. And you agree about we have to follow the transformation in primary care?
Yes, of course, yeah. But it is a transformation in primary care is actually a continuous effort, yeah. So it's not just like today we transform into something new. No, it's not like that, yeah. But it should be a continuous effort. So it is. We might not transform suddenly, yeah, into something better, but we can improve to attain it step by step, gradually.
Okay. Thank you very much, Dr. Indah Suciwidianing. So maybe this morning is the end of our plenary, and because of your presentation today, so we all understand what is the importance of primary care also in Indonesia, and we have to do something to strengthen the primary care and then follow the transformation of primary care in Indonesia to make better health condition of Indonesia. Thank you very much for all audience this morning. We will end this plenary morning for today. Thank you very much.
Thank you.
Welcome back, ladies and gentlemen. Now we are going to listen to Keynote Lecture 5 with the topic Primary Care Transformations and Health Resilience. This session will be moderated by Prof. Dr. Budi Wiweko, Reproductive Endocrinologist, Master of Public Health, PhD. Professor Dr. Budi Wiweko finished his study as Reproductive Endocrinology and Fertility Consultant in 2009 and also gained his doctoral degree both from Faculty of Medicine, Universitas Indonesia. In 2017, he gained his Magister of Public Health degree in Gajah Mada University, and then in 2018, he gained Professor degree in Obstetrics and Gynecology. Besides as staff at the Obstetric and Gynecology Department, Faculty of Medicine, Universitas Indonesia, Cipto Mangunkusumo Hospital, he's also a Vice Director of IMERI, Faculty of Medicine, Universitas Indonesia, and also being a President of Indonesian Association for In Vitro Fertilization and Asia Pacific Initiative on Reproduction. Professor Iko, the time is yours.
Thank you very much, Dr. Amel. Very good morning, everyone. Welcome to the Keynote Lecture 5, Eyes on IMERI 2021, with the title Primary Care Transformations and Health Resilience. Our outstanding speaker this morning will be Professor Dr. Akmal Taher, urologist consultant. He is a current professor in Department of Urology, Faculty of Medicine, University of Indonesia. And also, I think all of us know him very well. He is also the former director of Dr. Cipto Mangunkusumo Hospital, and also former Director of General in Ministry of Health. And Professor Akmal Taher is a member also National Academy of Science, Indonesian Academy of Science. And if we look at his educations, he's as a research fellow at Hanover Medical School in 1993, and then also graduate from Doctoral Program Faculty of Medicine plus Indonesia in 1993. Professor Akmal Taher will talk about primary care transformation and health resilience that we think is quite relevant with the previous speaker, Dr. Indah, that already delivered a very important role of primary care in COVID-19 pandemics. And right now, Professor Akmal will talk about how primary care transformations will help us a lot in establishing health resilience, particularly in post-pandemic era. I'm sure that Professor Akmal Taher has a lot of experience in the Ministry of Health, in RSCM and other things. He's a very expert in the field of primary care. So without further ado, please welcome Professor Akmal Taher.
Thank you very much, Prof. Budi Beweko. First of all, thanks also to IMERI and the organizing committee to let me to discuss this morning about the primary healthcare resilience. Just for the disclaimer that most of the my talk this morning actually is based on the four focus group discussion from Indonesian Academy of Science, where also Prof. Budi Beweko also the member of this academy. We are the Indonesian Academy of Science is preparing the recommendation for all stakeholders, particularly for governance, about what is actually we have to do after the pandemic. So most of the thought in this presentation is based on that focus group discussion, and also as acknowledgements. This four focus group discussion actually our work in Indonesia Academy of Science using the modified Delphi method and the modified foresight actually methodology, and then in cooperation with the Center for Indonesian Strategic Development Initiative, or CISD. I want to start by saying that I want to share. Yes, yeah. COVID-19 pandemic also has an impact for all aspects of our life actually. Particularly if you look at the health systems, actually that we have this pandemic show us that give the maybe big punch to our health system, especially in setback in our effort to achieve the universal health coverage and also to have a health security agenda. These two things actually usually before the pandemic until now, I have to say that these two important things, this health emergency preparedness and also that strengthening the health systems, is divided into two themes differently. Actually, this is not a good system, and also maybe this is the cause why we respond to the pandemics not as good as how we expected. That's why to achieve the resilience of our systems, particularly in primary health care, we have to talk about these two systems, strengthening the primary health system and preparing the health emergency in one sentence. And then these presentations will show that our thinking, at least in the group of the Indonesian Academy of Science, that these two things could be done together. This is actually, if you're talking about the impact of pandemic and primary healthcare. When we want to arrange our scenario after pandemic, we have to see about the pre-existing problem. I mean, pre-existing is pre-pandemic problems, where the inequalities is so wide, and also the marginalized and vulnerable peoples actually is a very get a hit, particularly in the pandemic. The second, in order to overcome the problem after pandemics, I think everybody actually is all agreed that we have to use the primary healthcare approach and as is a public health function to boost resilience against ongoing future shocks. So there are two objectives after the pandemic. The first, we have to make our systems stronger, but the second, at the same time, we have to prepare for the future pandemic or for the future our new problems. I will start with the pre-existing condition before pandemic. Sorry for the slides, but I just want to say that Indonesian position in South Asia actually is not as good as we expected. Actually, only Philippines, Cambodia, and Myanmar actually is worse than us, Indonesia. But you can see Vietnam has already passed our position, and not to talk about the Malaysia, Brunei, Thailand, and in terms of life expectancy. The other thing you can see here, the prevalence of strokes. This is the blue one, is in 2013, and the yellow ribbon one is 2018. This is increasing in all provinces in Indonesia. This is, as we know, that stroke is the most, I think, the cause of mortality in Indonesia now. And then if you take a look at the risk factors, the hypertension also increasing in 5 years period. How about our health literacy of our consumption of food and vegetables? Is around 90. I think it's wrong. It's 93.5% of our populations consume the vegetables and fruit in the less than the health standard. This is also some basic health indicators. You can see here the immunization among children, DPT, stunting. You could talk also about the tuberculosis and malaria. Everything actually is compared to other countries in Southeast Asia. I think we have not a good positions. This is the last slide that I want to show you, and that this is also even in improved drinking water, improved sanitations, we have still a problem with this. What I want to say is that everybody easily say that the problem, the root problem is the weakness of primary healthcare. Why? Because what is actually primary healthcare? What it means, this is at least 3 components. The first is primary care, health services, and public health services function. The second is community empowerment, and the third is multi-sector involvement. If you look at this, if you say that we have the weakness of primary healthcare, that means almost all of these components is weak. We have to strengthen all of this. This is not easy task. This is a very, very hard task for us. But without, I think, the political commitment and also budget commitment, we cannot achieve our objective. You can see here, this is not only about how we actually give the health service delivery. This also will be also about how we empower the community. I will show you later, and also how we involve the multi-sectors. You can see here just a basic healthy drinking, health water, sanitation. Actually, this is in daily practice in governments. This not belong to the Ministry of Health. This belong to the other ministry. So this is our framework of thinking. Because the root problem is about the weakness of primary health care. So the way out is to transform the primary health care. This is the evidence. Why? I will show you. This statement is based on very, very strong evidence. And then the second, if you want to make the arrangement of the new system after pandemic, we have to see the pre-pandemic. I have shown you that. And then we show that what about what happened in pandemic? The very, I think, serious problem is disruption of essential health services. This is not only about the COVID. And then inadequate pandemic surveillance. Based on that, and then we will make a strategic policy recommendation. That's most of the recommendation will be shown in a short moment. And our recommendation will be not only the policy. So many policy recommendations, so many policy offered by many experts, but we tend to give not only policy recommendation but also the action recommendations. This is I will very short. This is the first thing is a political and budget commitment, because transformation of primary health care need money. WHO say if a country want to transform or strengthen the primary health care, the country has to allocate 1% of the GDP of the country for the transformation of primary health care. And if we translate this 1% of GDP in Indonesia, that means it's 165 trillion rupiah. You can imagine 165 trillion rupiah in 2021. I think the health budget is, which can be used by the Ministry of Health, is around only 48 or something for the strengthening. You can imagine it. That's depend the political gain, the political and budget commitment. And then we have to national policy directions, and then multi-stakeholders. I've shown it before, and this is also the very important. Policy interest for economic, social, cultural, and commercial environment determinants of health. This is very, very important. I will try to show you the impact of primary healthcare transformation according to the evidence. It is very, very good paper. This is from the study of WHO, UNICEF, and World Bank, which showed that the health outcomes and health efficiency and health equity can be achieved by transformation of primary health care. They study more than 2,000 literatures. This is a systematic review. I think we all know that this is very, very highest ranked methodology used by this paper. I will go into detail here. The first is health outcomes. If we talk about health outcomes, means that's about the mortality and morbidity. The first is the all-cause and cause-specific mortality. If you transform your primary health care, that means will be, the finding is for systematic review, the strong evidence that supply of primary care physicians leads to reduction of all-cause and cause-specific mortality. And strong evidence that continuity of care means this is, I think, is very unique for the family physicians to reduction in all-cause mortality. Also in maternal, neonatal, and child mortality, this is very strong evidence from 7 systematic reviews. And then the mental health outcome also. Very, very, maybe somebody, we think why we don't use our local evidence. Sorry to say that this is very, very difficult to have our own evidence, especially regarding the impact, the health outcomes in our literature. Then how about health efficiency? I think the same. All of give this strong evidence, then continuum of care. Some evidence that case management progress in primary care. Usually, we in hospital use case management, but I think it's very rare that the primary health care can use the case management and report it in a publication. And why the efficient? Because they avoidable hospitalization. Again, that if we give a supply of primary care physician, it will be make avoidable hospitalization is increasing. And we can also hospital readmission, emergency department use, healthcare costs. All of this is some evidence or strong evidence with this systematic review. And the last but not least is about health equity. Equitable access, the 2 systematic review, some evidence that primary care as compared with other health services improve equity of access. And then also in the US, strong evidence that primary care improves equity of health outcomes across of measures. Again, this I think what we can learn. So the first said that this is very, very strong evidence. That's only depend on us that whether we want to use this evidence for the policy making. But one is, I think I want to emphasize that all of the literature that we just read actually, that's the primary care is actually often with reference to physician with specialization in family medicine or general practice. This is the World Health Report in 2008. So I think if you want to achieve the same results, we have to also to follow as a policy that we have to increase the quality of our services in primary care for doctors, nurse, midwife, and all of the health workforce in primary care. But but particularly for the doctors, I think the postgraduate is a time for us to make this as a policy recommendation. I think this is very another evidence from many new, very recent publication. This is for the primary healthcare performance index and World Bank. They mix this. They call it the reimagining primary healthcare after COVID. What they learn actually is the first that we have to use the task shifting using health cadre or kader kesehatan as a frontliners. There is evidence for that. This CHW means this community health worker or health cadres, kader kesehatan. Deliver range of health. In countries also in Nigeria, it was case detection and contact tracing. And then this is for, you can see this is for the low and middle income country, but even in Singapore, you can hear what is the problem in it. It's urban health problems. There are a lot of some problems, but one of the serious problems is fragmentations. They make the cost escalating in Singapore, and also in us, that because the fragmentation between primary care and secondary care, and how the way out is care can be better managed by the single family physician rather than multiple specialists. I think again, this is just to give the rationale why we want to recommend, then we have to make use of a family physician. We go on to the system-based approach for the macro level. The first, this is the prerequisite, should be in evidence on form. So many times that we use the policy is actually without any evidence. And the second, we talk about system-based approach means that there is no instant solution for primary healthcare strengthening or transformation, because a lot of the countries, the governments want to give the instant result with instant project. What they do is actually just to give money to the hospitals. Usually a hospital gives more instant result than system-based result strengthening. That's why we not recommended for this, that we got the system-based approach. Then it is a concrete based on impacts, delivery, and sustainability. I think what we see in the last evidence that I show you, this is all of an impacts. There's a health outcomes. And change in policy direction is fundamentals of health with transformation of primary care. This is I want to underline the priority of transformation of primary health care. This is very easy to detect whether one countries actually make real transformation or strengthening of primary health care by looking at the budget allocation. Because commitment politics, always the politicians say that they will give the transformation of primary health care. But once you look at the budget, this is very, very low. This is also the pathway. So this is very, I want to show you not only the policy, the big policy, but this is very, very important. The first is structural changes. Again, if you're talking about this health system reformation, the structures is to be the challenge. First is data system. I think Prof. Iko is much more than me about how the data system. Data is fragmented between public and private owned health facilities. I personally involved in a project that I will show it later, that especially in the grassroots and the primary care, so many type of data. We have to make it much better than we have now. The second is health service delivery. This is integrated. There is almost no connection between the public and private, for example. The third is medical education system. Again, we cannot avoid the necessity to have the family doctors. Budgeting system I have also mentioned before, and the others is about using the health cadre with one multidisciplinary team. Okay, this is the theory of change, the new frameworks. I just want to give you some of that. This is shift of role of community health workers, health cadre or cadre kesehatan, from voluntary to merit and performance based. Because until now, Indonesia is only one of the few countries that not make the cadre kesehatan as a part of the health system. That's shown if you look at the strategic plan in the Ministry of Health. There is no word about the community health workers, and that also means that there is no budget for this, because Posyandu and all cadre kesehatan now belong to the Ministry of Internal Affairs or Kementerian Dalam Negeri. I think we have to change that, because most of the countries actually use cadre kesehatan as one of the backbone of the health systems. Public fair partnership is also a problem. I will show you later. So this is all of the very, very important changes that we want to have. Of course, this is quite a lot of priority. So we can have to make a short list of this. This is actually the priority. I thought that Dr. Danasari mentioned about the Canadians' reformation systems. I think I just want to show how they make prioritization. The first is the foundation or the formation, only three, then I agree with this for innovation setting. The first is appropriate infrastructure. That means who is actually actor in primary care. This is doctors, this is midwife, this is nurse, then also the puskesmas, there's also the praktek mandiri, this klinik pratama, bidan swasta. You have to listen and takes one system first. This is the first step. And then the second, this all of the facility should be connected care with the system information reporting system, one connected care. This is the foundation of all of the information system. And the third administration and funding. I will make easy for the funding. If you just stick with the kapitasi now, it's only 5,000, 8,000. This is not enough to give, to strengthen, because the weakness of primary healthcare is so serious. It's so the financial reward actually is so low for all of the health workers, doctors, nurse. That's why this is the first priorities. So we can see once you have this, you can function. How comprehensive team-based care with family physician leadership. This is, of course, this is not easy, but this health system strengthening is never easy. Sorry. Okay. I want to the last slide, 5 slide maybe, is one of the our experience. Our experience means that me involved in one of the of CHISTI program, 6 months in the 100 puskesmas in West Java, trying to give we call it the full brown intervention. We just want to know that the book that's released by Ministry of Health, we want to have to make sure all of everything mentioned in book, and we try to find the money for that, and then we want to see where there is a result or outcomes by using them. The problem is, or most of, if not all of the puskesmas, never done the full-blown intervention. We just want to try it. 6 months, we make feasibility study, make regional planning. And then we also recruitment 3 or 5 nurse or midwife and doctors voluntarily, and curriculum development training for health cadre. This is, I just emphasize again, the health cadre, the cadre kesehatan, we train when deployment, and then dashboard monitoring and evaluation plan. What we have to first is the dashboard. We make by ourselves. Why? Because you cannot get information even on 2 times a week new data. So we have to make our dashboard just to make impact evaluation. What is the criteria is training, testing, and health services. So there's 2. Essential health services and also emergency preparedness together. We measure that. I think this is very, very important to see whether this is working or not. This is just to see the community health workers. We give them the personal protection, the APD, training, appreciation, incentive, and then community health promotion and surveillance. Of course, they all work under supervision of puskesmas. We have in 6 months, and just for you, remind you that 6 months in March until September, we went passed through the peak of this pandemic. This is very, 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 very difficult time. We get the community-based worker community health workers, more than 3,500. And this is just the wicked impact achieved by engagement of community health workers. We get 98% all confirmed patient and close contacts traced and isolated within 70 hours. This is actually the condition or reached by WHO. It is very, once you can engage the community health workers in good work. Of course, I know that this is, the first question is about the sustainability. Whether after the project, there is stay. That's depend on us. We just want to show that it's work. But if you are asking about the sustainability of the program, we have to learn from Thailand. Now, Thailand have 1 million community health workers. You have to different between community health workers and volunteers. What we have during pandemics is most of it as volunteers. Volunteers means that this is, of course, it is not a bad one. But I just want to say, don't talk about sustainability with volunteers. The second, most of the volunteers come not from the local village or local area. That's different. I just want to say that what we want, our recommendation about we get the evidence from the literature, but we have also some small project. Just like I want to continue about Thailand is they have the health cadre or kader kesehatan actually since 2010 when after the avian flu, and then they make a kader kesehatan or community health workers, and then they maintain until now. That's why when the pandemic came that almost I said not so difficult to use this healthcare. So what I want to say for take home message is the primary healthcare resilience needs transformation of primary healthcare, and then also that means that this is a long journey. Evidence-informed policy and actions is absolutely needed. And this health system never be instant. It's a long journey. And why we start with political government, budget allocation accordingly, and just do it. Thank you very much.
Thank you very much, Professor Akmal Taher, for very comprehensive review and also excellent talk regarding how primary care transformations can build our health resilience. So the last slide is very important. This is a long journey, political commitment, and also budget allocations. The most important things in doing primary care transformations from Professor Akmal Taher presentations is very interesting, how we can empower our community. So community empowerment, I think, is very, very tough. And also primary care and public health functions. And the last is multi-sectorial involvement. So my first question for Professor Akmal Taher. So regarding the community empowerment, we know this is the very hard work, not only for the healthcare provider or for the primary physicians, but also for the cadre or community health workers, because it's very hard to change the community behavior. So in this case, like the PUSPA programs, so do you think that we need some collaboration with sociologists? Because if we talk about the behavior changes, we need also the approach from the sociologist perspective. So what do you think, Prof. Akmal?
Thank you very much, Prof. Iko. I think this is very important, particularly for in the macro system and also the meso system until the, let's say in the district level in kabupaten or in kecamatan. But once you take we call it the social change, social and personal behavior change. That's, I think, not only a sociologist can, but we need also the psychologists. But according to our experience in day-to-day expressions, it's once you talking about the family approach, talking about the personal approach, I think, of course, we need some theory background for the how to affect the people. But I think in our experience, for example, in Puspa, we don't have any luxuries to have the sociologists. But I think one key words in how you empower the peoples in village, particularly in our experience, because I personally involved in the two times a week evaluation of all of this Puskesmas project. This is about trust. Once you can say just easy, you have to walk the talk. I believe that Indonesian peoples is not only in the rural, still in urban. Once you can get the heart of the peoples by trusting them, show them that you are serious, I think is enough. But back to your questions, I think yes, how to in the macro level or in the district levels, how about the theory of the sociologists? I think it's very helpful. But if you use your, I think, personal touch in the village, I think it's successful also.
Yes, correct. Thank you very much, Prof. Akmal. So I think it's quite relevant with the our 5-star doctors. One of the things is called good communicator. So what do you think about our curriculum? Because you mentioned about the medical education system is one of a very important pathway. So what is that we should enrich in our medical education system right now, Prof. Akmal?
Thank you very much. It's very, very good and very important questions. The first, before answer, I ask your permission to give one I think very, very important thing that I have to also to give you information that our recommendation and also already now in the pilot project in the Ministry of Health is about integrations of all primary health facilities, integration between Puskesmas and also Dokter Praktek Mandiri, Klinik Pratama. That means actually the publics and privates. Why? The integration, I will explain. The first said that if you make, let's say you strengthen the Puskesmas, that means it's around 10,000 Puskesmas in Indonesia. But it's mentioned also by Danasari that we have more than 30 or 40,000 another primary healthcare facilities, and 1,000 of them, that means equal to the Puskesmas already in the BPJS scheme. Our recommendation is we have to make integration of this, and then, but one of the condition that integration means that this Dokter Praktek Mandiri, Klinik Pratama, they have to do the personal of prevention and promotion. For example, immunization actually is this is a prevention of. Now we don't include the private sectors but to do the immunization, or the other. I think all of everything which use the personal approach or community approach or family approach actually could be done in the health facility, not only in Puskesmas. that means actually I want to end with say that actually this is also the basic skill of the big expert of the family doctors. They use the personal, family approach and community approach, and we can say that what we mean in community is actually the people who want kapitasi.
Yeah.
By doing this, actually, we suddenly broadening our coverage in Indonesia. Not only 10,000 plus 10,000, but we can use only also the other 30,000. Of course, with with increasing the capitation, not like this,
yeah.
not like now. And then I think that's why it is also in line with our previous recommendation that we need actually the special family physician. But for the first step, we will recommend that all we need from the governments about the non-communicable disease, we can give them additional courses for them. But in the same way, you can see this is also the base for the basic surveillance also.
Yeah.
Based on that, I think, Prof. Iko, this is, but maybe Dr. Indah or Dr. Dansari can say that, of course, we can have some changes in our medical education. Not to become all medical student to become a family physician, but some factors of this kind of work in primary care should be increased in medical education.
Yeah.
Thank you.
Yeah, correct. Yes, thank you very much, Dr. Ahmad. It's very clear, right? Nose. The interesting also you mentioned about sometimes in resource constraint resource country, frequently there is an oversimplifying of primary care. So what does it mean, Prof. Akmal? Can you?
Many people think if we're talking about the primary care or primary care, that means they're very cheap. This is very how do you call it in Indonesia? Is seadanya.
Yeah.
And people also the mind of the people also think that not only a health society.
Yeah.
This is wrong, totally wrong.
Yes, correct.
Because again, if you want to strengthen, we have to strengthen not only the facility, you have to strengthen the human resources.
Yeah.
And this is need money. And also the others means of the simply is sometimes they make only isolations health facility without any networking, without any integrated between the primary care and secondary care. Just like we did maybe 20 years ago in Puskesmas. I think this is not the case. Not enough for the moment, because now our backbone of our health system will be in the primary care.
Primary care, yes, correct. So I think we all agree that the backbone of the health system in every country should be primary care. So another question is regarding the use of technology, Prof. Akmal. So about the digital healthcare transformations in our country as well. So do you think it will be a good catalyst for improving our primary care, or even like double-edged swords? Sometimes it's not answering the gap, however, will broaden the gap. So what do you think, Prof. Akmal?
I will talk about two things. The first, we have to make by design. I know that every technology, not only now with the information technology, they could be just like mentioned it to like just work with the maybe the gap will be wide enough. The answer is only about the preparations, involvement of the good planning, and also the local government's involvement. But the second, I think, if I I will concentrate also first, just like I showed about the foundation of all health reformation. There is no, I think this is absolute condition that you use technology just to make reconnected reporting and reviewing system. This is only one of the base of your specialist, Prof. Iko, about big data. Without this, I think that means we have to connect it all of the puskesmas, non-puskesmas in primary care in one health in data system. Of course, we just try first with the primary care connected in reporting system. This is the first, and this is needs technology for sure. And then we go to the second is application of this technology for other application. For example, we use also the I imagine that diagnostic decision support, for example. Of course, if you use the diagnostic decision support, your result will be better than you are only not using this. That's why I think this is the second thing that I personally believe, that once you have make the foundation is success, and then the others will follow. But if you not make this the foundation, and then you give the technology, what you afraid for is about the widening of the gap between facility will happen.
Yes, thank you, Prof. Akmal. And the last, I think, is about the role of Indonesian Academy of Science, Prof. Akmal, in order to accelerate primary care transformations. Can you explain how was our role in Indonesian Academy of Science, and also the milestones maybe?
I will modify or add the question you asked. It's very important. I actually think about yesterday about actually what is actually the role of university before Indonesian Academy of Science.
Okay.
We have the problem first. The university first is I think university have to involve much more in primary healthcare, strengthening in their activity. The first is about the evidence generation. We have experience in making the evidence summit in Indonesian Academy of Science for maternal and mortality of a mother and child. One is we try to find 7,000 publications, and then it's very not. I think of 200 or some that we can make evaluation. Once we try to make a systematic review, it's very, very few. And then what we do is we make a letter to more than 70 university and asking, not for only for publication, but what do you have in your library? Unpublished data. Because there is in university, there are a lot of residents or students have actually simple, very simple research, but it's worth actually, but not published. We try to find. We are only get 700 publication. I think this is, but maybe in our work in the Indonesian Academy of Science, I will say that just a lot you mentioned about milestone, Prof. Iko. If Indonesian Academy of Science will have a role, I think we have also to make some also how we make just not only recommendations, but also some serial or some periodically evaluations of the primary healthcare. I think this is one of the we can do. But back to the university, I very, very want to hear or want to see there is evidence in primary healthcare. And second, maybe I very want to have the Nasari or Dr. Indah, and also how IMERI also maybe have a special cluster for primary healthcare strengthening. Thank you.
Yes, thank you, Prof. Akmal, for very important message. So, do you think also by program Merdeka Belajar Kampus Merdeka, it is quite relevant with the strengthening the primary care system education in the universities?
Yes, I think in one conditions that the primary care which the student will visit has also quite ready to accept the student. This is the first, and I know, and in Ministry of Health they have. I know that they have around 120 actually puskesmas, and I think Dr. Danasari know you also about this, and then we can use, because this 120 or 60 puskesmas has already equipped by the ultrasound, and I think this is very from the equipment point of view is okay, but of course we have to make preparation. So my short answer is, of course, the Merdeka Belajar can use this puskesmas with some condition that the preparation of the peoples, of the mentors in this facility. Just for our information, maybe in Cuba, 60% of the time of the medical students actually is in puskesmas.
Okay, thank you very much. I think it's very interesting, our discussion this morning. A lot of message, and I think we are sure that we getting a lot of experience and also new insight from you. It's very important, the role of universities in medical education system, creating evidence, and also the role of IMERI. Might be IMERI can have the next one of the research center focus on the primary care. So, Prof. Akmal, you want to say something as to our audience?
Yes, I think the most important thing is that we all medical society has one agreement that once we say that the primary healthcare will be the backbone of our health systems, I think all of us should give also not help, but maybe also involvement of participation to strengthen the primary healthcare, because according to the other countries, primary healthcare is not only the government's duty. This is all of the society, professional organizations. So what we call pentahelix should involve in this project. Thank you.
Okay. Thank you very much, Prof. Akmal. So we conclude our keynote lecture 5. Once again, thank you so much, and really appreciate for your insightful talk and insightful discussion this morning. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh.
Welcome back, ladies and gentlemen. Now we will move to our next session, Concurrent Session 15, Psychosocial Aspect Among Works During COVID-19 Pandemic. This session will be moderated by Dr. Nuri Purwito Adi, Master of Science, Master in Occupational Medicine Specialist. Dr. Nuri Purwito Adi finished his Magister program in Public Health at Maastricht University in 2009, and also finished his Magister program in Occupational Medicine at Universitas Indonesia in 2010, then finished his Occupational Medicine Specialist study in 2014. Currently, Dr. Nuri Purwito is active as lecturer at Faculty of Medicine Universitas Indonesia and Occupational Health Advisor at Komatsu, Indonesia. Dr. Nuri Purwito Adi, the stage is yours.
Thank you, Mbak Amalia. I hope that my voice is clear enough. Good morning, Professor, Doctor, colleagues, and Bapak Ibu. I hope that everyone is healthy, and I'm very honored to moderate session this morning. We from the Occupational Environmental Health Research Cluster in IMERI, we would like to endorse a session about psychosocial aspect among workers during COVID-19 pandemic. It is a great challenge for us regarding the psychosocial aspect, and we did a study conducted by Dr. Dewi Sumarko, Dr. Dewi Yunia, and also Dr. Natalia, and we would like to share the result about this research today. There is a bit a shift this morning. We will start the first session with Dr. Dewi Yunia Fitriani. She is currently a lecturer at the Community Medicine Department at the Faculty of Medicine, Universitas Indonesia, and also head of the Occupational and Environmental Health Research Center at the IMERI. She finished his occupational medicine specialist at University of Indonesia at 2017, and she led the research about the occupational, the psychosocial aspect among workers, among field workers that done last year, and I think it is very interesting topic that we can see. So I hope that Dr. Dewi is ready. So please, Dr. Dewi Yudia Fitriani, the Zoom floor is yours.
Morning, ladies and gentlemen. Good morning, ladies and gentlemen. First of all, I would like to thank you to the committee who has invited me as a speaker in this prestigious conference, the Six Eyes on IMERI. Today, we will talk about the pandemic and psychosocial impact of frontliners workers. Slide, please. Slide. Okay. So today we will talk about what are the risks that the workers are exposed to, especially the psychosocial risks during this pandemic, and what are their impacts on them. Next. Okay. So this COVID-19 pandemic brought many stressors and contribute to the onset of psychosocial and even to the mental health of the workers. Regardless of the pandemic, the economy must to continue for ahead, especially for those who work in the essential industry, such as healthcare workers, law enforcement, low beverage manufacturers, stores, distributing, transportation and logistics, and also the medicals and supplies and manufacturing, and those who work in basic needs such as energy, electricity, water, oil and gas, and waste management. Next. Yes, these workers, the frontline workers, they need to keep on working even though there are the risk of getting infected when they do their work, because they still need to go outside of their work, their home. When most of the people are doing the lockdowns, staying at home, immobilization. So these several factors can be associated with the impacts of their mental health, especially those who work as healthcare workers. or maybe workers who are still working, providing services, having talking or contact with other people. Next. Yes, so this pandemic COVID that starts on March 2020 really bring a lot of change into our world, and that change happens so suddenly. Yeah, even those essential industry workers keep on working, there are some changes in their work system to protect their workers getting infected by the COVID-19, such as you can see maybe reducing the number of people who are working, yeah, so they can keep the physical distancing when they go to their office or when they go to work, except for the healthcare workers. And then they have to maybe do some screening, such as doing the swab test or the antigen test before they go to work, or maybe they need to do the quarantine. Yeah, if they have to go to the field or to the site before they enter the site, they have to quarantine in like a hotel or a place that they cannot go outside for several days to make sure that they don't have the COVID, and then they can go to work. And those kind of things can raise the psychosocial impacts, yeah, that can disturb their mental healthness. Please slide. Yeah. So the work arrangements and condition has changed considerably. And also, despite of the changes, there are some other stressors, such as the job insecurity. You know, like the fear of losing the job, or a layoff, yeah, or reduced benefits because of the number of working hours is cut off also. And then worried about getting infected at work or passing the virus to the family when they come home. Yeah, that's also can be the stressor to the workers. And this uncertainty of pandemic situation may question how their future is going to be. There are lots of changes. It's very dynamic in terms of the rules, the regulation from the government, and then also from their companies. This might give the workers more stressors than they do before they have the pandemic. So now they have both stressors from the work that they usually do every day, and stress from the pandemic itself. Next. So these are the work-related psychosocial risks that may arise or increase as the result of the COVID-19. The first one is increased workloads. This happens because of the reduction of the number of workers that is doing work on the field, because they need to do the physical distancing. And so that usually, like, if they have one a job doing with that has been done before with 5 people, and now they reduce into 50%, let's say into 3 or 2 people, those 2 people who remain in the team must get the job done. So they will have the workload increase by covering the others team members' work. So that might happen. And then the longer working hours might happen because as you all know, some of the people who before going to the site or the field, some company asked them to do quarantine. So those who are usually working like 4 weeks on and 4 weeks off, rotational system, they will add maybe 1 or 2 weeks before they go into the site. So now they can do like 6 weeks on and then 4 weeks off. So there's going to be change in the working hours also. Reduce resting periods. This might also because of the longer working hour. Change in income, yeah, especially those in the companies who are dealing with the financial problem, with this uncertainty of the pandemic. They have to close some of their branches, so this might result in the job insecurity. Next, please. Now we talk about the impacts of those stressors. The impacts can be on the physical and mental health problems. On the mental health problems, it might cause a low mood and motivation, anxiety, depression, maybe with suicidal thoughts, burnout, and maybe changes in behavior. So they do some negative coping mechanism like using tobacco, alcohol, or drugs. Yeah, this might happen when they are exposed to lots of stressors and they respond with the highest level of stress that may result in mental health problems. Next. And impacts on the physical problems, they might have the digestive problems, yeah, such as gastritis, yeah, changes in appetite and weight, yeah, some neurodermatitis or cardiovascular disease, or even musculoskeletal disorder like ache or pains that they cannot explain why. So it's the impacts of in their physical health problems. Next. Okay. And how about the impact on the workplace? If most of the workers are having the health impacts such as mental or physical impacts, it can also impact the workplace, such as increased absenteeism, yeah, especially with the high rate of contact with the patient of the COVID-19 and they have to do quarantine, something like that, will increase the absenteeism. And those who with and physical problems also will increase the absenteeism. And also increase the presenteeism. Presenteeism is when someone is having some symptoms or any health problems, but still can go to work. But at work, they cannot do anything. They just being there, being present, but not doing productive things. And also can lower the job engagement. This is especially if the stressor is about the job insecurity. Yeah, they cannot predict what's their future is going to be. Yeah, reduce the job performance, especially when they get fatigue. Yeah, from doing the increased workloads. Yeah. And reduce the accuracy of work and increase the possibility of human error, which can increase also in the work accidents or work injuries. So next. We conducted a study on impact of pandemic on frontliners in oil and gas field workers. So we conducted a cross-sectional study about 8 to 9 months after the government say about the pandemics in 1,542 subjects of oil and gas field workers. Those workers who are still need to go to the field while still on pandemics. And we assess the prevalence of their mental health symptoms and its associated factors among them. So the subjects are workers who are worked on the field during pandemic and who had minimum of working period of 1 year, and those who were not treated as mental illness during this research. The types of mental health symptoms that being studied were emotional mental disorder, anxiety, depression, and PTSD. Next. So the instrument that we use is the informed consent, of course, and the screening questionnaire. The questionnaire for the characteristic or demographic of the respondents. And for the PTSD, we use the PCLC-17. For the anxiety, we use the GAD-7. For the emotional mental disorder, we use SRQ-20. And for depression, we use the PHQ. Next. And this is the result on the impact of pandemic among oil and gas field workers. For the emotional mental disorder, there are 88% of the field workers who are having emotional mental disorder. And for depression, about 2.4% of the oil and gas field workers having a moderate to severe depression symptoms. And for anxiety, there are 2.5% who were having anxiety among them. And for PTSD, there is 9.1% who has very severe PTSD symptoms. But for your information, this study was conducted 9 months after the COVID-19 pandemic was announced, and there were no vaccine yet. There were very little information about the virus, and at that time there are still lots of hoaxes that are very popular among the workers, the field workers, for everyone. So there are lots of information was going on then. Okay, next. So we see that the factors associated with these symptoms are the the symptoms of mental health disorders are female, age group of 40 years and under, and those who work, those who have higher education. Yeah, and about the work-related factors, if there is a change in work duration and change in the workloads, this is associated with the symptoms of the mental health. Yeah. So next. So what do we do then? In this pandemic, when the situation is very dynamic, right now maybe there is a very low incidence of COVID-19, but but still there are maybe some news about the prediction of increasing of the COVID again. I think we still need to do some precaution and preventive or mitigation in especially those who are still working as a frontliners. Yeah, such as first we equip them with the appropriate equipments that can protect them, such as PPE, and we educate them how to use it properly. Yeah. And then also we analyze again about how their workload or workplace and work schedule is can be adjusted in a way that they can adapt with it. Yeah. And then work-life balance. I know that work-life balance is very essential, even though there is no pandemic. Yeah, increase the flexibility during working time. Yeah, or maybe give some of the workers time to help maybe their children at home who is doing school from home. Yeah, this is very important. Job security, we can increase the communication between the management and the workers about how is the company is going, in which what's the prediction in the next year or in the next 2 years. Yeah. Management of leadership. Yeah, the leader here is very important to make sure that the staff are doing well, adapting with the changes in pandemic, still doing the health promotion and prevention. Yeah, especially for those who are doing the negative coping behavior, doing the social support and also psychological support. This last one maybe will be discussed more in the next presentation from Dr. Natalia. Next. So the conclusion is frontline workers have higher risk of psychosocial impacts. Work-related psychosocial risk may arise or increase as a result of the COVID-19 itself, and also the impacts of the impacts can be physical and or mental health problems. So managing the work-related psychosocial risk during the COVID-19 pandemic is very important to help and maintain the health status of the workers. Next. Thank you very much. That's all from me. I'll give back to the moderator. Thank you.
Okay, thank you very much, Dr. Dewi Yunia, for your great presentation. Yeah, we concluded here that psychosocial factors indeed became a great problem during this pandemic situation, and Dr. Dewi Yunia also suggests some countermeasure that should be done, implemented in the company. For the next speaker, I think we are very lucky to have Dr. Natalia Widiasih Rahadianti. She's a psychiatrist and also has a master in the medical education. She finished his master in medical education in 2011 and has a psychiatrist specialist in 2007 and finished her medical doctor at 1990. Currently, Dr. Natalia is a psychiatrist and a lecturer at the Cipto Mangunkusumo Hospital. Okay, Dr. Natalia, I think you may start your presentation now. The Zoom is yours, Doc.
Thank you, Dr. Nuri, for the kind introduction. And actually, I'm not a doctor yet. That's hot. Okay, good afternoon, the participant. My name is Natalia. As you know, I'm a lecturer in psychiatry, and I will talk today about prioritizing and improving mental well-being and resilience among frontliners. As we heard from Dr. Dewi Yunia, there is a lot of frontliners having mental disorders, and how as a frontliners we cope with that situation. First, we see the timeline of the COVID-19 during the early pandemic. We saw the surge of number of cases and death, and as well as the need to adapt to the completely new normal situation, such as social distancing, working from home, and then going through a rare phenomenon called panic buying. During this time, the health workers underwent a lot of stressors, such as the fear of getting infected, and then anxiety about uncertain situation, adaptation problem, conflict with family, colleague, overwhelmed with the hot information. This stressor might arise due to the imbalance of resources and challenges faced by the health workers, and that affected their well-being, where as we can see, the psychological, social, and physical challenges they face were much greater than the resources they have. And if after that come the period of transition, where the government tried implemented a stricter way to stop the spread of COVID, such as PSBB, PPKM, and working from home. Those further adaptation and compromise are needed in their daily living. This prolonged crisis affected a number of emotion, experience, and perception that elicited another problem, such as fatigue, the motivation of healthcare workers. And during this time, we saw a rise in mental health problem, especially in this who had what we call a high-risk population, who has a vulnerable in their way of coping with the problem. As for now, we know that the number of cases have decreased, but does that mean mental health problems have equally subsided? Okay. It turned out the number of cases have indeed decreased, but reflecting on the previous pandemic like SARS outbreak, we see that psychological effect on health workers, such as PTSD symptom, anxiety, or depression, tend to persist after years after the pandemic has down. Why do this mental health problem persist? High stress environment negatively impact mental health and well-being that cause high level of stress, burnout, and even mental illness, such as Dr. Yunia previously said. And that cause this condition will diminish physical and psychological functioning, causing high rate of absenteeism and reducing professional functioning. When this thing happens, quality of care patient could be lower and causing major mental error, even leading to preventable death, thus causing more stressor to the healthcare professional, forming a vicious circle that should we consider about. In this high level of stress experienced by health workers are linked to the some causes of long-term problem, which bring about some maladaptive thought surrounding COVID-19. The widespread infodemic about COVID-19 may bring up responses such as anxiety around the uncertainty, upcoming new and even get layers variants strain, and it may rise the general anxiety among workers. And then the prolonged social isolation also cause uncertainty about rebuilding relationship that which may cause chronic loneliness when people are too worried about reconnecting again. And high mortality also play a role. What if people lose their loved ones again, and then it may lead to the prolonged PTSD. They will always haven't worry too much about their family or their loved one, and they feel fear to lose their loved one again. And then these all are unemployment and loss of income also happen because of pandemic. But there is a question of whether the economic will ever recover. And then many people will have this mindset, may develop symptom of anxiety and also depression, and those who have lost hope could turn to suicidal. And this is what happen if are all part of maladaptive responses of uncertainty, which part of pattern of inflated responsibility or catastrophizing or threat estimation or negative affect. Maladaptive response to uncertainty will in time become a form of intolerance of uncertainty, where people struggling to handle the situation beyond their control or even limited information. Intolerance of uncertainty also may worsen mental illness and keep them from getting worse. This is why it is important to deal with it. So how we could control the or become tolerant to uncertainty, we will talk about cognitive flexibility. Individuals should have trained to have cognitive flexibility. Cognitive flexibility is the ability to efficiently switch between effective response to given situation. In this example, in other hand, when we have a good cognitive flexibility, we tend to have multiple perspectives when responding to the event, such as even though during the stressful event, we usually undergo two types of stress appraisal. One is we call the differentiation, a process of recognizing multiple perspective event, and then the second one is integration. It is which is the conceptual association, various perspective by recognition and weighing trade-off the compromise between opportunity or loss among the coping strategy. The appraisal process will form the coping response that lead to the outcome. Now, we'll take a look stressful event such as a patient that caused by the COVID-19. And then in this situation, the frontliner could be who are more not flexible, usually having difficulty in differentiate. They only have one perspective, like it is my fault of being incompetent. And then when they integrate this situation, their coping response not flexible, like self-blaming or tend to be personalized the situation, and then they this outcome will be persisting mental health problems such as PTSD or anxiety or depression. And those with persistent mental health problem as an outcome, when the cognitive flexibility is low, intolerance of uncertainty is usually increased, as we tend to consider uncertainty as a threat, have difficulty setting aside irrelevant information, difficulty in stopping maladaptive response, and difficulty in learning to be more adaptive in certain situation. This is why we know there is young doctors who are good in the field of her work become suicide because of her intolerance of uncertainty when her patient died in the ER. How to become flexible? We have a good cognitive flexibility. We tend to have multiple perspectives when responding to the event, such as the previous one when our patient is died. We could have a different perspective. Like, even though I feel it is my fault, I can save all my patient. I cannot save all my patient, and there is just things out of my control. So I just keep doing my best for my patient. This is an example of flexible coping response that usually will lead to the more favorable outcome. Okay. Why having a high flexibility will also increase our productivity, our creativity, and our quality of life, and also increase our resiliency during the difficulty time. Resilience is the ability to withstand or recover quickly from difficult conditions, and it's the key to overcome the inevitable changes. As having resiliency, we will see the problem as a way to self-development, and we understanding ourselves and understanding our strength and our opportunity to learning more to grow if there is a limitation or there is something we do is still wrong. And now we talk about how to promote well-being and resilience in adaptive way. This is the way to form better tolerance to uncertainty by increasing resilience. Increasing resilience is to maintain the way to form better tolerance of uncertainty and the stressor weight, but increased resilience will take time and will take intentionality among the individuals. There is 4 components we need to familiarize ourselves with when we're trying to improve our resilience. One is wellness, and then 2 is how to maintain the healthy thinking, and then 3 how to make connection, and then 4 is how to find the purpose of meaning of our life. And then to understand and explore the component, reflection is needed. Reflection is the way to focus on ourselves, to evaluate our thought, our feeling, and our behavior when we are facing the difficult time or difficulty. And then it is a chance to review our experience and examine the effect on our thought or feeling and behavior, and also examine the meaning of experience. And then after that, we can learn something from our experience and try to promote growth by gaining self-awareness, what is our strength, what is our limitation, and then how to give our weakness the opportunity to grow. So we are from a new meaning and new attitude toward the difficult situation. This is how we fulfill the component one by one. The first component is how to provide wellness. To provide the first component to promoting wellness, we need to fulfill our physical and psychological need to being more adaptive and more flexible. To fulfill our need is a form of self-care, and it's mean that we need to fulfill our hierarchy of need of our physiological need by promoting a healthy life and also a healthy lifestyle, and also safety and emotional need by controlling our irrational thought, belonging and relationship need to be by building more adaptive relationship, and also our esteem need. Our estimate is by building a more adaptive understanding our strength and our limitation and making an attempt to grow. And last thing, for our self-actualization need by achieving our full potential, being more adaptive and more flexible and having more meaningful and much happier life. How to keep this? First is keeping our body fit and healthy by staying active and having a regular schedule, and also having leisure time. Do something new like hobbies or we also have practicing stress management with speed for ourselves, like practicing mindful, or if we stress, we could do yoga or journaling to venting our negative emotion, or just practice spiritual to gaining self-controlling, and also avoid the stress situation by practicing our hobbies. And one more, we should having a risk management to control, such as another important thing to promote wellness is to stick the protective behavior 6M to avoid negative outlets such as avoiding to use drug or substance, and also as well as limiting our doom scrolling to may further increasing our anxiety during we having more information that triggering our emotion, negative emotion. And then the second one is to promote well-being and resilience is related to the second component, which is to maintain and practice healthy thinking that we called earlier as practicing cognitive flexibility. First thing to keep things in our perspective is by recognizing our feeling and thought, being aware of our irrational way of thinking, such as black and white or all or none thinking, and then personalized and inflating responsibility, or as well as fortune telling or threat estimation. After that, we need try to adopt more adaptive coping. As we know, there is several type of coping, namely dysfunctional coping, and then emotional coping, and then problem-focused coping. As we know, coping strategy is an action, a series of action or thought process that we use in meeting in a stressful or unpleasant situation, or in modifying one's reaction to such situation. Having a flexible coping ability means that we are more adaptive because we have able to relinquish an ineffective coping strategy and devise ourselves as implement an alternative one to have more effective.
One more minute.
Coping flexibility can be assessed from our range of coping strategy, what we call coping repertoire, and then our ability to change the coping strategy to deal with different types of stressful, what we call variability, and then how we select what is fit to the situations. This is the approach to coping flexibility to we should train about. And then how to practice it? We could start with maintain the positive and optimistic outlook. By maintaining the positive and optimistic outlook, we can empowering the mind that good things will happen, and those give more motivation by go forward even through activity. First of all, try not to compare ourselves with others, because it will make us to be more anxious. We should practice to broaden our repertoire coping by learning from their accomplishment. This is how to broaden our type of coping. And then we don't keep in our life, but we don't compete with anyone. But in life, we should achieve our goal in life. That life is not a sprint, but it's a marathon. So we could select what is good, and we should recognize our capability, and we should set our standard or our goal rational regarding our strength and our opportunity we have. So we should also having connection, support surrounding us with the people who always support and validate us, to give positive feedback to growing up our coping adaptation. And then the last one is find our meaning and purpose by helping others. We tend to avoid our sorrow, and we also give sense and purpose and self-worth by empowering growth and resilience to ourselves by see other people happy, and we find the meaning of ourselves as a mental by the medical frontliner. And then if there is not we cannot cope with ourselves or our family or our friends, so it's time to get help from professionals such as psychiatrists or psychologists. This is the conclusion that as a health workers, we have a high risk to undergo a persistent mental health problem post-pandemic, but we could face the intolerance of uncertainty by controlling and training the flexibility of cognitive ability, by to improve our resiliency to overcome changes and empowerment our goal to see the situation. I think that's end my presentation. I give back to the moderator. Thank you.
Thank you, Dr. Natalia. It is a very nice presentation, and I think we can learn about cognitive flexibility as well as the resilience that we might to improve in order to avoid us to have some mental health disorder. Okay, I will move to our last speaker. Our last speaker is Dr. Dewi Sumaryani Sumarko, Master of Science and Occupational Medicine Specialist. Dr. Dewi Sumarko graduated from Medical Doctor at Universitas Indonesia at 1987 and finished his master degree in Occupational Medicine at 1997. Get a brevet in Occupational Medicine Specialist at 2003 and became a doctor in medical science and at 2010. Currently, Dr. Dewi is head of Occupational Medicine Postgraduate Program at Faculty of Medicine, University of Indonesia, and active lecturer at the Department of Community Medicine, Faculty of Medicine, University of Indonesia. Dr. Dewi has research for the primary healthcare doctor, and I think during this pandemic event, and I think Dr. Dewi will show the result of research this morning. Dr. Dewi Sumarko, the Zoom floor is yours, Doc.
Okay. Okay. Assalamualaikum warahmatullahi wabarakatuh. Thank you very much for my time, Dr. Nuri. Sorry that I was very late uh, to become the first presenter. So this time I will tell you about the research. This is we call it the research. It's about the physician in the puskesmas. So one of the research is we want to see about the burnout. Okay. So burnout is the psychological syndrome due to chronic response to stressor or conflict. So there are three dimensions of symptom: emotional exhaustion, depersonalization, reduced personal accomplishment. So based on other study that we know about 35% physician in our developing countries has a burnout, and then in the we call it the United States, there are 46% physician due to burnout. And then in Europe, so I think nowadays a lot of physician has a burnout, especially for the emotional exhaustion. So during the COVID pandemic, I think the burden to the healthcare system is very high. So healthcare workers experience with the very high stress of during their work. So we need to know about the condition of burnout during the pandemic among our healthcare workers to anticipate about their performance in the future. So in here, why we choose the reduced personal accomplishment, because I think indicates reduce the symptom of one syndrome of burnout indicates reduce the productivity of worker ability, and also can make the low work spirit and maybe the failure to overcome them. So with increasing the demand and quality of health services, especially for our physician, especially in the puskesmas, I think we can anticipate about this syndrome. Okay. So our problem is the physician in puskesmas, they have the greater effort in line with increasing demand for health services in the JKN. JKN, it means the system of our social security in our population. And then demand for quality and patient satisfaction and limited number of health workers at the puskesmas can be breadth and complexity the responsibility of the puskesmas. So this condition can increase our physician job stressor, which means it also increase about risk of burnout. So given the role and responsibility of our doctor as the main element of health services, and also the magnitude of the responsibilities and the roles of puskesmas in our national health system, it is very important to know about our physician and then the relation to burnout at puskesmas. So our objective is knowing about the prevalence of burnout in our health center doctors or physician in puskesmas, and also knowing about the relationship between the socio-demographic factors with burnout at our physician in puskesmas, and knowing about the relationship between job characteristic and burnout at puskesmas. So our method is we have the subjects collect from our survey by using the online survey. And then the survey was conducted on 27 March until 21st April 2021. And then the total number of our subject is 226%. And then we are using the Maslow burnout inventory human services survey, but specific for the healthcare workers. And then we using the questionnaire too for measure about the characteristic and job characteristic and also the socio-demographic. And then we using the bivariate analyzer using the Kruskal-Willis and also the chi-squares. So this is our result. So almost the person in our study is female, more than 50%, and then more than 50% too, maybe almost 19% married, and then their income per month is less than 10 million. So the total number during the pandemic COVID is less than 40 hours. So in here we see the government has new rules for our doctors during the pandemic, and then they don't have the shift work, and then I think the location of our puskesmas is I think it's almost the same in the urban area and also in the rural area, but most of them the puskesmas location in Java, okay, and then they got more than 25 patients every day. So in here it's very I think it's very useful. The puskesmas got a lot of patients. So about the burnout, in here we have the criteria of burnout is moderate and high. So all more than 60% of our physicians in puskesmas got the moderate burnout, and only 3% of them get the high burnout. So based on that burnout, we divided into 3 dimensions, and then we see in the reduced personal accomplishment is very high, more than 40% physician has the high burnout in the dimension of reduced personal accomplishment, but not in the personalization or the emotional exhaust is only less, but the reduced personal accomplishment during the pandemic, they got high level. So based on the reduced personal accomplishment, so we see in here that only the age of the physician is associated to the burnout, reduced personal accomplishment, but the other is not related to this burnout. And then also about the number of hours is not as related to the burnout, but only the years of services. It means the duration of work of the doctors. In here, we have the association to with the burnout. So it means that if you got less than 5 years, I think the risk is more increased. And what about the the puskesmas type in our study? In our study, there is no related to type of puskesmas, and also the characteristic of puskesmas, and also the status of the physician, and also the location of the puskesmas and the number of the patient to the burnout dimension reduced personal accomplishment. So based on this result, we see that that only for gender, that is only for gender has the relation to the burnout. So it means that a person, a physician in the puskesmas has younger, they got the risk to be burned out. Okay, so the duration of work for the physician in the puskesmas, it means that if the duration of work is less than 5 years, I think they got more risk to become burned out. So in here that people maybe if the physician working more than 5 years, they have the coping mechanism of them, and then they can manage themselves not to be stressful for doing their work in the puskesmas. Okay. Now, what about our conclusion in our study? So our conclusion in here that we have a lot of physician worker got the burnout in the moderate level, yeah, 60% to 5%, and then 3.5% they got high burnout. Okay, the relationship between socio-demographic factor with burnout is only related to the burnout is only age of the physician. And then we know about duration of work or the years of service of our physician doctor is only the variable associated to the burnout. So I think the research on reduced personal accomplishment seem to be neat. And then I think it's to be specialized, and then it's necessary to identify the problem behind our problem of burnout. So our recommendation to our physician is the physician need to realize that they are vulnerable to burnout or chronic mental fatigue during this pandemic, especially reduced personal accomplishment. So physicians need to be aware of the symptom, and then they should take early prevention of themselves. And then for the healthcare facility, it should be availability of adequate infrastructure to deal with the pandemic COVID, and then setting of work schedule that takes into account the physical health of health workers, also affect the mental health of our physician. And then psychological support during the pandemic, it should be done for our physician. So what about our profession or Indonesia Medical Association for our physician? They should educate the members to be aware of the symptom of burnout, and then create a support group for our physician, and then provide information related to the psychological counseling assistant that can be assessed by our association members. And then what about our government? Our government is the central government can coordinate with the local government to carry out burnout surveillance for our medical personnel. Yeah, so it means that we can have the early detection for our physician in puskesmas. So also the Ministry of Health and the Health Office should be support for our physician, especially, and also the health workers by educating them to pay attention to burnout of them, and then facilitating the psychological counseling services to health worker in need. I think that's all for our study. So we are sorry that because our study has been finished for this semester. Okay, thank you very much, Dr. Nuri.
Thank you very much, Dr. Dewi Sumarko. There are still plenty of time. Thank you for your being on time, Doc. Okay. I think we have to move to our next session for question and answer session. I think it's very interesting topic and especially Dr. Devi mentioned earlier about problem of burnout. I'm a bit we every health workers I think feel about it, Dr. Devi. But it is very interesting that Dr. Devi mentioned here about a personal accomplishment, Dr. Devi. Maybe Dr. Devi can give a further explanation about what is the example of reduced personal accomplishment that you mentioned on your result of your study, Doc. I mean, is it due to the like they can they cannot do self-actualization based on the Maslow prism, for example, or there is another explanation, Dr. Devi?
Yeah, thank you, Dr. Nur. So I can answer, right?
Yes, okay. Doc. Yes,
okay.
Of course. Doc.
So, okay, thank you, Dr. Nuri. So it means that they seem, but I don't think so, but they lost their confidence to do something. So it's very dangerous to us if you lost the confidence to do your work. So it means that it seems they cannot do the right thing with confidence. So that's why. So if somebody cannot confidence to do their job, it's very dangerous. So in here we see that because this is the second years of the pandemic, so it means our doctors is getting very tired. So the last year I have the burnout study too. We don't have this dimension. It's still low, but nowadays it's still high, moderate and high. It's very interesting. So that it means that you have the coping mechanism, but I think the coping mechanism of our doctor it's not good enough. They lost their confidence to do the right things. So it means it's very dangerous. Okay, I think Dr. Natalie can explain about how to be self-confidence to do your work.
Yeah, Dr. Natalie mentioned about the resilience, and I think it's cognitive flexibility. That's I think important soft skill, Doc. And based on Dr. Dewi Sumarko explanation that the resilience or the coping mechanism of our health care workers, it's still low. Do you have any suggestion, Dr. Natalia? How
this
can
is
we
doctor,
improve?
medical doctors, loh, Dr. Nur?
Oh, medical doctors.
Yes, physician.
This is
physician in the Puskesmas.
Yes, I mean, I think it's not only for medical doctor, but also healthcare workers in general. But maybe specifically for the medical doctor. Do you have any suggestion, Dr. Natalie? How should we improve our resilience or cognitive flexibility, in order so that we can tackle our mental health problem?
Okay. Maybe we can talk about why people lost their hope related to the personal accomplishment. We should talk it is part of the symptom of depression, or this is because of the intolerance of uncertainty. Differentiated first, because as we know, during the COVID situation, during the pandemic, everything changes. Also, when this is young people, young doctors, they have cita-cita or vision. There is sky is our limit. In these years, I should be graduate, and then next year I should go to the abroad to take next step of the education. But because of the COVID, the situation changed, and they cannot be done to do their achievement. When they have cognitive inflexibility, they tend to intolerance to the situation. They tend to think black and white. So they see that it is impossible. It's already 2 years, and then the situation is not safety yet. So my dream is cannot come true. So they become more and more depressed, and they come more and more anxious, and they feel helpless or selfless, and they lost their vision or their dream. Now, to ask your question, how to bring hope to this situation? Maybe we can challenge their perspective. Maybe they cannot do the specialist abroad now or next year's. It's like my previous slide about life is not a sprint, but life is like marathon. You will be the specialist, but maybe not next year's, not in abroad, but maybe in Jakarta. You can do something similar, or just make plan about the time limit. People to be not become inflexibility because they tend to be only having one way of cope, like suit now, suit next year's. But if we can change the timeline, or you can be a specialist, it's all your goal. So just the time, just planning it, but make it rational, or make it feasible. Maybe when we think teach how to think alternative or different perspective, it could be change the way they react or the way they see the situation, and they will be reduce the burnout in their self, and they see always there's hope, but maybe the time is not fixed, but it could be achieved, and it possible like that.
Okay, Dr. Natalie, thank you. So we have to use our cognitive thinking, yeah, in order to reduce the goals and others. Dr. Dewi Yunia, I heard that you mentioned about work-life balance. I think it is very important. Maybe you can add some explanation about it. How we implement a work-life balance, especially for occupational physicians who are working at the hospital, healthcare facilities who are taking care of occupational safety and health. Do you have kind of some tips how we implement this work-life balance, though?
Okay, thank you, Dr. Nari, for the questions. Okay, for the first thing is we need to recognize or identify the work-life demands. Each workers or each person have different demands. Those who are already having kids, during pandemic, with the school closure, they have to do the school from home. Maybe they have different work-life demands than those who maybe are having senior or their parents at home. They need to take care of their parents, something like that. For some companies, they do this identification first with their leaders, and some allow the workers to use the parental leave during the school closure to take care of the children. or maybe some companies can provide financial support, like to give services for the working parents to help with their family life demands at home. So different kinds of work-life demands also will result in different solutions. So if we see, like for the health workers, maybe the hospital, like I said before, support with the quarantine place before they go home, something like that. So first, we need to identify and recognize the work-life demands. That's the key, Dr. Nuri, and it needs to be justified individually. So it's the right program for the right person. I think that's the key for our roles as occupational medicine physician at the hospital. Thank you.
Okay, thank you, Dr. Dewi. I think the time is up. I would like to make kind of conclusion for our this morning session that a mental health problem is really important aspect, and we aware that the problem is there. Based on the research, it is exists not only in the healthcare workers but also on the field workers. So we need to start with proper countermeasure, that can be done, can be managed individually. Like Dr. Natalia said, that we have to have positive cognitive or positive resilience, positive cognitive flexibility, and also it can be managed at the company or at the healthcare facilities level. So start from now, I think we have to be aware about this mental health issue and start to do some action about it. Thank you so much for Dr. Dewi Yunia, Dr. Dewi Sumarko, and Dr. Natalia. We hope that all of us stay healthy, and thank you for the opportunity to join our session this morning. I'm giving back time to our MC.
Welcome back, ladies and gentlemen. Now we are going to have a special session. There is free communication tool to accompany your lunch. On this special session will be moderated by Dr. Cynthia Olivia Maurin Jasirwan, Internal Medicine Specialist, Gastroenterology Hepatology Consultant, PhD. Dr. Cynthia Olivia finished her medical doctor at Universitas Indonesia in 2004, then continued with her Internal Medicine Specialist at Universitas Indonesia in 2010, then gained her doctoral degree at Kobe University in 2014. Currently, she is active as one of internists at Cipto Mangunkusumo Hospital. Dr. Cynthia Olivia, the stage is yours.
Okay, thank you very much to Miss Amalia Sadrina as the Master of Ceremony for today. Good morning, everybody, and Professor and every participants. Today we will have the free communication, and we will have 5 speakers for this session. And after each speaker present their poster, their paper, we will have around 5 minutes to question and answer session. Okay, maybe for the first, I will call Mr. Jonathan Pratama, with the title of the paper is about effectiveness of online training program in escalating social health workers as a knowledge about health promotion to prevent COVID-19 in Koja district. The time is yours, Mr. Jonathan Pratama.
Good afternoon, ladies and gentlemen, all participants and all judges. My name is Jonathan. Today I want to present to you my research about effectiveness of online training program in escalating social health workers' knowledge about health promotion to prevent COVID-19 in Koja district. So on 2020, UNESCO reported that the poor and the marginalized people are the population who receive disproportionate risks due to the pandemic. These populations still require more access to healthcare facility and are likely to live in unhealthy as well as dense environment, which make the virus spread easily among them. one of the sub-district in Jakarta, Indonesia, that has a high population density and high poverty rate is Koja. There were 383 confirmed COVID-19 cases and also 18 COVID-19 related deaths reported in Koja in July 2020 alone. This high number of confirmed COVID-19 cases could be related to the gap of knowledge in the population. Social health workers in public health center play an important role in developing and delivering information such as about prevention of the COVID-19 to the community. By engaging social health workers, public health center could use the knowledge and resources to improve control of the COVID-19 transmission among the community. Social health workers are frontliners in delivering the health promotion to the community, as they were required to be educated. So the objectives of this research is to perceive the effectiveness of online training program in increasing social health workers' knowledge about COVID-19. So this is my methodology. So the study design is an analytic cross-sectional study among the social health workers in Koja, North Jakarta in December 8, 2020. The training was held using Zoom application, and the materials were delivered all by an expert anesthesiologist from Cipto Mangunkusumo Hospital. All of the participants were evaluated with pre and post test right after the online training was finished. And for the participants, we recruit 35 social health workers that were distributed in 6 different sub-districts in Koja by giving invitations to register and attend a virtual training program of COVID-19. These all were done voluntarily. And then the social health workers are defined as members of the community selected from and by the community, which are willing and able to work together in various community activities on a voluntary basis in Koja Public Health Center. And then for the evaluation, we use pre-test and post-test as well as feedback questionnaire. So for the pre-test and post-test is in form of multiple choice questions about COVID-19, consists of 15 questions. We try to assess about the knowledge of the participants about the self-quarantine and then health protocols, risk factors in COVID-19, COVID-19 transmission, nutrition, and also physical activities during this pandemic era. And at the end of the training sessions, the participants were also asked to give feedbacks through a questionnaire which consists of several questions about the material and the benefit of the training program. We use Likert 5 as an evaluation scoring for this feedback questionnaire. And for the data analysis, we use SPSS software version 26. For the training materials, our training materials were all created by a dedicated team of anesthesiologists and were also published in a pocketbook titled Hidup di Era Pandemi dan Pasca Pandemi. The first material discussed mainly about COVID-19 transmissions, especially the risk of its transmission at home. And then the second one discussed about health protocol and its impact towards COVID-19 transmission. The third material discussed about nutrition and physical activities that can be done during this pandemic era. We tailored the nutrition material to the Ministry of Health of Republic Indonesia's program, which is Isi Piringku Sekali Makan, in order to make it easier for the social health workers to understand. Our training materials all could be accessed in the pocketbook, and also the reference for all of them were mainly derived from the Ministry of Health of Republic Indonesia's program and protocols, which all can be accessed in their website. All the materials were presented in 30 minutes, and the participants were given the opportunity to ask at the end of each presentation. So for the result, as we can see, the training was attended all by female social health workers with age ranging from 32 to 63 years old. The average social health workers who attended the training has worked for 5 years with minimum working experience is 1 year and the maximum is 32 years. As we can see at the bar beside, there's a increment of about 8 points in the post-test score. So this score implies that the material which were given through this module improved the knowledge between the social health workers who received the information. So there's a significant value between the pre-test and post-test score comparison, with p-value calculated using per t-test being 0.025. This result will be helpful and practical in application to Kojok's community, as North Jakarta is included in the third most prevalent cases of COVID-19 in Jakarta. So as we can see, this is the feedback result. The general feedback includes a satisfaction towards the module, with the module being clear and interesting, easy to understand, and also important and also applicable on daily basis. The social health workers also expressed that they were more confident in educating the community after attending this training program. And for the conclusion, the online training program proved that there was an increase in participants' knowledge. In the future, we also recommend the training to be held regularly, and also we need to measure the impact of the training program towards the community directly. So this is the end of my presentations. If you have any questions, please feel free to ask. Thank you for your participation and your understanding. Bye-bye.
Thank you very much to Mr. Jonathan for the presentation. We have 5 minutes for the question. If from the floor or from the participant have any question, you can type in the YouTube, and maybe the committee will read your question. Maybe for the first, I will ask to Mr. Jonathan first. How long is this research be done?
Thank you for the question. So this research, it's only for like in 3 days, but we prepare the module. That's the longest part of this study. And to prepare the module, it takes around like 3 months, and then another 3 days for the training program.
Okay, so 3 days, you train the social health worker and by online, right?
Yeah.
Did you send the module to everyone at that time, or just present it by Zoom or other tools of online?
Yeah, so we did not send the module beforehand because we want to assess the knowledge of the social health workers prior to the training program. So we deliver the materials through Zoom, and then after that we test the social health workers' knowledge again, and then afterwards we send the pocket books that we have made before to each of them to make them easier to recall and then to give informations to the community.
Okay, so there will be. Do you think it should be continue this study? I mean, in my opinion, this study looks like very good to educate the community. And do you have any plan to follow up, maybe to make the bigger research with so many, looks like training of trainer like that? Do you think it is important to continue the study?
Yeah, of course. This is only like we only scratched the surface with this study that I made, and then I'm interested in doing this more often, and then to furthermore to test the knowledge retained of the social health workers, and then if possible, I want to also analyze about whether the increase of the social health workers' knowledge in preventing COVID is mirrored into the COVID-19 transmissions in Koja district. So if that's the limitation of my study, and then in the future, I hope that I can analyze about that.
Okay, thank you very much, Mr. Jonathan. I think this is very important because we still have COVID-19 until now. Okay, thank you. I think now we can go to the next speaker. I will call Mrs. Reggie Tracia with the research about how does mite exposure, can it be a severe COVID-19 prevention? Please, the time is yours.
Assalamualaikum warahmatullahi wabarakatuh. My name is Reggie. Today I will present my narrative review about how does mite exposure, can it be a severe COVID-19 prevention? Okay, the rapid spread of COVID-19 poses a serious threat to public health. This prompted researchers to explore the pathogenic characteristics of the SARS-CoV-2 virus in order to develop effective drugs. However, to this day, the incidence and death rates due to COVID-19 are still increasing. There are several predictors of the severity of COVID-19 symptoms, including a decrease in eosinophil count below the normal range. The response of eosinophils during COVID-19 infection has been reviewed previously. Some research show that eosinophils have a molecular device that allows them to recognize and respond to respiratory virus. On the other hand, the host immune response to exposure to the host dust mite can increase the number of eosinophils through stimulation of pro-inflammatory cytokines. The purpose of this article is to review theoretically the alleged increase of eosinophils in host dust mite exposure can prevent the severity of COVID-19 symptoms. Okay, the first one is eosinophil response in COVID-19. Human eosinophils express several toll-like receptors, including TLR3, TLR7, and TLR9, which can detect virus-associated molecular patterns. TLR7 enables eosinophil to recognize single-stranded RNA virus, such as coronavirus, and stimulation of these receptors in human eosinophil triggers the production of eosinophil cytokines. Eosinophil cationic protein and eosinophil-derived neurotoxin from human eosinophils reduce viral infectivity via a ribonuclease-dependent mechanism. Human eosinophils produce nitric oxide via an inducible NO synthase, which has direct antiviral effect against several viruses. Eosinophils are capable of producing extracellular traps composed of eosinophilic granule proteins bound to genomic DNA and mitochondria. Eosinophils can also rapidly mobilize newly formed granules of T helper 1 cytokines, including EFN gamma and IL-12, which is important for antiviral immune response. Activated human eosinophils also express MHC2 molecules and co-stimulatory molecules, and can function as antigen-presenting cells for viral antigens, leading to T-cell activation and cytokine secretion. Interestingly, human subjects with asthma who were treated with the anti-eosinophil drug mepolizumab or placebo and consecutively exposed to the virus show that patients treated with mepolizumab result in a significant increase in viral titers in upper respiratory tract. This support the antiviral roles of eosinophil. The growth of biologic agent targeting eosinophils may be useful to clarify the role of eosinophils having different antiviral roles. Although preclinical studies have demonstrated that antiviral activity of eosinophil, their clinical relevance in the human response to different respiratory virus requires further investigation. Interestingly, Zhang et al. Reported that eosinophil levels improved in all patients shortly before being discharged. This suggests that the resolution of eosinophilia can be an indicator of improved clinical status. The pathophysiology for eosinophilia in COVID-19 appears to be multifactorial, involving inhibition of eosinophil egress from the bone marrow, blockade of eosinophilipoiesis, decreased expression of chemokine receptors on adhesion factors, and/or induced eosinophil apoptosis directly via the release of type 1 IFN during the acute infection. Okay, this is the increased eosinophil in house dust mite exposure. As we know, DRP1 is a systemic protease as the main allergen of house dust mite. In addition to being antigen, DRP1 can also activate protease-sensitive receptor (NTLR4) or trigger cell injury in epithelial cells. This activates NLRP3 inflammasome and secrete cytokines that recruit myeloid cells, including eosinophil. And then, activation of pattern recognition receptor in the epithelium by allergens will amplifying the entry of eosinophil. Furthermore, the released cytokines activate innate immune cells such as eosinophils to maintain the inflammation-mediated T helper 2. House dust mite allergen-mediated activation of PARs will trigger the release of pro-T helper 2 cytokines, which trigger extravasation and accumulation of eosinophils. Recent studies showed that NLRP3 complex modulates house dust mite-induced inflammation by controlling the influx of eosinophils in the mouse airway. Therefore, NLRP3 mice trigger an increase in airway inflammation in response to house dust mite, which is associated with infiltration of human cells, especially eosinophil in their airways. This study demonstrates that mice lacking caspase-1 due to house dust mite exposure trigger eosinophilia. Decreased inflammation is associated with less leukocyte infiltration into the lung, especially eosinophil. The relevance of C-lectin receptor to the house dust mite-mediated allergy is reinforced by evidence that dectin-1 is important for the development of eosinophil influx into the lung, as well as attracting T helper 2 cytokines, T helper 1, T helper 2, and T helper 17, thus recruiting eosinophils. So it can be concluded that although available data is still limited, there are indications that eosinophils have a protective effect during SARS-CoV-2 infection. Therefore, biological agents such as exposure to house dust mite targeting eosinophil may be useful to help clarify the role of eosinophils in their antiviral response. Thank you.
Thank you very much to Ms. Reki. I'm sorry, my voice. Okay. I think I will ask you some question because the study is really interesting. It looks like there is a conflicting condition, right? As far as we know that in the condition of allergic or atopy condition, it looks like that the person become more sensitive, and then maybe they will got the severe SARS-CoV infection. But in your study, it looks like that eosinophil that increase in the allergic condition have the potential protection from the SARS-CoV. Is it right?
Uh, Thank you, Doctor. Actually, this is just a narrative review because I read that it's true that there are very conflict between the theory and the fact.
Yeah.
But in the theory, I found that the severity of symptoms that arise due to COVID-19 infection is one of them caused by eosinophenia. So the lower eosinophil decrease below the normal. And the other hand, the host immune response to the host dust mite exposure can increase the number of eosinophils. So the clinical appearance is conflicting with the theory.
Yes, because until now we just think that the person that have the maybe hyperallergic like that, it seems that they will have more severe condition when they got a SARS-CoV infection. But if this is really good, the eosinophil, I just think that maybe we just can manipulate the eosinophil, so the eosinophil become more protective, but not make the allergic condition become flare up like that. Do you have any maybe another data or publication about this? Maybe someone already talk about this condition. I think to recruit the eosinophil and manipulate the eosinophils so that it can protect, or just by a natural study. What do you think?
Actually, there are some study that manipulate the eosinophil by biological agents, by other biological agents, like other parasite beside the host dust mite. But this is just a trial in mice, not in human.
Okay. Thank you very much, Mrs. Regi, for the presentation and the interesting study that is really increase our knowledge about SARS-CoV and eosinophil. We can continue now to the next speaker. The third speaker is Mr. Ronald Joshua Liman, that will present the study about the genus kinase or JAK inhibitors and coronavirus disease to COVID-19 outcome, a systematic review and meta-analysis. The time is yours, Mr. Ronald.
Good morning, my name is Ronald Joshua Liman, and I want to present an oral presentation with title JAK inhibitors and COVID-19 outcomes, a systematic review and meta-analysis. SARS-CoV-2 infection continues to spread globally, causing a global pandemic. The pandemic has put together over 169 million confirmed cases, with more than 3.5 million deaths as June 1st, 2021. While some infection appears as mild upper respiratory system and might be self-limiting, there are still notable number of patients require hospitalizations and intensive treatment following progression into more severe cases, varying from simple lower respiratory tract infection to ARDS and eventually may turn into a multi-organ failure. Therapies to treat COVID-19 have been growing and evolving rapidly, ranging from supportive care, antiviruses, and anti-inflammatory agents. JAK inhibitors have been repurposed for the management of COVID-19 because their ability to restrain immune response and cytokine release syndrome during the road of coronavirus disease 2019. The purpose of this systematic review and meta-analysis is to come up with the evidence whether administration of JAK inhibitors could enhance the outcome of coronavirus disease 2019 derived from the obtainable results. This is a systematic review and meta-analysis study of the observational and clinical trial studies. We registered this study protocol in Prospero. Upon research in the systematic review and meta-analysis, we choose as most likely attaining the coming criteria. Follow the PICO framework for population hospitalized coronavirus disease 2019 patient, interventions, treatment with JAK inhibitor drugs, comparator, a group of patients who only receive standard of care therapy or any other medication as control or placebo and did not receive JAK inhibitors drugs. Outcome, clinical deterioration and mortality. Inclusion criteria, cross-sectional case control cohort and randomized or non-randomized clinical trial research were contained. All studies beside original articles, case series, or case report studies reported that other than in English language, research focusing in pregnant women and population of age below 18 years old were excluded. The research from three databases, clinicaltrial.gov, PMC, and PubMed, were searched systematically. We use keywords JAK inhibitor or Janus kinase inhibitor or baricitinib or ruxolitinib or tofacitinib or fedrastitinib, and SARS-CoV-2 or coronavirus disease 2019 or COVID-19 in a period from 2019 until Jan 2nd, 2021 with English language restrictions. The search strategy we used was shown in the primary diagrams. We developed an extraction from the information about the study and its population characteristic, type of JAK inhibitor drugs, JAK inhibitor dose, the number of patients receiving JAK inhibitors, and the control group, as well as the outcome of coronavirus disease 2019 patients. We are focused the outcomes on the clinical deterioration and mortality. Modified Jadat scale was used to evaluate the quality of clinical trials, including the allocation, concealment, blindness, random allocation, withdrawals, and dropouts of each study. Newcastle-Ottawa scale was used to evaluate the quality of case control and cohort study. The assessment reviews the comparability, selections, and outcomes of each research. We use the Review Manager 5.4 coherent collaboration software to perform the meta-analysis to calculate risk ratio and its 95% confidence interval for the clinical deterioration and mortality outcome. We utilize mental Hansel formula. The I-square statistic was asserted to assess the heterogeneity. Funnel plot analysis was utilized to assess the qualitative risk of publication bias, while the Beck and Mamsuda rank correlation test was used to assess the quantitative risk of publication bias. The searches of the database yielded 2015 studies, an overall of 1,632 studies were attained after duplicates removing. As much as 1,567 records were removed after screening the titles and abstract, as well as matching the inclusion and exclusion criteria. Between 65 studies were full text articles which were assessed for their eligibility, and 37 articles were excluded due to the discouraging research. 7 articles had no control or comparison group. 5 articles did not bring up the criteria for the outcome of interest. 2 articles were not in English. This meta-analysis involved 14 studies, which included a total of 4,363 coronavirus disease 2019 patients. Out of 14 research, 3 research were double-blind randomized clinical trials, 1 research was single-blind randomized clinical trials, 2 research were non-randomized clinical trials, 5 were prospective cohort research, and 3 were retrospective cohort research. We used Jadat scale assessment and suggested that 4 out of 6 clinical trial researchers were high quality and the remaining 2 clinical trials were low quality. No scale was used to evaluate quality assessment of cohort and case control studies, which indicated all included studies had good quality. 12 of studies reported clinical deterioration as the outcome of JAK inhibitor in COVID-19. The pooled estimated indicated that JAK inhibitors treatment was correlated with reduction of risk of clinical deterioration in coronavirus disease 2019. The mortality outcome was revealed in 13 studies. The pooled estimates indicated that JAK inhibitor treatment was associated with lower mortality from coronavirus disease 2019. We used panel plot analysis for the mortality outcomes. This analysis saw a relative symmetrical inverted plot indicating no publication bias. Funnel plot analysis appeared an asymmetrical inverted plot for the clinical deterioration outcome indicating some publication bias. Beck and Mamsuda rank correlation tests were statistically significant for clinical deterioration outcome, confirming the presence of publication bias. Our study systematic review and meta-analysis indicated that the treatment of JAK inhibitors saw favorable outcomes in COVID-19 in terms of reduction risk of clinical deterioration and reduction of mortality rate. This review proposed that JAK inhibitor might be a prospect agent for the treatment of COVID-19. Even so, more randomized clinical trial studies are still required to further verify its benefit regarding the timing of initiation treatment. Finally, JAK inhibitors should be considered as promising drug to improve the treatment as well to decrease the mortality in COVID-19 patients. Thank you.
Okay. Thank you very much to Mr. Ronald. I have some question about this study. This is the comparison between two arms. I think it mentioned previously that the comparison with other drugs that not other than the JAK inhibitor. So it means that any other drugs can be included as the comparison. Is it right?
Yes, doctor. For the comparator, I use the standard of care treatment in the others research. So, for example, they use hydroxychloroquine or placebo or dexamethasone.
Okay, so all it means that all other than the JAK inhibitors, right? And how many study that is the RCT that it included, or no RCT, only case control and cohort?
For the randomized clinical trial, we have two double-blind randomized clinical trial, one single-blind randomized clinical trial, and two non-randomized clinical trial.
And both of them already finished, right?
Yes.
Yes. Okay. And you just mentioned only about the clinical deterioration of the COVID-19 infection. Is there any data? What specific? I mean, specific clinical appearance of the COVID-19 deterioration, because it looks like no specific you mentioned.
In my full manuscript, the clinical deterioration is defined by RDS, the patient go to the ICU or have a mechanical ventilation.
Okay, so the condition only becomes severe and then go to the intensive care unit, or no? Just it?
Yes.
Okay, and
use it
yes.
Mechanical ventilation use.
Okay, and once more, what about the mortality? How many percent that the JAK decrease the mortality? Do you have mentioned it before?
No, I'm not mentioned of the total presentation, how many presentation, but I use the review manager to count the risk ratio. So the risk ratio show that the check inhibition is the mortalities.
Okay. Okay, thank you very much, Mr. Ronald, for the interesting presentation and the study. It really increased our knowledge about COVID-19. Okay, we can go now to the next speaker, Mr. Vito Philbert Jayali, with a study about post-operative radiotherapy in benign tumor, a case series and systematic review on keloid patient. The time is yours, Mr. Vito.
Good morning, good afternoon, good evening, everyone. My name is Vito, and I'm from Department of Radiation Oncology, Faculty of Medicine, Universitas Indonesia, Dr. Cipto Mangunkusumo Hospital, Jakarta. And today I would like to present my paper, which is about post-operative radiotherapy in benign tumor, a case report and systematic review on keloid patients. Well, as we know, keloid is a benign fibroproliferative skin disorder in which the prevalence is quite small, 0.15% in Taiwan from 2002 to 2005. But this disease caused a lot of trouble to the patients, in which patients may experience pain, cosmetic disturbance, and itchiness. And this will result on the impairment on mental and emotional aspect of the patients. And it will lower the quality of life of the patients. Therefore, we must do something to these patients. Right now, there are several treatment options such as intralesional corticosteroid therapy, surgery, radiation therapy, which may interfere with vascular endothelial formation and new fibroblast proliferations. And the most common one is the surgery. However, surgery still yield a 65 to 99% recurrence rate. Therefore, we must do some things. And surgery, it is said that surgery combined with other modalities, such as with radiation therapy, it will have a lower recurrence rate. That's why this study aims to present case report and systematic review on radiotherapy as an adjuvant treatment in post-operative keloid. The methodology of this paper, there are two, the case report and systematic review. The case report, the data obtained from Dr. Cipto Mangunkusumo Hospital patients, the data obtained with informed consent. The systematic review, literature searching was done on September 30th, 2020. The articles processed following PRISMA and CEBM guideline. Risk of bias using the Concurrent risk of bias tool. The systematic review itself, this is a flow chart. There are 397 articles found from PubMed and Scopus, and after inclusion and exclusion criteria, there are final 5 articles to be appraised. And this is the keywords, and this is the inclusion criteria and exclusion criteria. Well, let's see to the case report first. There are 2 cases. The first case is a 23-year-old female Asians, lump on left ear after giving birth to second child, history of ear piercing with a mouth size of 4.3 times 2.2 times 2 centimeter. We plan surgery and electron external beam radiotherapy 3 times 6 gray within 7 hours post-surgery. The second patient is 18-year-old female Asians also, lump on both ear with the history of burn injury due to the house fire. Mass size 1 times 4 times 7.5 centimeter. We plan also surgery and 3 times 6 gray of electron beam radiation therapy within 7 hours post-surgery. But we do the left ear first before the other part of the body. And this is the patient's preparations. So this is a bolus preparations using paraffin wax. So this is the how the patient's being attached to the bolus wax. And this we give a bolus here, and this is the applicator, electron applicator. And this is how we deliver the beam to the patients. And this is the patients before surgery, after surgery, and this is after 1 month, 8 months, and 12 months after radiotherapy. And we can see that 12 months of follow-up, no recurrence, grade 1 radiation toxicity, and the patient is very well tolerated to the therapy, and the patient is very satisfied with the therapy. And for the risk of bias assessment among the papers collected, there are 5 papers, but all of the papers have a high risk of bias. But we can see that there is 2 clinical trials among the papers. Kali et al. Show that the recurrence of radiation therapy compared with steroid injection, the radiation therapy group has a higher recurrence rate. But this paper discussed more on steroid injections, and the researchers were from plastic surgery department, and no further elaboration on the specification of electron being used. So there might be a bias in this study. Slavani et al. Yield a lower recurrence rate of the surgery plus radiation therapy, 12.5% compared with other modalities and also with the surgery only. But this paper has no allocations concealment and no specific elaboration on RT interventions. The number of patients in surgery only group is only 3 patients. So there is a potential risk of bias in this study as well. But among those studies, we can see that the recurrence rate of the post-surgery external beam radiotherapy is 12.5 to 56.7%. Post-surgery brachytherapy has a lower recurrence rate, and the surgery only is 33 to 54%, with the median of follow-up 9 to 10 months. And we can see that the best one is the brachytherapy. However, brachytherapy needs certain type of applicator. So therefore, if there is no brachytherapy, electron beam radiotherapy has a comparable effectiveness for post-surgery radiation therapy. The optimal time from surgery to radiotherapy is less than 7 hours. And the minimum biologically effective dose for earlobe radiations is 15 to 22.5 gray for less than 5% recurrence rate. So this is a recommended radiation dose for earlobe radiations. But the toxicity profile is very tolerable to the patients, in which is only erythema, hyperpigmentations, epidermolysis, wound adhesions, infections, reopening of wounds, which can be easily treated. And the risk of secondary cancer, as what we afraid in radiation therapy treatment. The risk of secondary cancer report only esophageal cancer, and this esophageal cancer is far from the radiation site. So there is no direct relation between the esophageal cancer with the previous history of electron beam therapy. So radiation therapy is very safe for keloid patients. The case report shows that in 2 patients, these 2 patients have a dose 28.8 gray, treated within 7 hours post-surgery, and have a very good local control in 12 months of follow-up. And we hope that years or maybe their lifetime, there is no recurrence of the keloid itself. And the patients only experience grade 1 radiation toxicity, and which is very well tolerated for the patients. And in conclusions, we can see that the post-operative radiotherapy compared with other modalities is beneficial to improve local control and rate of recurrence. EBRT has a comparable effectiveness with brachytherapy for keloid patients, and low toxicity level was found among studies. So it's very well tolerated. However, there is a very high risk. There is a high risk of bias among studies in these papers. Therefore, randomized clinical trial is needed. Before I end, I would like to quote from Henry Ford: "Coming together is a beginning, staying together is a progress, and working together is success. Let's hand in hand together. Let's do more research for the role of radiation therapy in benign diseases." And that I would like to thank you for your attention. Have a nice day.
Thank you very much, Mr. Vito, for the presentation. I have some question about your presentation. The first question is about, you said that after you give the 2 to 6 gray of radiotherapy, and how long is the interval from the surgical to the radiotherapy? And then you said that there is also grade 1 toxicity, and maybe you can specify what kind of toxicity that the patient got as a adverse event, maybe.
Yeah, thank you. Am I clear?
Yes.
Yeah, okay. So for these patients, we give 3 times 6 gray radiation therapy. It is given 7 hours post surgery. So after coming out from the surgery, the patients directly go to the radiotherapy department, and then we directly make everything. And both of them are radiated within 7 hours. Those 3 times 6 gray is with the interval 1 day. So what day at the first day from the surgery, given first dose, and then tomorrow the second dose, and the day after tomorrow the third dose.
Okay, so every day.
Yeah.
1, 2, 3 days. Okay.
Yes, and the dose is 6 gray per fraction of radiation therapy.
Okay, so there are no additional dose after that, and then after that you follow up after 1 year.
Yep.
Okay, and then about the toxicity, the grade 1 toxicity.
So the grade 1 toxicity experienced by the patients is just only erythema and slight fibrosis of the skin.
Okay.
So there is a grading of toxicity used by the RTOG. So the grading we use usually for skin toxicity. So if the grade 0, there is nothing happens. So it's like a normal skin, but grade 1 is slightly fibrosis because, as we know, radiation therapy itself, as well as operations, also can lead to the fibrosis of the skin.
Okay.
So it's very from here we can see that it's very well tolerated by the patients.
Okay. And maybe one small question about the timing. 7 hours after surgical, is there any specific reason why we must take around 7 hours after the surgical, not maybe directly after the surgical, sound like that?
Yeah. So actually, it's very nice. It's very interesting questions. So the research, the biomedical research about keloid is very scarce. So it's very rare. We don't really know the exact mechanisms behind that. So maybe this is a further research opportunity. But as we know, radiation in keloid patients, it interfere with the process of inflammations. So in the several hours post surgery, there is a very huge inflammations coming around the surgical site. And if we do the radiations at the right time, it will inhibit the process of the fibroblast proliferation, which may lead to the keloid formation. So that's the reasons why we should do the radiotherapy as soon as possible. So there are also several publications about the exact timings. So they are saying that maybe less than 24 hours, and another publication told us to do in 48 hours, within 48 hours for the first radiations. But there is one systematic review so that within 7 hours, you have the best outcomes with the least recurrence rate.
Okay. Thank you very much, Mr. Vito, for the very interesting presentation and then also the study. I think we can go now to the last speaker for today, Mrs. Emilia Kusnaidi, with the study titled Understanding and Managing Compulsive Sexual Behavior with Cognitive Behavioral Therapy Approach. The time is yours, Ms. Emilia.
Good afternoon, ladies and gentlemen. My name is Emilia Kusnaidi from Department of Psychiatry, University of Indonesia. And today what I want to share with you is how to understand and manage compulsive sexual behavior, or CSB, with cognitive behavioral therapy approach. As we know it, sex has become part of mainstream culture, as reflected through the extensive coverage of sexual behavior in the media, movies, newspaper, and magazine. Sexual addiction has largely been ignored by psychiatrists, even though the condition causes serious psychosocial and medical problems. In 1945, the psychoanalyst Otto Fenichel coined the term sexual addiction to design the condition of driven sexual behavior. Nowadays, CSB is a term that describes a disorder featuring repetitive, intrusive, and distressing sexual thought, urges, and behavior that negatively affect many aspects of an individual's life. And the primary treatment goals for CSB patients is to improve sexual self-control, reduce problematic sexual behavior, reduce adverse consequences, particularly the risk of harm to themselves or others, and reduce distress and impairment in personal, family, social, functioning, educational, occupational, or other important areas of functioning. And Individual psychotherapy for CSB can take many forms, but the most prevalent are CBT or cognitive behavioral therapy. The concept of compulsive sexual behavior developed over the last 20 years and derived from the model of addiction to such as drug as heroin or addiction to behavioral patterns such as gambling. And it is characterized by psychological dependence, physical dependence, and a withdrawal syndrome. And CSB have a variety of repercussion, which is higher risk of STD, the potential to break relationship and emotional connection, and also the feeling of shame and guilt. Human sexuality is a multifaceted phenomenon with biological, psychological, social, and cultural aspects. It encompasses a variety of aspects of our personality, including attitudes and behavior towards sexual health, as well as value, feeling, and experiences. Many aspects of sexuality differ from men and women, such as sexual reactivity and preferences. Two early studies in the US reported that 3 to 6% of the American population suffer from sexual addiction and 5% meet diagnosis criteria for sexual compulsivity. Previous research also indicates that about 80% of individuals who use sexual behavior addictively are male, and the dominant clinical presentation of CSB is problematic pornography and usually coupled with masturbation. Identifying a compulsive sexual disorder is a challenge because of its sensitive and personal nature. But in ICD-11, it is characterized by repetitive sexual activity that become a central focus of the person's life and numerous unsuccessful efforts to significantly reduce repetitive sexual behavior. And also, there's a pattern of failure to control sexual impulses or urges and resulting in marked distress or impairment. The patient also continues the engagement in repetitive sexual behavior despite the adverse consequences and deriving little or no satisfaction from it. And the most important thing is the distress that is entirely related to moral judgment and disapproval from the public is not sufficient from diagnosis. CBT also has been shown to useful for obsessive sexual behavior both as a full treatment and a standalone method. CBT in CSB borrow heavily from substance use disorder and substance use addiction treatment CBT, which is include three core elements, which is functional analysis, a comprehensive assessment of the influencing factors of addiction, the coping skills training, which is the core of addiction. The coping skills training include the identify negative automatic thought, regaining the fun of life, problem solving, and developing a relationship. And also, the most important thing is the prevention of relapse pattern. The risk is one of a skill taught in CBT, and it is to raise awareness and to identify early warning sign for high-risk situation, for relapses, and second, to avoid risk and to develop alternative coping strategies or countering behavior. And the conclusion is, we still have a lot to understand about CSB, especially the role of cultural values in their development. And this behavior can manifest in a variety of ways, and there are probably numerous subtypes, severity levels, and clinical outcomes. And CBT has been shown to be very useful for obsessive sexual behavior, both as an adjunctive treatment or a standalone treatment. And previous report on the efficacy of the program, as well as several open studies and case reports, have reported significant reduction in sexual behavior. Thank you very much.
I would like to ask the question to Ms. Amelia Kusnaidi. This is the CBT that caused by addiction of the drugs only, or not CBT. I mean compulsive sexual behavior caused by the addiction of the drugs, or is also caused by another things. And then maybe you can tell me about the CBT, the specific CBT. I think it's not so clear what kind of CBT, I mean the tools and how the way you perform it. Thank you.
Thank you very much for your question. I will try to answer it. For the first question about the CSB itself, the CSB itself, it is usually or commonly caused by other things besides the drug. So it's commonly a separated things, two different things, and usually it's because the behavior that at first it is impulsive behavior and then became a compulsive one. So the patient will not have a good impulse control about it. That's one thing about CSB, and I will try to answer the second question. The CBT is a way for us, the therapist, to give the patient to challenge the idea of or their perspective, such as with questioning. We usually use a method called Socratic questioning. This is a method where we given a sequence question about their ideas, their values, their perspective, and then we try to recognize their cognitive error. And when we recognize that, the patient also became aware of that. And in this way, when they are aware of their cognitive error, error of thinking, it also helps their behavior. So we think about that. If we change their mindset, we can also change their behavior. That is the basic of CBT. Thank you.
Okay, and how long it takes time until they can change their mindset, and then maybe there is the change of the behavior?
Okay, thank you for the question. For the basic CBT, it is usually take 12 session with one session per week. But if you can go to the polyclinic such as 2 or 3 times a week, that is much better. But usually, if in the 12 session there were no good improvement, we can also add 2 more sessions for booster. Thank you.
Do you think there is advantage using like hypnotherapy in this condition also? Because I think when you try to change the mindset and then try preference or what they think about their behavior, when they are not so aware and make it hypnotize, is it better or no?
Okay. It is possible to use hypnotherapy in this case, but usually hypnotherapy is used for relaxation only. So we cannot insert that such idea in their consciousness in hypnotherapy. It doesn't work that way. But and also the type of the patient who can use hypnotherapy is very specific. It is also the patient who is really suggestible, so we can guide them to achieve what they want, such as more relaxed, maybe the change of perspective. But we cannot insert such an idea in this case with hypnotherapy. Thank you.
Okay. Thank you very much to Ms. Amelia Kusnaidi for the study and then the knowledge about the sexual compulsive behavior and then the way to change the behavior. I think we can close this session, this forum. I will give this session to Master of Ceremony again.
This session will be moderated by Dr. Mila Maidarti, obstetric gynecology specialist, consultant of reproductive endocrinology and infertility, PhD. Dr. Mila Maidarti finished her obstetrics and gynecology specialist at Universitas Indonesia in 2012, then finished her study as consultant in reproductive endocrinology and fertility at Faculty of Medicine, Universitas Indonesia in 2016. Then she gained her doctoral degree in the Center of Reproductive Health at University of Edinburgh, United Kingdom in 2020. Now she's active as one of reproductive endocrinology and infertility subspecialists at Department of Obstetrics and Gynecology, Dr. Cipto Mangunkusumo General Hospital, Faculty of Medicine, Universitas Indonesia. Please welcome Dr. Mila Maidarti.
Thank you, Dr. Amalia Sadrina, for reading my short CV. Assalamualaikum warahmatullahi wabarakatuh. This is actually the sponsorship webinar sponsored by Merek Serono. And it is my great honor to introduce our speaker in this session, Professor Dr. Budi Wiweko. Could you please show the slide of Professor Budi Wiweko on CV? Okay. Professor Budi Wiweko, reproductive endocrinology and fertility consultant, Master of Public Health, and PhD. He was graduated from obstetrics and gynecology, reproductive, and also reproductive endocrinology, infertility consultant, both from Faculty of Medicine, Universitas Indonesia, and currently he is a staff in obstetrics and gynecology department, Faculty of Medicine, Universitas Indonesia, and Cipto Mangunkusumo Hospital. He's also a vice director of IMERI FMUI, and he is also a former president of Indonesian Association for In Vitro Fertilization, as well as a former president of Asia Pacific Initiative on Reproduction. So ladies and gentlemen, leading with infertility patients is indeed a big challenge, not just about how to diagnose and finally to determine the cause, but also how to treat the patient. So today we have Professor Budi Wiweko, and he's going to share with us about the challenges in infertility management. Without further ado, Professor Budi Wiweko, time is yours.
Thank you very much, Dr. Mila, for a very nice introduction. So I will start with the session this afternoon with the topics, the challenge on infertility management. As the chairperson mentioned before, I think this is one of the challenges not only in the infertility management, but also in all of field of our health services in Indonesia. We are facing the current pandemic COVID-19 that fortunately, I think this month, hopefully it will be getting better now and in the future. If you look how the pandemic COVID-19 disturbed our fertility services in the world, we can see how this is the nice data from American Society for Reproductive Medicine mentioned that the pandemic COVID-19 extremely increasing the patient to become upset, and most of them are very upset or even less likely minimal and moderately upset because due to the COVID-19 they should postpone the program to have children. So that's why we also just published our current paper in fertility and production just last month. It's about the COVID-19 pandemic impact on decision-making and psychosocial behavior in women seeking fertility treatment in APEC region. And this is based on Aspire patient experience report. And the results, at least the women in the countries that have better infection control and are living in new normal were less worried about the pandemic influencing their lifestyle and the finance. And if we look into details, there is this figure 2 showing us this is the concern in women seeking the fertility treatments. Number one, the news and uncertainties that they are currently facing make them worry a lot. And this is almost the same in all of the country in Asia Pacific, and then particularly in India and Vietnam. They are very worried about that. And then also extremely worried about the risk to be infected, for them to be infected, and also the partner to be infected. And they are really worried to resume any activities until the vaccination is available. And COVID-19 had a huge financial impact. They are mainly worried about the financial consequences related to the virus. and then also try not to worry, even, and try to enjoy the activities on their own. And also they think that some of the measures taken to protect against COVID-19 are exaggerated. And what are their hope or changing hope in the clinics? I think this is their wish about the fertility services in fertility clinic. They hope that there's a testing of COVID-19 to all the staff at the fertility clinic. And also the patient also really hope there is a good preventive measurement on sanitation and more treatment slot, that it will also make a good appointment and then physical distancing during the consultations. Also, the patient prefer to have a virtual consultation, such as the teleconsultation or telemedicine that we discuss a lot in this today's conference. This is also reduced in-person visit, including the teleconsultations, and then most of them also actually avoid to visiting some clinics because of the COVID-19 pandemics. If you look how their decision making in choosing the treatments, most of them, more than half, decided not to continue the treatment because of the pandemic. Even they are still willing to have a pregnancy, even they're still willing to conceive, at least as soon as the pandemic is controllable or manageable, like now. So that's why it's very important. There is a recommendation in prioritizing patients for treatment of infertility during the pandemic. They are on prioritization are cancer patients, advanced maternal age patients, poor patients with poor ovarian reserve as categorized by Poseidon criteria, and then also the low prognosis patients based on the physician judgment, and if they have history of IVF failure or implantation failure. What is the key drivers is the very important on the patient survey. Number one, age. Age is the main contributing factor for the patients to continue the treatment. And parents want to start the family and being a parent as soon as possible. Patients trust that prevention measure in place. Patients have more time because not working or even working from home. This is the key drivers that insist the patient to come to the clinics. What are the key barriers? The barriers are the patients are very concerned about risk of infections. Patients are changing priorities in life. Patients need support from family, and patients have difficulty in access to the clinic or to the hospitals. And the last, what is the key change expected in the clinics? Number one, the patient hope there's a regular testing of COVID-19 for the clinic staff and the patients, a good preventive measurement on sanitation and more treatment slots, to increase virtual support function, including telehealth, and then the clinic reduce the number of in-person services. So I think this is the proposed broad solutions: actively manage patient safety, prioritize patients for treatment, improve patient acceptance in remote options, and then improve support for patient coping with emotional and stress situations. The other things also very challenging during pandemic COVID-19 is the risk of the SARS-CoV-2 toward gamete and embryos. Even we know there's the evidence still conflicting. Some evidence prove there is no evidence SARS-CoV-2 in semen or males recovering from COVID-19, as shown in this slide. There is no not detected in semen after a median of 31 days after recovering of from the SARS-CoV-2 infection. However, some studies also showing us that some SARS-CoV-2 can be present in the semen of the patients with COVID-19, and some SARS-CoV-2 may still be detected in the semen of recovering patients. At least we can see this is among 6 patients. There is a time since onset the clinical characteristic of patients with positive test result for SARS-CoV-2 in semen. Yeah, you can see here, this is time since onset from 6 to 16 days after the onset. And the next, how was the effect of the SARS-CoV-2 to the ovary? Yeah, even we know that S2 expressions has been identified in the primordial, primary, secondary, and follicle count, stroma, and corporal lutea of human ovary. And in addition, S2 expression is upregulated during the course of follicle development and further increase after gonadotropin stimulation and HCG administration. So that's why it should become a important note to us for doing controlled ovarian stimulation that may have several implications for the women. So that's why it's very important to avoid ovarian hyperstimulation during pandemic COVID-19, because it is very dangerous to have to increase the possibility to have SARS-CoV-2 infected oocyte or infected the ovary. The other thing, the use of technology is quite important to reach to increasing the healthcare access and quality of healthcare during pandemic. We know that the use of telemedicine and also the use of artificial intelligence, genomics, and also big data and robotics is becoming very challenging and promising, particularly during the pandemic COVID-19. This is one of the study showing us that the patients even can use sonography monitoring follicular growth in their house, and this is for in 100 attempts, only one patient missed her follicles. 9 hospital visits occurred for circumstantial reasons, and then 9 attempts were completed without any hospital visit between initiation and puncture. Mean number was for oocyte is 11, metaphase 2 oocyte 8.5, and fertilized oocyte is 5.5. And then they 5 blastocysts up to 2 embryos, and embryo replacement effort on approximately 1 embryos, and then frozen embryos about 1.3. And there is no significant difference the percentage of clinical and ongoing pregnancy if we compare with the patients with the conventional monitoring follicular growth. So that's why it is very important and very interesting how to empower patients to do their own monitoring follicular growth in their home. The use of the Sono-Aura system that consists of dedicated tablet connected to a vaginal probe using the USB technology. This is also we apply in our IVF clinics, the teleconsultations for infertile patients and also for the patients suffering from abnormal uterine bleedings. So the most important things in infertility and particularly in IVF that this is very high biological inefficiency, since we look only 5% of fresh oocyte produce a baby. So from the total of 570 egg retrieval that yielded about 7,200 oocytes, the total number of transfer and frozen embryo was 2,252 with utilization rate only about 31.2%. So that's why does reparative medicine require artificial intelligence? The quality of embryos is the most critical factor for the success of IVF. However, they still lack in the method of judging the quality of eggs, quality of sperms, and the quality of embryos accurately. So that's why embryo selection methods cannot be used only based on a single parameter or algorithm. That we should establish the algorithm, quite important to select which one is the best embryos, which one is the best sperm, which one is the best oocytes. This flowchart provides a brief overview of artificial intelligence workflow. Number one is very important, is collecting data. The data include electronic medical record, hospital data, and cloud data sharing. The second step is data pre-processing, and the third step is the selection of the appropriate models. And then the final step include the evaluation and validation of the models. The data is analyzed using AI methods such as machine learning and NLP. then the training data set is used to training the model. So AI will become better and better after the trainings. So the big data include electronic medical record and other data is quite important. So the mandatory, I think, should be applied in Indonesia, the use of electronic medical record in the hospital or in the healthcare services. EMR can capture data from various ways, and then the data is analyzed using AI, such as machine learning and NLP. And then AI has been used in the many aspects of reproductions, not only research and experiment, but also toward the clinical practice. Yeah, we can use AI in the sperm cells classifications, select the oocyte, embryo selection, use the clinical decision system support, and also can be used as an outcome predictions. This paper showing us the use of AI in reproductive medicine, particularly in selecting the best embryos. This is the decision tree model conducted to make prediction of the selection of embryos. The model first spreads cumulus cell sample upon AMH2 receptor expressions, high or low expression, and then upon leukemic inhibitory factor expressions, even high or low. And the next, the researchers obtained human semen samples from 8 healthy donors and acquired the quantitative phase maps on the sperm sample by using the diagrams of optimal system. And the last, the created NN model, artificial neural network model, to produce decision support system that can help to predict the semen parameters based on the data collected by the questionnaire and can support the traditional diagnosis. So this is the example how to use AI in the reproductive field. And this is also a very interesting paper published by the group from David Gardner from Australia, the use of deep learning as a predictive tool for fetal heart rate pregnancy following time-lapse incubation and blastocyst transfer. This is the deep learning model that was able to predict fetal heart pregnancy from time-lapse video with area under the curve about 93%. And if you look this one, artificial intelligence technique for embryo and oocyte classifications, the study improving the possibility of obtaining a reliable method to help physicians and biologists in selecting embryos or oocyte. How the use of AI and machine learning for human reproduction and embryology in the world. So if you look this one, the presentation in American Society of Reproductive Medicine and European Society of Human Reproductive Embryologists annual meeting in 2018, at least there is a 16 AI and machine learning approach were reported at this Congress. Nearly every aspect of patient care was investigated, including sperm morphology, identification of empty or oocyte containing follicles, predicting embryo cell stage, predicting blastocyst formation from oocyte, predicting blastocyst formation from oocyte, assessing human blastocyst quality, predicting live birth from blastocyst, improving embryo selection, and for developing optimal IVF stimulation protocol. This is, we can see how the AI and was used, published in the American Society of Reproductive Medicine annual meeting in 2018. This is the predicting blastocyst formation, assessing human blastocyst, application of AI, deep learning, and many more presented in the free paper or in the oral or in the poster presentations. This is one of our data in the Yasmin IVF clinic. We are trying to collect the data image from 1,226 IVF patients. And then all the image was processed, used the deep learning with a CNN convolutional neural network. And then we established the algorithm from deep learning that was trained by database from fast AI tools. And some articles were published by our groups. It was used the data image from embryos. We predict the models, AI model to predict the human blastocyst classifications. And also now ongoing study is model prediction in order to predict embryo chromosomal status of the embryos. And right now, so we are facing the increasing the patient's age. So if you look this one, the graying of infertile surfaces, the demand of infertile surface by older women continues to grow. We can see because achievable IVF outcome are widely underestimated. Most fertility centers do not offer maximal treatment option with use autologous oocyte. If you use this data in United States, increasing the patients with older age and also increasing the patients with the lower MH serum, it means increasing the patients with lower ovarian reserve. So we know that Poseidon criteria already classified our responder patients based on the ovarian reserve and also their age. So this one is a group 1 and group 2, these patients with the good ovarian reserve, however bad ovarian response. And group 3 and group 4, this is the patients with bad ovarian reserve with bad ovarian response. Of course, the prognostic is much better in Poseidon group 1 and group 2. So how we should do control ovarian stimulations in the patient in expected poor responder patients? Evidence support that ICOS is very important based on ovarian reserve testing, body mass index, and age to tailoring the exogenous gonadotropin use. One more oocyte are matters. If you look this graph, for example, if the patient between 35 to 37 years old, if they get only 2 oocytes, the predicted live birth is only about 12%. However, if they have 1 more oocyte, 3 oocytes, so the predictive live birth increasing up to 17.5%. So that's why the Poseidon criteria and its measure of success through the eyes of clinician and embryologist is very important. This group with low embryo aneuploidy risk, and then this group with high embryo with aneuploidy risk because of the age is more than 35 years old. So that's why it's very important how we can make a good approach in the expected poor responder patients, group 3 and group 4. We can see here the reason of this is the poor reserve with a good quality. This is poor reserve with poor quality. So that's why approach which might be different. The ICOS treatments, maybe we can use the high dose gonadotropin, considering there is a genetic polymorphism. In this the group 4, we are considered to do the double ovarian stimulation because of poor ovarian reserve. So the target is the same. We are trying to improve at least 1 more oocyte to improve the clinical pregnancy and also improve the live birth. The other things also very important and challenging is male factors. We know that from the evidence, 35% of infertility is caused by male factors. And not only the number, the mortality and the morphology, but also very important is DNA fragmentation index. Our study show in the cutoff point 26.1, with the area under the curve is about 80% to predict the male patient suffering from infertility. So that's why this the predictivity of the use of DNA fragmentation index even much better than conventional sperm analysis. So in the patients with high DNA fragmentation index, it's very important our effort to choose to select which one is the best sperm by using high magnification up to 6,000 or even 7,000 higher. So we call it, this one is intracytoplasmic morphologically selected sperm injection. We do the people did in order to improving the sperm selection, so improving the oocyte, the embryo quality, and improving the clinical pregnancy and the live birth. So that's why right now we are facing the high inefficiency of the assisted reproductive technology. So that's why very important for us developing biomarker for select which one is the best oocyte, to select the best sperm, to select the best embryos, and also to determine which one is endometrium most receptive, so we can confidence to replace the embryos. So the life cycle approach of innovations in preventing primary prevention of infertility is also quite important. The use of biomarkers, we can put the biomarker in the primary prevention approach to prevent the subfertility or prevent the patient to suffering from infertility, and then we can use this primary prevention even in the primary care or in the level 1 of the health fertility services. So the other things very important is cutting edge of the technology in reproductive medicines. Now people trying to establish mitochondrial transfer to solve the problem in ovarian aging. People trying to establish gene editing to solve the problem, the aneuploidy or single gene disease by PGTA, and many more people even trying to establish the artificial ovary to help the patient suffering from primary ovarian insufficiency, and others such as the stem cells also very, very important to solving the problems in our fertility patients. So the last, as a take-home message, number 1, COVID-19 pandemic. We are noticed that COVID-19 pandemic increasing stress among infertile couples. So therefore, infertility clinics should keep an access with strictly mitigation of disease prevention. Number 2, the technology will enhance both of access and quality of infertility services during and the post-pandemic era. Number 3, data collection, processing, and modeling is very crucial to establish artificial intelligence in healthcare, and the sperm is the greatest contributing factor to infertility. Therefore, paradigm was changed. High biological inefficiency of ART should be addressed by biomarkers development in precision reproductive medicine, and the last, development of selection method of gamete and embryo can be supported by using artificial intelligence. I think this is my presentation. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you for your beautiful insights about the fertility challenges from what happened during the pandemic era until what we can develop later on. Professor Budi Wiweko, I have some questions from you, from the audience and myself. So as we know that at the beginning of the pandemic, when WHO statement stated about the pandemic of COVID-19, ASRE and ASRAM at that time recommended to postpone the fertility treatment. In fact, without this recommendation, as we know that infertility is already a big challenge. So linking this statement from ASRAM and ASRE with your presentation, what do you think as the consequences that probably we face following the pandemic? Because there are so many changes. So sometimes we have people try to postpone the treatment. So we have to deal with this kind of condition. So is there any impact following the pandemic in terms of the treatment and how to diagnose the patient, infertility patient? Thank you.
Yes, yeah. Thank you very much, Dr. Mila. I think this is a very interesting and also very tough questions. Number 1, of course, the pandemic disrupting anything. Number 1, we should realize that because of pandemic, the technology, the use of technology are accelerated, including the use of telemedicine. So before that, we cannot imagine that our patients can use ultrasound by themselves in the home for doing the follicular monitoring. So right now, because of pandemic, they can do that. And then number 2 is very important that in the pandemics, we don't know actually what is the effect of SARS-CoV-2 toward the gamete and also toward the embryo. So that's why I think this is the big task for the IVF clinician or fertility specialists to explore, to do the further investigations whether any negative effect of SARS-CoV-2 toward oocyte, toward the sperm, and also toward embryo in the pregnancy. I think this is the second question that we should answer. And the last, of course, because of pandemic, there is an increasing of the stress of our patients that because of they cannot go to the clinics because they are afraid. And the postpone or the cancellations of the patient to go to the clinic, even sometimes make a deteriorations, for example, particularly in the patients with the limited ovarian reserves, for the patients with advanced maternal age, for the patients with the severe malfactors. So that's why I think the pandemic now changing everything, Dr. Mila. So many answer that still we need many questions that still we cannot answer.
Okay. Prof. Budi, it was very interesting, your statement about and your presentation about the ultrasound sonography by the patient at home. So do you think this method is applicable in our country? What might be the constraints when we try to apply this with our patients?
Yes. Number one is the very important is the role of professional organizations. I mean, Indonesian Medical Association, IMA, or even we have an Indonesian Association for IVF, I think should be endorsed this kind of innovation in follicular monitoring, follicular monitoring by the patient in their home. It should be endorsed by professional organizations. And number two, of course, it's very important for us educate the patients, empower our patient, which is not so easy. However, this is our task to empower our patients. And the last also to empower ourselves. So not many clinicians, not many fertility specialists, it's very open toward the latest technology, toward the use of technology that actually we should adopt and we should adapt the technology to improving the quality of health services. And the last also about the ethics. It's very important. We should comply to the ethics that already should be followed in Indonesia.
Yes, thank you, Professor Budi. So I'm actually intrigued with your statement in your presentation stated that as we know that ACE2 receptors also present in the follicles. So in that case, we have to be careful when we try to stimulate the patient during the pandemic. So with regard to this statement, I would like to ask you, so in that case, sometimes we have to postpone the treatment or the fertility treatment. So regarding the age, if the patients then end up with postponing the fertility treatment, do you think it will have an impact in the ovarian reserve and the oocyte quality? If not, then how long do you think that the patient can delay the treatment without impact on their ovarian reserve?
Yes, Dr. Mila, I think it's very tricky questions. Yes, of course, we should realize that the ACE2 receptor was there in the ovary. So that's why if we did the control ovarian stimulation, please to avoid ovarian hyperstimulation syndrome, use appropriate or optimal dosage of recombinant FSH. And then I think we can use, of course, the antagonist protocols, or we can do the trigger by using agonist GnRH, and please do freeze-all protocol. I remember during the May until April last year, almost in all of the world apply freeze-all protocol, whatever the patients. And then number two, of course, it's very important that we should do prioritization of the patients. This advanced maternal age, let's say the patients with the 41 years old or the patient with very low AMH, less than 0.5 nanogram per ml, I think we should put this patient in priority list. They can go to our clinics, and then we do the counseling, good counseling. We do the stimulation and then freeze the egg or freeze the embryos. I think this is the very important that we should take care of our patients based on the real data anyway.
Okay, thank you very much for your answer. I think we have one question from Dr. Anurag Shankar. So he's already in the Zoom. So in addition to the highly innovative fertility treatments, is there a complementary social role for child adoption for couples who would like to have children?
Yes. I think this is one of the alternative, one of the choices if we are facing our infertile couple in Indonesia, that somehow in the appropriate time we should offering to adoption, the children adoption, for example, in the patients with suffering from primary ovarian insufficiency or premature menopause, that we cannot do anything. I think it is appropriate for us in Indonesia to offering the couple to children adoptions. Since in Indonesia we did not allow to do egg donation, did not allow to have a sperm donation, and not allowed to have a surrogacy. This is thank you, Anu, for your great question.
Thank you for your for the great discussion, Professor Budi Wiweko. I think this is the end of our session today. I would like to thank Professor Budi Wiweko and all the audience for being with us for this session, and also Merck Serono for the to sponsor this session. Thank you very much. It's over to you, Dr. Amalia Sadrina.
Ladies and gentlemen, now we will listen to Concurrent Session 17, Tackling Infectious Disease Challenges in Indonesia through Research of Impact, Universitas Indonesia and Oxford collaboration. This session will be moderated by Professor Dr. Arif Fahri-Alsham, Internal Medicine Specialist, Gastroenterology, Hepatology Consultant, and Fellows of the Indonesian Society of Internal Medicine. Professor Dr. Arif Fahri-Alsham finished his Internal Medicine Specialist at Universitas Indonesia in 2000 and continued in 2005 being consultant for Gastroenterology Hepatology at Universitas Indonesia. Then gained his doctoral degree at Universitas Indonesia in 2011. Now, as we all already know, Professor Dr. Ari is active as Dean of Faculty of Medicine, Universitas Indonesia. To Professor Dr. Ari Fahrial, the time is yours.
Okay, thank you. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, ladies and gentlemen. So thank you. So you are stay here. I gladly welcome to our concurrent sessions. That the Master of Ceremony mentioned, I am Arif Fahri-Alsham, so I will moderate to 3 speakers this afternoon. The session will bring up the main topic of tackling infectious disease challenges in Indonesia through research of impact, UI Oxford collaborations. We know that we have long collaborations with Oxford, University of Indonesia, and to further discuss this topic, we have with us today the 3 speakers that will present 3 different topics. Our first speaker is Dr. Anurag Sankar. He is a lead researcher in Ekman Oxford Clinical Research Unit, Jakarta, and also a research fellow at Nuffield Department of Medicine, University of Oxford. His work spanned from biomedicine to global health policy, with unifying a theme of regulation and resilience of complex system of biologic behavior and pragmatic level. Today, he will bring up the topics that are driven approaches to strengthening community health. Without further ado, here is our first speaker, Dr. Anurag Sankar. Please, Dr. Anurag, time is yours.
Okay. Thank you so much, Inari. Just sharing my slides here. Great. Hope you can see that.
Yes.
Okay, fantastic. Yeah, thank you so much. It's really great to be here, and thank you to the committee for the invitation, and thank you, Dinari, very nice introduction. So I first want to open by introducing this idea of precision public health. As we know from precision health, and some of the previous presenters at this conference have talked about that, but precision public health specifically is this emerging idea really for focusing on disease prevention, treatment, promotion of thriving and resilient individuals and communities by taking into account population-based characteristics, in addition to individual variability in genes, environment, and lifestyle, and taking into account provider variability in skills. So by doing this, the idea is you can much more carefully target from a public health standpoint the types of interventions that are likely to be effective at the population level. So as a starting point for this, I just want to talk about our story from this work that we had done very early on here in Indonesia, many, many years ago, this large-scale randomized controlled trial, multiple micronutrient supplementation in Eastern Indonesia, where we had enrolled around 31,000 pregnant women, and showed that multiple micronutrients in pregnancy actually reduce the death in children by around 18%, around 38% reduction in death if the mom was anemic and she got a multiple micronutrient supplement. So that was very interesting and important from a policy standpoint. But there was something else in that work that was extremely interesting, in fact, that relates to this issue of community health. So what we observed in the study was, in fact, high-performing frontline health workers who were promoting antenatal care, promoting general services, health services. They themselves had a big impact on the community. So we could see that, in fact, if a good quality health worker, frontline worker, whether it was a community health worker, a bidan or a skilled birth attendant, if they were good, you could see that they had a substantial impact, reduction of mortality in their community about 30%. And in fact, this correlated very well with the use of skilled birth attendant at delivery or consumption of the multiple micronutrient supplement. So we had a double-blind randomized trial within the process of enhancing community health services. And both of those interventions, the multiple micronutrient supplement and the promotion of community health, had a substantial impact, amazingly. So, and in fact, the community health workers had a bigger impact, right? So I think that's extremely important. So the question is, how do you find these and nurture these high impact community health workers? How do you enable them to do good quality promotion, information sharing, and promotion of participation in the community? So the route towards finding and growing these superheroes on the front lines essentially is use of information, this data-driven cycles of selection and coaching from really the standpoint of recruitment onward, in fact, right? So there's all these data-driven cycles of recruitment, of training, making sure salary conditions are good, supervision and coaching, and retraining and so forth. All of these are extremely important, in fact, and are core part of enabling programs to improve health, disease treatments, and reduce mortality overall. So in order to handle this sort of thing at scale, use of digital health platforms is extremely helpful. So when we began exploring this work in 2014, we realized there really was not an open source digital health platform for frontline health workers. So we launched an initiative to develop this sort of open source tool. We put together a team of developers from Indonesia, from Pakistan, Bangladesh, and Kenya. And over the course of several years, we're able to create and launch this tool called the Open Smart Register platform. And this ended up being underwritten by the World Health Organization and is now actually deployed in around 17 countries in the world, including Indonesia. And it's really a scalable information and intervention platform for integrated care that we say the frontline workers deserve and that clients need. And also clients deserve and frontline health workers also need that. So you can look at this more carefully at smartregister.org. You get more information about that. You can download the code from there. Teams can start to change it the way they want it for their own use case and so forth. So when we deploy this, in fact, on the front lines, this is an example with antenatal care, we see a improvement in the delivery of care. Basically, for antenatal care, at least, you see the improvement of the quality of care, the homogeneity of care, very interesting, very quick response from that, from using the tools. So then we thought, if we want to do comprehensive management of health on the front lines, what we really need is a set of apps with all the frontline health workers who can focus on integrated care with infectious disease, diagnostics, treatment, rapid detection and treatment, nutrition, and early childhood development as an integrated package. So the goal was to develop these multiple different apps for the frontline health staff using their existing paper forms, but making them digital and enabling them to exchange data, which meant that this was an interoperable system, enabling coordinated teams of frontline health workers. So when we deployed this, what you could see is really on the left here is the impact of an app deployed with a single worker, as a skilled birth attendant providing antenatal care. And we certainly see improvements in antenatal care, like I showed you before, reductions in a low birth weight, which is great to see, reductions in anemia because, compliance was better, but we don't see really any change in postnatal care or vaccinations, even for maternal vaccination. Interestingly enough, when you deploy these apps with teams of frontline health workers, now you see the movement, a continual movement in ANC and even further improvement in postnatal care. So it's amazing. You can see that these teams of workers are actually helping each other to succeed. And I think this is a big key, new innovation really in community healthcare that's very critical for infectious diseases. And of course, now you see vaccination levels also going up. This is sort of a deeper dive on some of that information, increased rates of vaccination, and a mortality reduction as well. So the goal here is really creating coordinated and networked care. So the whole system overall is more than the sum of its parts, starting from pregnancy onward, the first 2 years of life, focusing on both nutrition care, infectious disease detection, diagnosis, and treatment and follow-up if treatments are in fact successful. So I think that you can follow this with these series of apps, essentially, different frontline workers, whether it's a community health worker, nutritionist, a cadre, early childhood development worker. Through this data interoperability, they're able to create a one data system enabling this integrated care. So precision public health, which I mentioned at the beginning, this system that I described, this really enables a system, community health system, to be client-centered. Currently in most countries, including Indonesia, actually care is provider-centered, which means that the client needs to go to these different providers. But with this team-based care that's integrated, in fact, it changes that. It modifies it into a system, transforms it into a system that is in fact client-centered, which is really the goal to create much better quality care. And of course, precision public health is integrated, as I mentioned. So in this case, if the starting point is the pregnant woman, you want to prevent infection, for instance, COVID-19, other infections in pregnancy, following up of the child, dealing with infectious disease from very early on, the first year of life, as we all know, the child is very vulnerable to many different infections. So this integrated care ends up being extremely important. So in fact, the World Health Organization has decided that integrated care, digital care, precision public health is so important that they've now created a framework, these WHO SMART guidelines, with the first use case, in fact, being antenatal care. They have focused on every WHO recommendation needing to have a digital care plan associated with that. And this links directly with the community health initiative as well. So they have these key levels, and I would refer to all of those who are interested very strongly to this antenatal care ANC adaptation toolkit. It's the first use case that WHO is coming out with. They're now porting this on to other use cases related to infectious diseases also. So we were able to use this here in Indonesia, work closely with World Health Organization to build really this first digital tool to support all aspects of antenatal care, including those elements related to infectious diseases, and to deploy this actually in 3 countries so far, and including Indonesia. And there's other things you can integrate with this now, if this is the case. So how do we further enhance digital technologies to create even more integration with this? So one of the things is we've realized we can actually help to track all interventions, whether it's vaccines, whether it's antibiotic treatment, whether it's nutritional supplements, by essentially placing a barcode on that product. Many products already have these, but we work with this company, Zebra, who actually is the largest producer of barcode technology and temperature sensors in the world, in fact. And we work with them to invent or create actually a special sticker that can be placed on any product. We can define what the temperature sensitivity should actually be, whether you want it to be 30 degrees or 40 degrees. And now these barcodes are not only embed a lot of information, but they're smart barcodes, enabling you to know whether or not a product has been degraded by excessive exposures to temperature, whether it's a counterfeit product or not, lots of different aspects to that. And in fact, you can further integrate this in with the app to track the product itself as it's handed out. Again, this is using the example of multiple micronutrients, but likewise, this could be for any pills you're prescribing, antibiotics, vaccinations, and so forth. So it enables you to actually track these things much more carefully. Now, let me turn our attention to digital health also in this context for RDTs, rapid diagnostic tests, for the case for infectious diseases specifically. So, as we know, RDTs really emerged, I would say, 40 years ago, maybe around 40 years ago. And there was a lot of excitement, in these. And they sort of have fulfilled their promise to some extent. But the big gap in RDTs has been, in fact, the information from them for diagnosis of all these different infectious diseases has not actually been optimized. The utilization index of information has never really been optimized. So we really sought to come up with some tools for community health and digital health about how to do that. So we received some funding from Gates Foundation to, in fact, create what we called open guideline RDTs. And the goal behind this actually was to create a standard, information standard and manufacturing standard that producers of RDTs could use to enable their RDTs to be more easily assessed on an app and to capture the critical information from them. So what does that look like, in fact? So here's a prototype, two sort of prototype open guideline RDTs. You can see they have an individualized barcode, an individual ID number for each device. Each individual device has its own ID code on it. And this particular one has a temperature sensor on it as well. It might have a color barcode here, enabling the camera really to detect what is the darkness of the line that is observed there. And this barcode actually includes information telling an app that can read this RDT, telling that app how to configure itself to read this specific RDT. So now one app can read any RDT. And through these open guidelines, it really enables now a diagnostic device, an RDT, to be turned into a public health device. And I'll show you really how that works. So here's an example, of course, this RDT can be read with an app. You can detect whether it's positive or not. You can detect much more successfully if an RDT is expired or degraded in some way. Here we show that frontline health workers using the app and these open guideline RDTs were able to detect 98% of actually expired RDTs, whereas just regular health workers going out and using RDTs, they detected very few, in fact, of these expired RDTs, and we're using those routinely for service. This information now that gets collected and captured by the app can now be used for combining with other key information from the health information system, symptom data, other data, and so forth to get further inference. So it becomes much more interesting. And you can get population-based inference, real-time epidemiological information. So now one person's data contributes to diagnosis and help for information for everybody else. And that's the bridge really between a diagnostic device and a public health device. And again, focusing on precision public health. So these are just some examples of work we did both in Indonesia and Kenya, real-time tracking of who's positive for what. We had two sorts of prototypes for these RDTs. One was for malaria, another one was for COVID-19 antibody, another one was for COVID-19 antigen. But you can see here, immediate real-time tracking is very useful. We're also able to integrate the symptoms together with the result from the RDT. And in this way, we can actually increase the area under the ROC curve. Here's just the RDT alone on the left. On the right, if we're able to use the open guideline RDT, integrate other symptom data and so forth, our performance of the RDT for case detection is much higher, in fact. And in fact, we applied the same thing with colleagues Dr. Rina Agustina and Dean Ari, who was a great collaborator on this as well. Applied this to information on RDTs collected from Jakarta during the pandemic, and we're able to show that, in fact, use of this integrated information, again, increased the utility of antibody RDTs, really increasing their use during the COVID pandemic as a surveillance tool, not diagnostic tool specifically, but as a surveillance tool. So again, the value of this from a public health infectious disease standpoint. So last, I want to bring up this issue related to public health genomics and precision public health. We've often thought about genomics as being an individual, type of activity, but in fact, again, it has implications at the population level. And how would that work, for example? So let me just sort of walk you through something from a public health standpoint. So let's say, again, from the nutrition standpoint, we know there's genetic polymorphism existing for multiple nutrients, metabolites, for also infectious disease response genes, interferons. We've seen for COVID-19, for instance, at least 15 genes identified which might affect outcomes. So one thing that becomes interesting is let's say the entry point with respect to, for example, is ongoing at that point. Now you can actually create the whole antenatal care experience. So every woman receives a benefit based on her genetic profile in terms of how that changes her care. And the care prescription for her changes in real time as managed through the apps, right? So now you're detecting this information in the lab, her genetic heterogeneity, what the population-based genetic heterogeneity is in that area. You're able to come up with specific personal guidelines and population-based guidelines for that general area overall, that general geographic area, or a certain age of patients, or a certain group of patients going to a specific health clinic, for example. And this enables you to provide much more detailed services for preventive and promotive care. So bringing it all together, there's this concept we refer to the adaptive network for care at scale, which really is this coordinated data-driven maternal, newborn, and child care programs to reduce mortality, reduce infection, reduce stunting, and so forth.
Sorry, Dr. Anu, 3 minutes.
Okay, great.
More, please.
Thank you so much. Yeah. And so we're able to create these coordinated teams of frontline workers, create real-time data sharing, promote interoperability through this global standard of HL7 FHIR, and integrate in with that actually genomics and infectious disease diagnostics, and leading to really our conclusions that precision public health can be a reality today. In fact, digital innovations are keys to this, really boosting this impact for infectious disease diagnosis, treatment, and prevention at the community, and to transform community health into a new era, really, that's client-centered, coordinated teams of workers, all information, smart diagnostics, one for all and all for one, data interoperability, and we can get rapid impact. So let's do that as soon as possible together. Thank you so much. Thank you, Binari.
Okay, thank you, Dr. Anurag. Yes, I think Dr. Anurag have mentioned about the building a digital tool, public health genomic, and also transforming rapid diagnostic tests. It is an informative presentation. So now let's move on to our second speakers. Dr. Mutiara Harjani, Master of Science, will talk about, Dr. Mutia is a clinical research operation manager at Ekman Oxford Clinical Research Unit. Her involvement in local and also global development, operational management, and also quality of oversight for studies in oncology, autoimmune, hepatology, and also nephrology. Today, she will bring up the topic Indonesian Oxford Clinical Research Laboratory harnessing high-quality clinical trial to improve patient outcome. You know that actually we have laboratory working together between University of Indonesia and Oxford. Okay, without further ado, here is our second speaker, Dr. Mutia. Time is yours, Dr. Mutia.
Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, and thank you for the opportunity to share our work at IOPRO. Since 2017, University of Indonesia and Oxford have conducted numerous clinical research in the area of infectious diseases with the vision to improve patients' outcome both in Indonesia and globally. In this session, I would like to focus on how us at IOPRO aspire to continuously improve the quality of clinical research through capability building in clinical operations and collaborations. Let me share my screen. First of all, clinical research is conducted not only to produce scientific publication. We have to envision clinical research to be able to deliver a long-term outcome, to inform health policy and clinical practice, which ultimately improve patients' outcome. To achieve that, it has to go together with capability development and also collaboration and partnership. Unfortunately, most research failed to make an impact and ended up wasting resources. This chart here shows that many of these causes are preventable through good planning and execution. And in the next slide, I'm going to show the illustration on how even well-designed research can fail to make an impact. There are so many moving parts in clinical research conduct that can go wrong. The issues shown here are very common and almost always recurring in any study. They result in low quality data due to inaccuracy, incompleteness, and invalidity. And again, this highlights the importance of good planning and execution. In order to make an impact, we have to start with a well-designed, well-conducted clinical research. As we can see here in this diagram, well-conducted randomized clinical trials and series of observational studies provides the breadth of information and highest level of interpretation to inform policy and clinical practice. And that brings us to the definition of high-quality clinical research. There are several aspects to this: the design, the conduct, and the overall data integrity and analysis. And all of these anchored on the principle of preservation of subjects' rights, safety, and welfare in compliance with applicable relevant regulatory requirements. And in this session, we're going to focus on the conduct of the clinical research itself. But first, we have to acknowledge that there are challenges in conducting academic clinical research. Academic clinical research rarely has the advantage of abundant resources and capability. I highlighted here in the slide the most common challenges, which includes the lack of awareness about the changing regulations, and then the skill of budgeting and planning, oversight, and reporting, and also GCP and pharmacovigilance related capabilities. Clinical research is heavily regulated, as we all know, and there is a really good reason why. We have to first and foremost protect the participants. Balancing meeting the compliance requirement and not overspending resources is not an easy feat. Oversight requires more people with specific skills, which takes time and also money, which often is not a privilege of an academic research. And unfortunately, this is a fact. In Europe, about 90% academic research failed to be reported within 1 year of completion in 2017. This is due to poor results in compliance, incomplete research, and other contributing factors. it will be interesting to know how this figure is for research in Indonesia. Clinical research involves not only the researcher and the participant, but also multiple stakeholders. It also involves myriads of operational aspects and individual tasks that need to be managed effectively. Over time, the clinical research complexity also increases. This pyramid figure was taken from an oncology paper almost a decade ago, classifying the complexity of research implementation into 8 levels. However, this figure has not yet taken complex design, such as an adaptive trial, into account, as it was not yet common then. Recently, more adaptive trials are being conducted due to shorter timeline and resource efficient, while producing faster, comparably reliable results. And in addition to that, the COVID-19 pandemic has made things more complicated by disrupting a routine clinical research activities, thus requiring a more agile and adaptive approach. And this is where the clinical trial unit comes in. The role of clinical trial unit, or CTU, encompasses a broad range of clinical trial implementation activities, from planning, startup, until closeout and publication. CTU focuses on supporting patient safety, protocol compliance, data quality, efficient study completion, data sharing, and timely publication and dissemination of results while meeting regulatory requirements, so that the clinical research is of high quality. And since 2017, Yoku and ICO has conducted a clinical research in TB, HIV, brain infection, malaria, infectious disease burden, antimicrobial resistance, and currently, COVID-19 makes the most of our portfolio starting from the earliest phase of the pandemic in 2020. In the last 2 years, the clinical research activity doubled in number due to COVID-19. The pandemic also put a hold on non-COVID trials, but these and new studies recently resumed as the situation improved. Within the last 5 years, these clinical research projects have enrolled more than 5,000 participants and are still growing. And we conducted this at 20 hospitals and 10 puskesmas in 10 provinces. We also involved 2 army battalions in East Java, which will soon be joined by 2 others in Sumatra for malaria studies. We involve also various regional health offices, or DINCAS, in our activities. Through this clinical research, we also support the development of the site study team capability and aim to also improve clinical practice in the long run. And now I'd like to share 3 main COVID research conducted by IOCO, and these are recovery, INACO, and also COPCOM. Recovery is one of the most prominent COVID-19 treatment research. Indonesia joined the study in February 2021, and since April 2020, this study continues to provide treatment recommendations adapted to clinical practice worldwide. Further detail about this study will be shared in the next session. Secondly, INACO is an observational study to characterize clinical immunological and also a response to treatment of hospitalized patients in Indonesia. This study is also part of ISARIC global initiatives. We have enrolled 476 participants from 5 sites, and the analysis is currently ongoing for the first report. Lastly, COPCOM trial is a double-blind randomized clinical trial aimed to determine the efficacy of chloroquine or hydroxychloroquine as chemoprophylaxis to prevent symptomatic COVID-19. Despite the challenges related to chloroquine safety concerns and also increasing rates of vaccination, we managed to recruit 782 participants from 5 sites in Indonesia to date. The clinical trial unit is pivotal to ensure that these projects are being carried out effectively and in a compliant manner. Our team at IOCRO consists of over 65% experienced personnel with various backgrounds from academia, industry, and also CROs. The team also have various capabilities critical to each phase of clinical research. We also put an emphasis to personal development through academic and also professional training. As we can see in this diagram, CTU significantly contributes to each step of clinical research, although the majority of the activities conducted by CTU are during the setup and conduct stage. Its contribution actually starts from providing operational input to the protocol development and budgeting during the planning phase, up until the reporting and also publication. The organizational structure of the CTU at IOCRO is based on these roles and capabilities. In early 2020, new roles were added to ensure both people and also expertise can be developed in a more optimal manner. This includes project management, clinical trial monitoring, data and study drug management, and also pharmacovigilance. We base our development strategy on this chart here, covering 8 main competencies of clinical research professionals. As COVID-19 research opens IOCRO to new collaborators, both well and less experienced, we have the opportunity to not only develop these competencies in our personnel, but also at sites. We hope that the study team gain experience and expertise through the collaboration with IOCRO, which leads to more possibilities of future research. Moving forward, we aim to establish 4 new capabilities at IOCRO: project management, quality and monitoring, data management, and also pharmacovigilance. We have started by recruiting qualified people, developing training and development strategies, and establishing procedures and systems. So going back to the first slide of this presentation, IOCRO Clinical Trial Unit is strengthening our role in supporting the conduct of high quality clinical research through scientific mentoring and navigation throughout the complex world of clinical research, supervision, and also mentoring of research staff, both in our unit and also at study site, providing the operational input to the protocol development and also regulatory support, coordinating all stakeholders and aspects of clinical research and also data management, and continuously looking for innovative ways to improve processes. We are determined to improve the quality of clinical research conducted in Indonesia so that in the long term, we will be able to make an impact by providing input into health policies and clinical practices, and finally improve patients' outcome. That was all of my presentation, and thank you for your kind attention.
Yes. Okay, thank you. Yeah. I think for your insightful presentations. You mentioned about the challenges in conducting academic clinical research and also how to build the clinical trial unit, and also I would like to introduce our third speakers, Professor Ralph Hammers, MD, PhD. He is an associate professor at University of Oxford, based on Ekman Oxford Clinical Research Unit in Jakarta, and also in internal medicine, doctors with infectious disease consultant, trained in the Netherlands. He also initiated the clinical infection disease research program with focus on tuberculosis, antimicrobial drug resistance, emerging infectious disease, diagnostic and also multidisciplinary approach to improve health outcome in low resources setting. In today's session, he will present the topic of leveraging clinical network in Indonesia to improve patient outcome, COVID-19 and beyond. Without further ado, here our last speakers, Professor Rob Hammer. Please, time is yours, Professor Hammers.
Thank you very much, Dean Ari. Let me share my slides. So I'm very honored to be invited and to be speaking today, also after the two previous speakers. My talk is supposed to be complimentary. A lot of has already been said by Anu and Mutya, and I would like to give a little bit of a higher level view about priorities and strategies in the research that we would like to do in Indonesia, but also, of course, that we encourage our local partners to be doing. A lot of us has already. So first, I would like to start off with a little bit of background of the University of Oxford's presence in Indonesia and the partnerships that this university has been having with local institutions. So this has been a long history, starting formally in 2008 with a partnership between Oxford and the Eijkman Institute, and that was at that time driven by another outbreak that was the bird flu. And the first collaboration was about a clinical trial to treat bird flu. And that was actually the start of this collaboration where the Eijkman Oxford Clinical Research Unit was established as part of the Eijkman Institute, led by Professor Kevin Beard. And only a few years later, another partnership was started with the next neighbor University of Indonesia, the Faculty of Medicine, in 2012. So this MOU that was established back then expressed the interest to do collaborative research in infectious diseases. That partnership was successful with initial focus on malaria, and there was soon a need to expand, and that led to the establishment of a physical facility on the premises on Salamba campus of the Faculty of Medicine called Universities of Indonesia and Oxford Clinical Research Laboratory. And I will say a little bit more about this facility in a bit. So there's this, the reason University of Oxford has an interest to do the work that we do in partnership with local institutions is because of a shared vision, a vision of conducting excellent biomedical research that has an impact to the health of Indonesians, Asians, and humanity. And the focus of our work, as Mutya has expressed in much detail, is indeed on clinical trials. However, we do not operate as a single entity. We are part of a larger network. Oxford University has a very long tradition of supporting tropical medicine research across the world and has always had quite a strong presence in this region. So this map shows that there are partnerships in place between local institutions and Oxford University in Nepal, Vietnam, and Jakarta. On the ground, this means that Oxford University typically has a connection with either a local hospital or a local university or research institutions, and scientists and technical staff work together with these local scientists. Now, this Asian network is part of what we call the Oxford Tropical Network, and as you see at the bottom of the slide, this is a global network of groups with specific expertise connected to overseas units in Africa and Asia. So in orange, it says OCRU, and that is the part that we're in. So it's Indonesia, Nepal, and Vietnam forming one program. In green, there's a program that is actually centered around Kenya and Uganda. And at the bottom, there's a program that is centered around Thailand and neighboring countries. So this is a long tradition. If we look at the structure of the unit, the leadership exists actually of the director of OCRU, who is in Vietnam, that is Professor Guy Thwaites. And that leadership is shared with two local leaders in Indonesia representing the two hosts of EOCRU and IOCRL. There's Professor Amin from the Eijkman Institute, who recently stepped down, and Professor Dean Ari, being the Dean of the Faculty of Medicine. Our research is divided in 4 programs that are thematic, but there's a lot of cross-cutting activity and collaboration, which is clinical infectious diseases, malaria, community health, and geospatial epidemiology. You've just heard Anuraj speak about community health. On the operations sides, our leaders are Rizky, who is our operations manager, Agus, our finance manager, and Mutya, who just spoke about the clinical trial operations. So what is the Universities of Indonesia and Oxford Clinical Research Laboratory? So this was jointly established between the Faculty of Medicine and Oxford in 2018 with an aim of further strengthening and expanding clinical research in infectious diseases. So it actually consists of a suite of offices for technical staff and scientists, a meeting space, And very importantly, there are secure storage facilities for study drugs and for documents. And these fulfill requirements from GCP and other frameworks. So this is important to have in place to be able to conduct clinical trials. There's also a laboratory that also is important in the conduct of these same clinical trials. We are located with FKOE Department of Parasitology, and I will show you some pictures on the next slide. So in this unit, we have the core technical people and equipment that are dedicated to the conduct of pivotal clinical trials. So GCP compliant, a clinical trial support unit that Mutya leads. There is secure drug storage and archiving, a bioarchive with freezer capacity and power backup, and there's laboratory capacity. However, I think what is even more important than these building blocks is that we try to create this nurturing and stimulating research environment where we try to include young scientists and young technical staff and teach them and train them on the job to do high quality research. So it is a hub for training, education, and also for public and community engagement, where we try to enrich our science by engaging with communities. So here are some pictures just to give you an idea where this is all pre-COVID, by the way. That's why there are no mouth masks. But this just shows a flavor of where people meet each other. The laboratory, which was at that time quite empty, but it's now very much occupied. And also you see at the bottom in the right corner, lower corner, you see from above, from the IMERI building, you look down at the parasitology building, and that's where we are. So the focus of the research is on clinical infectious diseases, and our overarching aim is to evaluate biomedical and behavioral interventions that can result in better patient outcomes in Indonesia, and also have global relevance. So the focus is on the management of complex infectious diseases with high public health impacts such as malaria, tuberculosis, HIV, COVID-19, drug-resistant infections. And we dedicate ourselves to designing and implementing integrated complex interventions that lead to improved care delivery, the use of treatment, or, for example, mitigate drug-resistant infections. In doing so, we also try to strengthen local capacities, not only in our unit, but also with our partners. As Mutya has also explained, a trial is not conducted from the CTU itself. It is conducted in close collaboration with site teams and with a whole range of disciplines. So our job is, we see it as building these local collaborations that are crucial to the success of our work, and also build international collaborations. So we connect Indonesian institutions and scientists to international researchers as well as local research. So what happened during the COVID-19 pandemic was actually, of course, a very bad thing in many ways, but it has also brought us as a unit a lot of good things, because it has enabled us to accelerate and strengthen our collaborations and our activities with many academic partners and hospitals across Indonesia to deliver large-scale trials of high quality and impact. By working from this hub with experienced people in the team, some members are shown here in the pictures, but definitely not all of them, it has greatly facilitated speedy setup of the sites, the selection of the sites, setting up studies, and doing good governance of studies. Our aim is, in doing this, is to promote the national ownership and increase the relevance of study findings for the Indonesian people. So we have been trying to select and implement projects that have high relevance for the local situation. So this was the slide that Mutya already showed of our portfolio to date. And I just wanted to add to this the group of principal investigators from the Faculty of Medicine, to which we are very grateful for their involvement. And they have been really great in supporting all of this work. So they have been leading with us the implementation of all these projects. And these are experts from several departments. I will not go through all the names, but they represent the Department of Neurology, Internal Medicine and Infectious Diseases, Pulmonology, Parasitology, Microbiology, and Community Health. So it's a very broad range of disciplines that we are happy to collaborate with, and they may really make the difference in making sure our research has the right impact, and that we can actually deliver the work that we try to do. Then I would like to move, as Mutya announced, to one trial that we were involved in, which is a recovery trial, the randomized evaluation of COVID-19 therapy. And as Mutya said already, this has been the most prominent and most important trial to date, finding answers to what are effective new therapies to treat COVID-19. And I think the very famous example is the discovery that dexamethasone led to improved survival in people hospitalized with COVID. So it's the largest global trial to date. It's a platform trial, phase 3, which means that this trial is not static. It is a very dynamic trial. Treatment arms are added all the time and also completed. So arms are leaving the trial when they are completed, and new arms are added to the trial to evaluate new drugs. And you can see here in these 9 squares all the drugs that have already been evaluated. Now, this has led to practice-changing evidence about treatment effectiveness for dexamethasone, Regeneron, monoclonal antibodies, and tocilizumab. Funding comes from the UK, and at the bottom you see the 2 chief investigators from the UK, Professor Peter Horby and Martin Landry, who have been the initiators and the driving forces behind this trial. Now, there was soon a realization in the UK that this trial needed to expand it internationally. So there's a need to include a diversity of populations and settings because the pandemic is rife in many places, not just the UK. And the treatments that are being discovered need to be effective and applicable and feasible across all populations and settings. So there was they soon reached out to Indonesia and Nepal as the first countries to, through our units, to be joining this trial. And to date, you see here the list of countries that is part of this trial. The UK, that's where it's all started, then followed by Nepal and Indonesia and Vietnam. And there is another 5 countries, Ghana, South Africa, India, Pakistan, Thailand, preparing to join the trial soon. So the Indonesia experience is the following, and it just summarizes this in one slide. You can see here Dr. Ernie Nellen being the country PI for recovery in Indonesia. The target is to recruit 2,000 COVID patients in a period of 2 years. And the current status is that we have recruited 202. So that's about 10% of the target. And of course, currently because of the fact that the cases have gone down, we are currently very slowly recruiting. But who knows, there may be another surge, and at that moment we will be well positioned to recruit more patients into this trial. So you see the timeline here. I will not go through all the details, but what I would like to just tell you is that we have worked as fast as we could to get approvals for this trial and built up this network of sites, and we have been able successfully to start recruitment into this trial in February of this year. So what were the keys to success in Indonesia? I think, first of all, there was very strong central governance. So this all started in the UK. So there was a wealth of experience on how to do this trial. And the UK team built on existing collaborations with Oxford units in Nepal and Indonesia and Vietnam to go international. So that really leveraged and made it easy to go into, step into new countries from the UK perspective. Now, I think one really great key to success, and that's something to keep in mind, is the use of very simple protocol designs and very user-friendly data collection tools. So it really minimized the burden for the hospital staff that was already super busy and overwhelmed with all the COVID patients. Then the site selection. So we made sure that we only chose to work with sites that had a very committed clinical team, high-level support from the management, and minimal bureaucracy, because this trial cannot be run in a place where things move too slowly. Then lastly, and I think definitely one of the most important things that we managed to achieve was, this is a very fast moving trial and operational at multiple locations in multiple cities. So we really made it very essential to use one single umbrella ethical approval from one ethical committee in the country. And the sites that we reached out to were required to accept that ethical approval, because it would not be possible to go to the ethics committee every time we wanted to make a protocol amendment to add a new study arm. Well, looking back at this experience, I think this is a model for future clinical research. The simplification of procedures was just great to see. And I think that is something we have to keep in mind, that doing research is complex enough in itself, but where we can simplify it, we should definitely do that. I think that's an important message that or an important lesson we've learned from the recovery trial. If you want to read more about the recovery trial and the experience of Indonesia, I would encourage you to go to this website on recoverytrial.net. And it tells the story of Indonesia. A nice case study has been described where Dr. Ernie and I have been interviewed by the Oxford team. So I would encourage you to go there to read more. Now, this brings me to the next part of this presentation, the importance of infectious diseases research. Not long ago, many people were actually doubtful whether infectious diseases would still be relevant in the future. Well, COVID-19 has proved everybody proven those people wrong. Now it has become clear that it is very important to do locally integrated, responsive research to these challenges to improve prevention, treatment, and control of infectious diseases in Indonesia and the Southeast Asian region. So COVID-19 has had a catastrophic impact. And in this region, particularly, it has been compounded by pre-existing disease burdens. For example, dengue, tuberculosis, malaria, and many other diseases. Also, it became very clear, not only in Southeast Asia, but probably across the globe, that health systems are very vulnerable to new and re-emerging infections. And you can again think about some, like COVID and dengue and the hand-foot-mouth disease, measles, and other vaccine-preventable diseases. There is the threat of drug-resistant infections, disease X, so diseases that may emerge in the future and that we don't know yet. And there's also the realization that this region in particular, has strong risk factors for infectious diseases, densely populated megacities, frailties of health systems. There is climate change that leads to changes in epidemiology of diseases. So there's a need to do very much integrated research that is not only clinical research, but it's connected to the community and also to high quality laboratory science. So what should be our priorities going forward? Well, first of all, I think increasing the contribution and impact of Indonesia in global clinical and implementation research. And I'm not saying that just as a wish, but I'm actually saying that this is an opportunity and something we can do. We have seen what is possible with, for example, the recovery trial, but many other collaborations that we have. There is just huge potential to do excellent science and really make contribution to national health, but also global health. And I think Indonesian scientists and medical community should grasp that opportunity. So one important thing that we would really encourage everybody to do, of course, conduct clinical trials and research of impact, locally owned, high quality, practice changing, and large scale. And in connection to that, other priorities would be to implement new technologies. Anurag has spoken about this in much more detail, but you can think of point of care diagnostics, new drugs, new vaccines, care delivery models. That is also what Anurag described, surveillance systems. These are all priorities that need to be researched. And then in connection to that, it also has become really clear from, for example, the use of COVID-19 vaccines and the reluctance for some communities to accept vaccines, how important social research can be in implementation research, enhancing pathways to impact. So just to have the technology is not the holy grail. You need to combine this with social science to really understand your local context. And lastly, also expressed very well by Anurag, the need for better data management systems. Data can really make a big difference, and these data need to be usable and interoperable. And I think that is something that really needs to be strengthened throughout health systems and also throughout research projects. So what should be our strategies? So first of all, harnessing Indonesians' excellent scientists and medical facilities. That means building direct experience and the capacity of large-scale studies amidst routine clinical practice. And that is something that we have learned in recovery, is to do a trial in routine clinical practice is really challenging. But I believe strongly this should be the way forward. Every patient in a hospital should be in a trial. That should be the starting point. And so we learn from every patient, and we can improve our care from every patient. Then to continue developing world-class clinical trials teams of clinicians, scientists, and administrators. And at some point, that can become self-sustaining if such a team is so skilled that actually it can win grants, funding, and can continue to do new projects. And third, nurture local ecosystems of high-quality clinical and implementation research. Local groups can emerge that have specific expertise to run certain types of studies, and that, of course, needs to grow and become a local ecosystem representing various disciplines and types of people that together conduct these research projects. And of course, the fourth point, really important, emphasizing in-country capacity building, young scientist career development, and local ownership of data samples and scientific output. So another strategy that is really important to underpin all of these activities is to support solid professional research administration and finance. To do research is really complicated, and it needs these underlying mechanisms to be in place to operate. Like just to have the scientific idea and have clinically oriented people is not enough. You also need to have good governance and good administration, and that is something that needs to be developed. The capacity needs to be developed in parallel to the technical aspects. And then lastly on this slide, increasing the importance of collaborations between institutions. one group or one institution or one department can only do so much. If you work together, you can achieve way more impact. The whole is greater than the sum of its parts, which has also been used by Anuraj. And that was my presentation. Thank you very much for your attention.
Okay, thank you, Ralph, for interesting presentations. And I think you have give us some advice about how to improve our research in the future. Okay, so time is for Q&A. So any question from the audience in the chat box? Not yet? Okay, I will try to ask first to Professor Ralph. Okay, you mentioned that you have any experience with some research in some country as well. So do you have find any problems like in Indonesia as well in that country? Do you have any comment about that?
Well, I think one challenge to highlight maybe is that I believe in relative terms compared to some other countries, but definitely not. Well, it's definitely Indonesia is not unique in that sense. Is that doing research with multiple partners means that you have to go through bureaucratic processes, and these bureaucratic processes are not streamlined. So every time we have to go through a different process for each individual partner. So to do a collaborative project is often delayed because of that aspect. So if there would be ways that there can be some improvement there, coordination or acceptance, for example. Well, one example is that how we tackled that was by asking sites to accept one single ethical approval. And these are examples of how you can improve the efficiency of the research and also keep the speed in processes. And again, I'm not saying that Indonesia is unique in this respect, but it is definitely something that we have experienced in the type of work that we've been doing during the pandemic.
Okay, thank you. So maybe any comment from Mutia, because you know that you have worked together with Oxford, and then I think you have any experience with work with Indonesians researcher before. So any comment about that, please? Dr.
I think the main issue we always face, Prof. Ari, is bureaucracy and the lack of standard processes at sites. And I think this is also, my background is in industry research. So this is also one of the biggest issues that is faced by industry. Like probably you know that most of the multinational industry, pharma industry in Indonesia has already, like most of them stopped their clinical research activity in the last couple of years. And Indonesia is not perceived as a very attractive place to do research because of these issues, the regulations, bureaucracy, while the pharma industry wants to get data quickly. So it really is a shame because it deprives us from innovative drugs, new drugs that can be accessed by Indonesian population, but also we miss a lot of opportunity to gain information and insights about the data in Indonesia itself to provide input for our government to make a policy. So I think that is something we need to work on together moving forward.
Yes, I agree with you that this is our problems. I think we to overcome this problem in the future, then there's no industry will come to us to make a clinical trial. So to Dr. Anu, I think you have experience research in Indonesia more than 20 years. So what do you think that's the changes of our researcher around 20 years in the last 20 years, Anu?
Yeah, that's a very good question. I think there's two things that have changed. I think one is that there certainly is more, there's a growth in the human resource, that the training and people interested. in doing research, and you find more persons that are sort of, highly skilled in the core skills necessary, to conduct research. I think that is good. I feel like the ongoing development of institutions to support research, I think that needs to be accelerated, sort of to keep up with the increasing capability of the researchers. And also there is, I think, ongoing shortage of funding for researchers in the country. So I think that what we're finding is an increased capability of the human resource, but the institutions and the funding availability is having a challenge to keep up with them, to help them to continue to grow. And I think if these three things can be put together very, very well, I think definitely there would be some, continual ongoing high impact research emerging from Indonesia, both for the people of the country and at the global level. And to me, the most critical thing actually is for these research institutions to focus on really some key questions that are important for Indonesia from a public health and a clinical standpoint, and put a lot of resources into those. And I'm fairly certain some very important discoveries are going to emerge from that, but there must be continuous high level of funding. It's hard, I think, to do some really innovative, important work on less than $1 million per year per research team. So I think I always feel that's like a ballpark figure, $1 million a year per research team for 5 years. And I can virtually guarantee if you do that, there's many talented research teams in Indonesia, they would come up with very important, high impact, important discoveries for the country and for the world overall. So let's make that happen. It's possible.
Yes, I agree with you. I know this is our problems that how to get grant from government and also from university, because it depends that how can we can get money from other place, not only from the student. This is our problems. I think we must work together with industry. So I think from that we can take some money to support our research in the future. Okay, so maybe any comment or any things that important that you want to say here? I think this is an important meeting. So maybe if you mentioned that you work together with some institutions. Now, if some institution want to join our research, how they can do? So maybe you can ask, maybe Ralph or Mutia. I mean, if any institution want to join our research.
You're referring to other national, like Indonesian institutions.
Yes.
Yeah. Well, I think, as I also said in my talk, I'm a strong proponent of national level collaborations. I look at Indonesia because of the scale of the country as a place that actually should be capable to run a lot of good projects, trials with impact, relevance for the whole world just by themselves. So without the need for these cross-country collaborations. Of course, it's always good to work internationally, but just looking at the quality of institutions, the quality of hospitals, the quality of local scientists, and the burdens of the diseases and the problems that we are studying, if you put all that together, it should be possible to run some really, really important projects and studies. But I do think that requires collaboration across the institutions, across the groups, across cities, settings. So within the country, I believe that is definitely something that should be encouraged to collaborate. So that's what we are trying to do. I think it could be a role of us as being a foreigner to being less kind of, because we are less kind of part of the perhaps political discussions between institutions, and there are always these competitions going on. We may just ignore that and just invite everybody to be part of a project, because we have that advantage of not having not been a player in those complicated relationships from the past. I'm just giving an example. So I think that's how I would like us to work, to just say, hey, wait, we're doing this great project. Would you like to join? Because together we can have a larger impact. And of course, we will share all the credits. This is a win-win situation. Everybody will get something out of this. It's hard work, but you also get revenues from it. This is, and also not focus only on this project, but look at the opportunities that come from this project. If we deliver this well, then maybe the next project can, deliver more and also help your institution to build your own capacity. So I think that kind of story I would like to always tell, and invite people to be come together and be inclusive on that.
Yes, I agree with you, because that we always remember that if you want to go fast, go alone. If you want to go far, we must go together. I think this is the important things. Okay, maybe last statement from Anu, 1 minute, and also Dr. Mutia, please, before we close the session. Dr. Anu, maybe last statement from you, please.
Yeah. I think I would just say that the research potential in Indonesia is very, very high. I think focusing on community health, integrated community health, is very important. Bringing together interventions related to digital health, infectious disease control, and genomics in an integrated way is very important. And carrying out intervention trials, large-scale intervention trials, enabling to identify these interventions that are very effective in quick impact on mortality. And also, I would say from a social standpoint, being able to focus on human development, particularly early childhood development. We want people to be both healthy and more capable. Just healthy alone is not enough to have a thriving society. You need them to be healthy and more capable. So that would be my final message. Let's do those trials. Let's get those interventions going, and let's scale up those interventions.
Okay, thank you. So final message from Mutia, please.
Yeah, thank you, Prof. I think my last remark is going back to my presentation. I talk about impact. So we've been doing a lot of research, and I think there's a lot of good research in Indonesia ongoing at the moment, but we need to stretch this a bit further, not only to get something published, but also to make an impact. We need to think a bit harder to be able to produce research that is meaningful. It's not only collecting data, but to make an impact. And in the end, we will improve patients' outcome, and that would be my my note. Yeah.
Okay, thank you. Because of time, thank you for your contributions, Dr. Anu, Prof. Ralph, and also Dr. Mutia. And so
thank you.
I'm happy to discuss this afternoon with you. And back to the
thank you, Prof.
Also thank you, yes, for all audience stay with us. And back to Amalia, please.
Dr. R. Muharram finished his study in obstetrics and gynecology specialist at Universitas Indonesia in 2005, then gained his doctoral degree in medical science at Universitas Indonesia in 2011, continued with magister program in public health at Gajah Mada University in 2020, and currently he's head of Immunoendocrinology Reproduction Division, Department of Obstetrics and Gynecology, Dr. Cipto Mangunkusumo General Hospital, Faculty of Medicine, Universitas Indonesia. Please welcome Dr. Muharram.
Yes. Good afternoon. Today, we want about demography and Dr. Muhammad Riza Martua, Master Reproductive. We know that but if it can be we not well. Expert, the veterinarian Muhammad Riza Martua Daman, the reproductive officer, discussed about graduate from IPB, science in Monash in 1990 and 2005. in science from Indonesia. So today, for training research, National Population Planning Board, to of nutrition, or good. Please, Professor.
Can you hear my voice, Dr. Muharrem?
Yes, clearly. Okay, thank you.
Okay, thank you. Okay,
Yes,
thank you. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon to all participants. First of all, I would like to thank the committee for inviting me, actually inviting the chairman of PKKBN to this important meeting. And the title of my presentation this afternoon is about the stunting reduction to improve quality of life and to achieve a demographic dividend. As we all aware, that Indonesia is the largest archipelago country comprising thousands of islands and also has the longest coastal line. Yet, Indonesia is also ranked the fourth largest populous country in the world after China, India, and United States. Indonesia has 34 provinces and 519 districts or municipalities with total 360 ethnic groups. This year, the population numbers of Indonesia is estimated about 272 million people. In terms of the population growth, Indonesia remarks as notable progress in reducing its annual population growth rate. This is attributed to the success of family planning program to manage population size over the time. One of the most prominent demographic experts in Indonesia, the late Professor Wijoyo Nisisastro, in 1970, was actually attempting to project population number of Indonesia using the projection assumption from the population parameters of Indonesia at that moment. When we were using population indicators at the moment, year 1970, and projected the population number to year 2000, the figure revealed 285 million people. But according to Indonesia population census by Central Bureau of Statistics Indonesia, the population number was only 205 million. Thus, there was 80 affected births due to the success of a family planning program. Also, when we projected the population number using indicator assumptions in 1970, the estimated population number in 2010 was 330 million, where in fact the population census data revealed the number only 237.6 million, or there was 100 million of births affected, attributed to the success of family planning program. All the program run by the BKKBN in terms of population, family planning, and family development are blended and implemented accordingly until grassroots level at the rural areas, which is known as the family planning villages or Kampung KB. In Indonesia, we call it as Kampung Keluarga Berkualitas, not Kampung Keluarga Berencana, but Kampung KB is stand for Kampung Keluarga Berkualitas. Family planning villages work on various programs related to the family. With regard to improving nutritional status of community, family planning villages are also targeted to combat stunting, which is still prevalent in Indonesia. From this slide, we can see that there are significant regional differences. Subsequent studies found that in some locations, the rate of stunting in children reached 42%. 3 provinces with the highest prevalence are East Nusa Tenggara, West Sulawesi, and West Nusa Tenggara provinces. And among 34 provinces, only 4 provinces that are in the medium level. Data revealed from the Indonesia Ministry for Health from the basic health research in 2018, the prevalence of stunting among children under 5 years old was 37.2%, and around 19.5% of children under 5 years old are categorized as severely malnourished. Not only the children, the mothers themselves were also in danger. Around 38.5% of pregnant women aged 15 to 49 years old experience energy and protein deficiency from their basic daily food intake. The worst even continues. Around 37.1% of pregnant women were detected anemia, which put women into a danger when they gave childbirth. These research also confirmed the finding there was a strong statistic correlation between the incidence of stunting and the mean age of first marriage of the mothers. This means that the younger of the mother when she got married, the greater relative risk to have stunting children are accounted for 2.5 folds. Demographic dividend. This is irony, considering that Indonesia is now entering the period of demographic dividend, meaning that Indonesia experiences a boosted economy productivity due to larger proportion of population working age 15 to 65 years compared to its non-productive counterpart. As we may aware, since 2012, Indonesia is entering the period of demographic dividend marked by consistently declining dependency ratio nationwide. This will reach the lowest peak of dependency ratio at around 44 per 100 between the year 2028 until 2031. Thereafter, the dependency ratio will increase again due to the rising proportion of elderly. Harnessing the demographic dividend. Demographic dividend will be achieved under the condition of the family planning program being implemented properly. When women can control their fertility and have fewer children, women can enter the labor market, they can earn income to support their family. When all families in the community can save their income, they will contribute also to public savings and improve their own infrastructure. The diversity of geography and history, including social, cultural, and economic differences, have contributed to highly divergent health status and health systems across and within countries of Southeast Asia. Southeast Asia contains about 600 million people, or 9% of the world's population, with Indonesia having the largest population and 4th largest in the world, and Brunei the smallest. You can see this in the table. Nearly half, or 43%, of the region population live in urban areas, which is less than the world average, but there is much variation between countries. from 15% in Cambodia to 100% in Singapore. The region's average population density of 133 people per kilometer square also masks substantial inter-country and in some instances intra-country differences. Population densities range from a low of 20%, 27 people per kilometer square in Laos to a high of 7,022 per kilometer square in Singapore. Population density in Southeast Asia's only two megacities, Jakarta and Manila, are much higher at more than 10,000 people per kilometer square. Rapid urbanization, population movement, and high density living raise concerns about newly emerging infectious diseases. But these outbreaks have stimulated regional cooperation in information exchange and improvement in disease surveillance systems. Southeast Asia peculiar geology contributes to it being the most disaster-prone region in the world, more susceptible to natural and man-made disasters affecting health, including earthquakes, typhoons, floods, and environmental population. Climate change, along with the rapid economic development, would exacerbate the spread of emerging infectious disease. The question is now how to prepare human resources to harness demographic dividend in Indonesia. In order to improve access to services for mother and children, the approach of a continuum of care has been implemented since the pre-pregnancy until elderly. During the pre-pregnancy period, program is targeted to eligible couples through family planning in persuading eligible couples to adopt long-acting contraceptive methods. Therefore, the couples could avoid unwanted pregnancy and able to plan the pregnancy on the right time. For those eligible couples would access the integrated family planning and reproductive health services in the community health centers. And during pregnancy stage, the program is targeted to protect the lives of the mother and the fetus, where there are complications and health risks, so the health personnel could detect the problem as early as possible to determine the proper interventions. The activities included in this stage are pregnancy planning and prevention of complication during delivery, integrated antenatal care, and also maternity class for pregnant mothers. These slides come from the report of the Commission for Nutrition in the first decade of the millennium prepared for the ACC SCN in the UN. It shows how inadequate fetal and infant growth can lead to four main areas of negative consequences. One is that since 1/2 of child deaths have undernutrition as an underlying cause, for example, they would not have died from the infection if they had been better nourished. The second is that brain development is affected, leading to long-term damage to cognitive and educational performance or increased good repetition rates. The third is that the size of the body is compromised or stunting, and tissue development impaired, such the work capacity is reduced, as is immune capacity. And the fourth area of a consequence is that the metabolic programming to cope with the resource-scarce environment, which leads to all the chronic degenerative disease of adulthood, including obesity. It is noteworthy that the cause of obesity and stunting are both rooted in the fetal and infant growth. In developed countries, both conditions are more common among the poor than they are among the rich. This slide explains us the golden period when the brain development takes place in its primary time, namely under 5 years old. The brain development of children until they reach 5 years of age becomes pivotal for their future. Various studies state that the severe failure of growth and development of children under the age of 5 is referred to as the stunting stage, occurring when the comparison of height and age is not balanced. In other words, the increase in height is much less compared to their age. Research has been confirming the significant difference between brain development of a normal child and a stunting one. In a study that examined the development age of the year-old children suffering from stunting, there was a significant difference in brain development, and brains of normal children turn out to have a larger volume than the children who suffer from stunting. Brain development is heavily dependent upon interaction between the child and the adult. Some of the sensing pathways that have a major role in development of the brain are shown on this slide. That's how the mother responds to signal from the child while be influencing how the child's brain develops. These back and forth interactions can be babbling, facial expression, gestures, cries, and words. Now, I'm going to talk how BKKBN elaborates these parental functions. Through family planning villages, all activities are dedicated to families, among others families with children under 5 years old. Within the community, the BKB groups, Bina Keluarga Balita, activities are to monitor the children growth, additional complementary food provision, and also counseling delivered by family planning field workers at villages. Through these Bina Keluarga Balita activities, families also learn how to implement at family functions. And the family planning villages are also plotted as stunting villages for similar considerations. Besides the community group activities among family with children under 5 years, in family planning villages, there are also community group activities being developed among families with adolescent children and families with elderly members. For the elderly members, we name it as Bina Keluarga Lansia, and for the adolescent children, we call it as Bina Keluarga Remaja. Those three pillars of community group activities were developed under auspice and through observation study developed by the Deputy for Research Training and Development of BKKBN to be integrated into family planning villages in Indonesia. Therefore, family planning or stunting villages, which spread over 34 provinces in Indonesia, welcome all kinds of collaboration with universities, research institutes, and also private sectors. Family planning villages in Indonesia, which integrate three pillars of community group activities for families with children under 5 years, families with adolescent children, and families with the elderly, becomes the social laboratorium for national program on population, family planning, and family development carried out by BKKBN. In the family planning villages that we have visited during youth visit, the families in Indonesia are persuaded to implement 8 family functions with their own family setting. Those 8 family functions are religion, social and culture, love and affections, protections, education, socializations, reproductive health, economy, and environment. The implementation of the last family function, for example, in economy, is through planting eligible vegetables or plants. For instance, planning the Torbangun list, especially for family whose mothers has a newborn infant, to improve the breast milk productions of lactating women. And partnership of BKKBN with universities or health education institutions, and also forum of the Indonesia rectors to collaborate research in the field of population, family planning, and family development targeted to prevent stunting cases. The front line of all interventions to combat stunting is through family planning villages in Indonesia, which invite all collaboration with intersectoral ministries, universities, and academicians, and also private sectors. And the launching of the family planning villages by the President of the Republic of Indonesia, His Excellency Joko Widodo, on February 2016, has proven to leverage the outcome achievement on population, family planning, and family development program in Indonesia. So that's all for my presentation. Once again, BKKBN welcomes all supports, especially those which are directly distributed to the community. Thank you very much for your kind attention. Assalamualaikum warahmatullahi wabarakatuh. Thank you.
So we go to Q&A. And while we getting the Q&A, maybe what the program, the short program from this or this kind of demographic of bonus here, Professor, from the BKKBN and from the long-term planner, and for the short.
Yeah.
Yeah, thank you.
Yeah, in relation to the demographic dividends, one condition that we must show is about the condition of the young generation. Actually, if the young generation condition, for instance, about their nutritional status, yeah, as we are facing now at the moment to combat stunting, to reduce stunting, the prevalence of stunting at the moment in Indonesia is 27.7, and President has mandated the BKKBN to lower the percentage to be 14% at the end of 2024. So this is a very basic. If we cannot yet reduce the stunting condition in the relationship with the demographic dividend. So now we are just launched about this program to reducing stunting, and will be started in the January next year.
Because the situation is very fast, changes like VUCA like this, because the COVID-19, the economic and the education and the meeting from the population is very changed today. There's any special program from the KKBN to anticipate the situation, because after COVID is we have many changes.
Yeah, you're right, I think, because actually the program in reducing stunting should be begin the 2020 to 2024. but the unpredicted condition, the pandemic. So we have to cancel about the beginning of the program to, due to the pandemic, hopefully to the 2022 in the next 2 or 3 months. So meaning, we try to do our best. Actually, we use to communicate with all field workers using the technology, the IT things, but this is a very challenging. So during the 2000 and 2001, we, to reach, to share the information, to train about our midwives, our field workers, to provide information about what is stunting, what is the mechanism, what is action are needed to avoid stunting things, to teach about the field workers is not easy. And at the beginning, they are not familiar yet with the virtual meeting things, and also the geographic condition in Indonesia, especially in the east of Indonesia, like Papua and then Maluku, right? It is the geography is not supported, so cannot receive signal in that area. So that's why the challenge actually, and we must delay actually from the 2020. So it's hopefully the pandemic is over, and then we can begin the program next January. So we train our field workers, and we try to coordinate with the ministries and institutions during this pandemic period.
Thank you very much. Now, how about the family planning? Because in pandemic, because they work from home, there's many couple with unprotected, so many pregnancy.
Yeah. Yeah, stay at home, the policy, just stay at home. You still remember last in 2019, if I'm not mistaken, the presidents asked the people to just stay at home for almost 4 months, right? Yeah. And lucky us, actually, we had the chance to conduct the survey, and the result shows that many couples stay at home, stay home because their office, right? There are no activities, public transports, right? Stop. So but we should calculate again about the second survey after this pandemic situation. Seems to be there is an increase in pregnancy due to the pandemic condition, right?
Because the economic is quite impact negative from the COVID, so they can buy the contraception maybe, and they cannot consult. Maybe in the rural area,
in the rural area, right? Because they were forced to stay at home, right? No activity because the market are closed, economic stop. Not only happen in Indonesia but around the world. So for the services, for the family planning tools like contraception things, pills or IUD, we will actively make using a mobile and to move to one village to village using the cars, and microphone telling, okay, anybody would like to have a service in contraceptions, we will visit your home for the midwives in the remote area out of Java. Right? So all the branches of BKKBN are actively reach the people in their homes using the mobile to make an announcement, right? This is midwives, and anybody would like to have a service will visit their home. And also using the, in some remote area, using also the technology, handphone, WhatsApp, to make a contact with the clients, asking about their implants, maybe they want to replace about the implants, etc. Yeah.
Very opportunity. And if for the stunting, is there any I think like go with the green beans in Posyandu maybe, or there's different workers to different target to management to get the make a low stunting. Jadi tidak seperti zaman dulu ada pembagian kubur kacang hijau gitu sementara atau tidak lagi, kita metodenya beda lagi mungkin Pak.
No, we still the same method actually, right? But we just more active in give a service to the community. The method is still the same, right? Yeah, this is a very unpredictable conditions. We never have this kind of experience about the pandemic thing. So as we experience, we just stay at home and then no activity, right? So, but later after 3-4 months, we make kind of coordinating meeting, right, with all branches throughout Indonesia to see about the situations, because although the condition is pandemic, the service must be run actually in normal situation. So that's the initiative that we have been practiced during the pandemic.
Thank you, Prof. Because the time, is there any last statement for us, Prof?
Yes, as in the last slide, I think we are welcome or collaborating program either from the university or any professional organization to participate in this, I would say, a kind of a war, right? A war in combating stunting. This war, I think, is our investment for the future of Indonesia. If we cannot reduce the stunting prevalence from the 27.7% in the next 3 years, very bad for Indonesian future generation then. So the target, the 14%, is actually is not easy. It's not easy, it's very hard. Meaning from 27 to 14, it means that each year we have to reduce it about 3 up to 5%, right? To reduce 3% is very hard actually. So need an extraordinary mechanism between ministries and institutions, include the universities, include especially the Faculty of Medicine from University of Indonesia.
Okay.
Thank you.
Thank you.
Doctor.
Thank you very much, Prof. Uji.
Yes.
So we talk here about we have to cope the poor demography with good planner and good positive thinking. Thank you very much from the committee. Thank you, audience here. We hope the policy demography with spirit. Okay, thank you very much. Back to Amalia as
Ladies and gentlemen, here is our last session, Concurrent Session 19, Virtual Reality in Our Future Medical Education and Healthcare Training, that will be moderated by Dr. Imelda Rosalin Sianipar, Magister of Biomed, PhD. Dr. Imelda Rosalin finished her medical doctor and Magister of Biomed at Universitas Indonesia and gained her PhD degree at Kobe University in 2015. Now she's currently active as lecturer at Faculty of Medicine, Universitas Indonesia. Please welcome Dr. Imelda Rosalin.
Thank you, Amalia. Does my sound, my voice clear enough?
Yes, doctor. Your voice is clear enough.
Okay, thank you. Okay, so good afternoon for all participants and also the three speakers for today's session. Greetings for everyone from Indonesia and also from abroad. This is our last but not least session for today's webinar. It is an honor for me to guide this very interesting session because COVID-19 pandemic situation really enforced us all to be innovative and creative. And today we will have our three excellent speakers regarding the virtual reality and in training and learning for medical education and healthcare training in this pandemic situation need to be modified by its method and delivery. Hopefully this session will open our inspiration and explore more challenges and innovation in virtual reality for our future medical education and also healthcare training. So for the first speaker, it's going to be Dr. Siddhartha Manggala. He is an anesthesiologist in the Central Hospital, Cipto Mangunkusumo Hospital, and also he is a lecturer at the Faculty of Medicine, Universitas Indonesia. He graduated from Universitas Indonesia in 2010 and become an anesthesiology specialist in 2015, and now he already a consultant for anesthesiology from 2020. So without further ado, I would like to ask Dr. Siddhartha with the title of How to Design and Create a VR Module. Dr. Siddhartha, please, the time is yours.
Thank you, Dr. Imelda. Okay. Please allow me to share the screen. Okay. Okay. Thank you very much. Good afternoon, everyone. Pardon for my my English is not that good. Okay, so today I am asked to tell about how to design and create a VR module. So as we know, the VR is a creation of digital world and interact with it in real time. So it was proposed by Jaron Lanier in 1980s. It integrates many key of technologies and it's very useful for medical education, not only for medical education, for aviation, but also for aviation industry, and also for military industry. So it's the use of VR right now is very wide. Okay, so general concept of building medical VR application. The first one we need to identify. So what is the aim and scope? As for me, I am right now I am working for making a VR CPR module. So my aim is to make the learner to be able to do a good CPR, high quality CPR, which is a push hard, push fast, full recoil, and minimal interruption. So that's the aim, and then also the limitation, and then after that the justification. So with whom that we want to work with. So we need the IT specialist, and then we need to think about the resources, the cost, and also the risk. And then the third and the fourth one is the most important one is knowledge acquisition and also knowledge formalization. So this is how we transform the concept or the thing that we want the learner to learn, and then make it incorporated in the VR module. So this is the most important thing. So we need to understand the VR technology, and also we need to know the VR system that we are using. So this is need to be a very close loop between the IT specialist and also from our medical specialist. And then after that, the application and implementation, it can be done with readjusting if there's anything that not very good. So with time, it will be getting better. So this is the virtual reality system, as you can see in here. So this is the closed loop of the VR system. So VR system use visual, hearing, and also touch. And then after that, it will be transduced to computer input. And then after that, we go to PC. And then after that, the PC will make the computer output. And then also, as you can see in here, for the head-mounted display, it will show the visual and then the sound and then the tactile. Actually, it's limited right now to vibration from the controller, and then also the proprioceptive. So like when you move your head to the left, then the virtual reality world would also change to the left, something like that. Okay, goal project of VR in CPR education. This is my major. So we want to create a risk-free environment. As you can see right now, it's a COVID pandemic. So with VR, we can have social distancing, and also we can limit the person in one place. And also we want to improve the decision making in lifelike scenario, improvements in procedural memory, improvement in speed, accuracy, and transfer of skill to real life scenario, and also increasing numbers of CPR trained personnel. Okay. So this is the feature of ideal VR for CPR education. So the first thing is fidelity. So fidelity is how good the VR actually it can close to real world, to reality. So the fidelity needs to be very good. So it will make the person feel like he's in the real situation. And then after that is engagement. You need to make it very interesting, so the person, the learner, is can very interested in the module, and then can learn a lot of things. Because if you are interested in something, then you can learn a lot. But if you're not interested, then you don't learn anything. After that is resource conservation. This is the good part of VR. Yes, you might not need you might only need a mannequin, maybe, or in some of VR, they don't need mannequin at all for CPR procedure. So it's a very virtual. So you might not need anything. And then also, because of the fidelity and the engagement, you will have the memory enhancement. Okay, so this is the level of educational medical VR application. You can see there's a 3 level. The level 1 is the basic one. So as you can see, if we can have a anatomic atlas. You can see you can look at the person, and then you can open the chest. You will see the heart, and then the lung, and then you can see the anatomic, and then you can name, and there's a name in it. So it's only for general knowledge. For the second one is for procedural knowledge. I think this is for my case. So we can do some procedural knowledge, like if you want to do a good CPR, push hard, push fast, full recoil, minimal interruption, you can do it in the level 2 for CPR. And then the third one, the level 3, is the most sophisticated one. I think this is for a specialist doctor. If you want to do like laparoscopy surgery, the complicated one, then you can mimic that kind of situation in virtual reality. So it's a different level from what I making right now. So you need to adjust your module to with whom you wanna who is the learner. If your learner is the specialist or subspecialist, then you need to make the level 3. If you want to teach the student, if the VR is for the student, then you will need only the level 1. So that's how you're making the level based on the learner. So this is the breakdown of what you need to do for level 1, level 2, and level 3. I'm gonna skip this. Okay, so analysis of the characteristics of the interactive interface design of the virtual medical system. So the first one, the most important thing, is the immersion. So immersion is like when a person feel like he's really, really in that world, so he can learn a lot. And then after that, the interactivity. So he needs also to be interact with the world and the virtual world. So he can do a lot of things. He can touch. He can manipulate the object inside of the virtual world. That's very important to do. And then after that, the conceptual is based on what the module maker wants. So what do they want the learner to learn? So they kind of put a conceptual idea that what the learner needs to learn. So like in my case is do a good CPR, push hard, push fast, full recoil, and minimal interruption. So this is the immersion. So this is the new VR. It's for gaming, but this is very cool. So like this person, he can walk, he can shoot, he can do everything in this VR model. So it feels like he's in the real world. So this is like maybe like a Matrix movie. So this is very cool. This is what really immersion should be. Okay, and then the VR simulation pathway. This one is quite difficult because not too many VR system can make it like this one. So actually, but this is the ideal one. Actually, the medical student and instructor go to the simulation center, and after that, the thing that the visual that they see is split by 2. The medical student will enter the training room, receive the instruction, and then also take action according to the scenario. But the instructor will set the scene, give instruction, and adjust the situation according to the student action. So actually, this is like in our simulation center. But nowadays, the VR, the VR technology still cannot have this this kind of pathway. So maybe in the next few years, they will develop this kind of VR. So the medical students and the instructor will have a different roadmap, and then it will interact one and another, and then it will make the students feels that the VR is really the real reality, because the instructor is adjusting everything based on the what the user do, the medical students do. Okay, so this is the VR simulation game modes. This is from Singapore. This is for a lay rescuer. So this is very interesting. So what you can see in here, you need to have a lot of instructions because it's very hard if you don't give instructions in the VR because you don't know what you want to do. Because you immerse in a very different situation, you will go into the unknown world. If they don't give you instruction, then you don't know what you have to do. You don't know the boundaries. What can you do about what the thing that you can do in that world? So it needs to be there's need to be instructions. Okay. And then this is the VR result by the participants from another study. They feel like they really enjoyed playing it. It's improved the understanding. It's prepare for the real life because it's imitates the real lives. And then it's very beneficial for different cases because you can simulate a lot of scenario. Easy to understand, and the hard part is they don't think it's very easy to use the interactive elements. This is the hard one because when you're making the good VR model, then you need to think about the interactive elements, and this is very hard. And then the gameplay element is useful, but regardless of that, they enjoyed the VR learning competency for CPR more than the video-based learning, more than the text-based learning. And then the other one is ER. I'm just going to mention it a little bit. If VR is fully enclosed synthetic experience with no sense of the real world, augmented reality is real world with digital information overlay. So the real world remains central to the experience, enhanced by virtual details, and the merged reality, I think it's not yet exists, is interaction with and manipulation of both the physical and virtual environment. So this is for VR CPR. The VR CPR is non-inferior to the real CPR. So okay, just next. This is the AR. So this is AR HoloLens. As you can see in there, that's the resuscitate and mannequin. And then after that, with ER, you can merge the reality and with the picture of the diagram of the heart, and then also the cardiovascular properties. And then when you do the compression, then you can see the blood flow from the heart. It's very interesting. It's kind of merging the virtual and also the real one. So this is very conceptual and this is very interesting. So AR and CPR quality result is quite good, both from compression rate and compression depth and also recoil. And then they were the testimony is they are comfortable. They have the feeling the patient was present in front of them, and also visualizing the blood flow while performing CPR was useful. They said like that, conceptual. And then they want to use this AR CPR application in future trainings. So the problem with VR, the VR that are being developed is VR cannot mark. VR cannot integrate the ER, the real element. So the study from VR study is they're doing the CPR not to the mannequin, but they're doing it virtually. So actually they are pushing air. So that makes the CPR feeling is not very good. This is the difference of VR and ER. Okay, what we are developing right now is we are using Oculus Quest. It's easy and quick setup. It's wireless with Oculus tracking with the properties of a virtual reality system. It has a good, it's quite good audio. with 2 touch controllers, and it have a play inbounds or guardian system. Play inbounds is like you can mark where is the drawer, where is the chair in your room. So if you walk in your VR, then if you want to hit the wall or something like that, it will give you a warning sign, so you don't have the injury. And then the Oculus Quest is readily available commercially for gaming. It's very interesting. So this is what we are doing right now. So we kind of merging of VR and ER. So this one, we want to have a real CPR quality, to have a good quality CPR. So then we are using the real mannequin. So this person is measuring the distance for the controller, and then after that, in this picture, this is the picture from the VR world. What he see. So he's pushing the code blue because the patient is in the arrest condition, and then he can do look, feel, listen. So this is the mouse, and then the sound should be no breath at all, because this is the arrest scenario. And then he can also do the compression. As you can see in here, the controller is being put in some special socket in the arm, because the controller is the one that will track the depth, the rate, and also the full recoil of the good quality CPR. So we need the controller. So we can have a little bit improving a bit. And so the problems that we are having is the interface. As you know, you need to make a socket for controller in your arm. And then also we think the sensitivity to the real world for VR is, we need to make some adjustment. I think we need to make more sensors, because for our case, we need to have the same desk height and then the same mannequin to do the CPR. So because the VR world is not cannot adjust it, but AR world can. So that's the downside of it. But I think we can do it with making more sensors. And then the VR from the Oculus doesn't have voice command, so it's hard for us if you want to do a CPR sequence like you are commanding to give epinephrine. So they cannot. So we need to think to use another method to make the NPC non-playable character to give epinephrine, such as touching the screen or something like that. Okay, so I think the conclusion is the main concept of VR is creation of digital world or environment in which a human user is placed and can interact with it real time. It's provide immersive experience for users, resulting in improvements of procedural memory, speed, accuracy, and transfer of skills to real life scenarios. It's still not perfect, but we can work it out. Okay, thank you very much. I think that's all from me.
Thank you very much, Dr. Arta, for such a very interesting and comprehensive talk. And I believe it will be challenging for all medical teacher and also healthcare personnel to create such a good VR module. We will compile all the questions from participants after all speakers finish with their presentation. So let us continue with the second speaker. The second speaker will be Dr. Aida Rosita Tantri. She is an anesthesiologist specialist in the Cipto Mangunkusumo Hospital and also lecturer at the Faculty of Medicine, Universitas Indonesia. She graduated from the medical doctor from South Sumatra University, and then become an anesthesiology specialist from Universitas Indonesia in 2001, and finished her doctoral degree from Universitas Indonesia in 2014. And she is the head of the Simulation-Based Education and Research Center, IMERI, Faculty of Medicine, Universitas Indonesia. For the next speaker, Dr. Aida, the time is yours.
Thank you very much for a very nice introduction, Dr. Imelda. Let me share my screen. Okay, I hope everybody can see it. Okay. Okay, so thank you. After we hear Dr. Arta how he has developed a CPR module for training, for healthcare education and training, let me talk about how can we use virtual reality in our simulation center, because this is a cutting edge technology, and can we use it in our teaching and daily activities teaching, or maybe in research also. I think we remember about around 2 or 3 weeks ago when Mark Zuckerberg, the CEO of Facebook, changed the name of Facebook company into Meta, and then he decided to more focus in virtual reality development. Mark Zuckerberg think that virtual reality will play a main important role in our next future, especially in education and healthcare. And Mark Zuckerberg say that virtual reality is better than the limited real world that we already know nowadays from what we use from social media or other connection. So we can see now also the forecast size of the augmented and virtual reality market prediction for the next 4 years, and we see that the healthcare will play the second market, the second biggest market for virtual reality and augmented reality, and that means we all will be exposed to virtual reality and augmented reality in the next 2 or 3 years ahead. So that what Dr. Arta has said, that virtual modalities is consists of 3 main types. That's the virtual reality, augmented reality, and mixed reality. And that's different from how the learner will interact the reality or the virtual reality, and how we can interact with our world, our real world. So the VR will play a good and main role again in education. So the question is, why medical education needs VR modalities? So nowadays there is increasing needs of simulation modalities. There is increasing of patient population. There is wide range of treatment, interprofessional nature of care, and simulation has played as a vital part of medical education. But unfortunately, there is limited resources of simulation. Simulation with high fidelity simulators requires significantly more resources than the traditional education, and that makes room for VR modalities to come as one of the modalities in simulation. Dr. Arta has explained it very good in how we can run the virtual reality simulation by running a scenario, and then run the scenario and do the debriefing. This is like we usually do the simulation in our job as a teacher for medical education. In scenario, we can design what our student want to learn. Is it a decision making? Is it a critical thinking, clinical reasoning skill, empathy? And then during debriefing, we can do it by virtual debriefing, or maybe by we ourselves as instructor do the debriefing for the students. For the learners, the VR can make clinical experience more simple. So compare with the high fidelity simulator, it is more simple. Just put the headset and they can play the VR. Of course, they must learn a lot how to operate the device, but nowadays youth are very easily learn about technology, and they become a fast learner in technology. And then learners can integrate the simulation-based education into everyday practice. That's what Dr. Arta said, that virtual reality is more immersive compared than the traditional teaching that you will usually use. And the VR scenario are repeatable, and learners can feel safe and they can make mistakes safely, and then they can learn by themselves. So it's learn through deliberate practice, and can easily encourage engagement and autonomous learning. And this, in the long term, it will be free up space and faculty time. So faculty member not always need to be present there. A faculty member can be focused on more advanced communication skill, or maybe on insight to simulation. The other is, we don't need a big room for a simple VR. We can only the VR can run in a very small space, 2 times 2 meters, the smaller one. But if you want to run a big simulation with VR, of course, with more sophisticated device, of course, we need a more free space room for that. And again, multiple simulation can be run simultaneously in different simulation rooms. So a lot of students can learn it one time, compare with the simulation that we usually perform now. So, and at the end, we hope that simulation can be distributed globally, and then it increases the quality of medical education. But of course, there is a drawback, and I think Dr. Andi Ade next after me will explain why VR is not suitable for every possible educational opportunities. But the most important thing is VR can and should not replace the expert educator. So expert educators still needed in the training for or education for students or healthcare, because they can give a good debriefing, especially in a very highly sophisticated skill. And how about the reality lab? Reality lab is we usually know the simulation research. So reality lab is the part of simulation research that do the virtual reality. So by having a reality lab, we can do research in virtual reality. What kind of research? We can do research in quality improvement. So by doing the research, we can understand what problems underlying the quality disturbance. So, and we can also assess what intervention we can do, and how the feasibility of the intervention that we will do. And of course, we can evaluate the effect of the intervention and optimize the design and implementation of the intervention. And then the most popular thing is the effectiveness study. You usually use it to learn, is it one VR is more effective than the other VR modalities, or maybe compare it with the traditional modalities in simulation to improve our student knowledge. And then also VR can use for evaluation and economic study. More and more research labs are turning to use virtual reality for their studies. And we can see it in the PubMed publication that in recent year, the VR publication is increasing in number, because like Dr. Arta has already said, that virtual reality can provide a highly immersive environment for students to learn. And we can design a complex scenario with high cost efficiency. And of course, we can run multiple scenario. Other study stated that participants respond to virtual reality almost as if they exposed to a real world scenario. So it might be because of the immersive condition that the virtual reality can create. So how to develop the VR lab? No. it's not as simple as we think. If you want to run a simple VR lab, so we can run it with only a PC or computer, and then the headset, and then the other tactile device, we can run it. But if we want a good, very immersive VR lab, so we need a lot. We can tailor according to our center. Is it a big one, or maybe a small one, or maybe a moderate one, and tailor it to the budget that we have. And please, if you want to choose the right device, we must remember that we must choose the device that can customizability, can customize and can scalability according to the latest technology advances. So we can upgrade it, and we can use we choose the device according to what we will do. So what our simulation center usually teach, who usually teach in our simulation center, and what they need. So we choose the right device for that. And then do we need the footprints, or maybe we need a highly responsiveness device, because the highly responsiveness device can respond to movement very fast, and the fast response will make the visual refresh rates of the picture that the learners receive will be more good, better than the slow response one. And this one can decrease the incidence of motion sickness that usually triggered by using the headset of the virtual reality. So if you want to decrease the motion sickness, we must choose a good device, a good headset, and a good computer device. So this is the one that the picture that I see, that how the device can sensor the motion of the learners. Is it to left or right, up or down? And then this is the device that we need to settle for our simulation center or our reality lab. We need a good output. Is it only a headset, or maybe we want a projection room? A projection room is one small room where the virtual reality is projection to the four wall of the projection to the room, and the learner don't need to use the virtual headset, but he only use the 3D glasses. So he can, like, he go to another environment, another world by entering the room. So it is one kind also for the output. And we need hardware for rendering. And the input, do we need only the tactile sensor by using the data glows, or maybe we want to use the position tracker, like using the treadmill, especially designed for the virtual reality, or maybe we can use the eye motion tracking. So there is so many devices that we can use, and so we can choose which one is suitable for our reality lab. And if we want to use a big scenario, if we want to run a big scenario of virtual reality, we need a physical space layout, a big physical space layout, the open area that is free from any obstacle or clutter, and keep the cables out of the way. So we usually hang it on the ceiling. And then if we want to we want to use the camera-based motion tracking system. So we must make sure that the camera cover all the whole room, and then avoid the light interference. So usually the CPU will be bring by the learners as a backpack. So it's not too far away from the headset, like in this picture. So this is other device that usually can usually need for the reality lab. There's a backpack PC, like I say before, and then there is input device. We can use the data gloves or maybe eye motion tracking, and then maybe speakers and sound, because it make a more immersive situation by giving sound, and then maybe also visual display like VR headset, or maybe a mixed reality glasses like HoloLens or maybe Google Glass. So this is the example of 3D projection room. So in this case, the learners doesn't need to use the headset, the virtual headset, the VR headset, but only use the 3D, a simple 3D glass like HoloLens or maybe Google Glass. So how about the research that has been done so far in the virtual reality? So far, we can see that research has learned which method is effective compared with the other method. This is for anatomy teaching, and they use the virtual reality-based technology, and they found that virtual reality may act as an efficient way to improve the learner's level of anatomy knowledge. And here in IMERI, I see that this is already been applied also. And then the other research is how they develop skills of laparoscopy using the virtual reality simulation, and they found also that the laparoscopic skill compared with other studies non-inferior. So it can be used to replace the other technique of teaching if we cannot provide it. I think that's all from me, Dr. Imelda. Thank you so much for time.
Thank you very much, Dr. Aida, for a very integrated and comprehensive talk. A lot of advantages of using simulation through VR, not only for the medical education, but also for research, and also not just for tutors, but also for the learners, or student, and the faculty or management. And for questions, we will compile at the end of all speakers. And now we will continue to our third speaker, Dr. Andi Ade Wijaya. She is an anesthesiologist specialist. She is the anesthesiologist and also lecturer at the Cipto Mangunkusumo Hospital and lecturer at Faculty of Medicine, Universitas Indonesia. She graduated from Medical Doctor Universitas Indonesia in 1996 and became a specialist in anesthesiology in 2004 from Universitas Indonesia, and become a consultant of anesthesiology from Universitas Indonesia in 2009, and finished her doctoral degree from Universitas Indonesia in 2018. And she will deliver the talk for today about optimizing the use of VR in CPR training. Dr. Ade, the time is yours.
Thank you, Dr. Imelda. Good afternoon, everybody. This is a very heavy rain here, so I hope there will be no problem with all things. Okay, I will start the slide. Sorry, I should make it small. Okay, how do we gonna optimize the use of VR in CPR training? You know that the recent outbreak in COVID-19 has derailed the conventional methods of delivering medical education and forcing educators to reconsider how will they continue training their students in order to secure the supply of future doctors that we want them to be. And for the temporary closure of medical schools and suspension of clinical attachments, it will have forced us to think about another opportunity for the students by using the technology and deliver the teaching remotely. So what is VR? Dr. Arta and Dr. Aida already tell about the virtual reality. What is the VR and how do we implement it in our medical school teaching? So the VR can be used to also to mitigate missed hospital-based teaching by providing fully immersed and highly realistic clinical simulation to students. This is for examples in not in medical but in industrial. They are comparing about traditional training and VR training, that VR training gain more benefits comparing to traditional training. And it the literature said that for industrial, the VR training save a lot of time and a lot of money also for the and the benefits is like not really far from the traditional training, and they also get some benefits from VR training. Okay, what is VR in medical education? We know that now the anticipation are also need on how the generation will learn and practicing what they need to know and what skills they'll need and what tools they will use. You know that teaching teaching for the millennials or this group of students is challenging. That they need to learn to study in their own pace and their own expectation. So we need to adjust the strategies how to give effective learning for the millennial learners. Then it can be summarized within 5 hours, ensuring relaxed learning environment, building rapport with the learners, highlighting the relevance and rationale of learning objectives and assessment, and implementing research-based educational methods. So that's how they will learn fast, and we can give the best education for this kind of this group of students. When we talk about the learning pyramids and the medical education now have a challenging changing situation. So simulation is increasing and becoming a cornerstone of clinical training. And though it is effective, but the resource is intensive, and the resource including the cost of performing simulation also. Dr. Aida already mentioned about that. And in virtual reality, it is emerging now. It is emerging as a new method of delivering simulation. And VR also offers benefits for learners and educators, and it's delivering cost-effective and repeatable standardized clinical training on demand. What can VR offer to us? VR systems usually comprise a headset and a laptop combination. Laptop, all students already have laptops, and they are commercially available, and so simple to set up and designed to ease and safety to use. Many VR systems work with no faculty, and learners can go to VR systems whenever they want to use it. So the scenarios are also repeatable, so they can use it repeatedly and performing the scenario until they are able to perform what best for them. And VR also allows simulation to be delivered at reduced cost. You know that we don't need the sophisticated simulation center. it's also can distribute it globally. So for within healthcare provider, a VR is like a solution for global training for medical healthcare. VR in CPR training first introduced by Italian Resuscitation Council, collaborate with European Resuscitation Council. They they built the platform for basic life support and automated external defibrillation training. This is not for medical students, but for bystander. This is what they built. This is the first PR for CPR. And this is what we try to build the VR for CPR training in IMERI with Dr. Aida. It still needs improvement, but it can be used. So this VR is not for lay rescuer, but it is for the medical students and for in-hospital cardiac arrest. So it can be used for medical students, and it also can be used for another resuscitation team. For this kind of ER, the students can perform the CPR on a mannequin, or whenever they are like in the remote, then they can use this VR for like they can use any kind of like pillow or anything that they can perform the CPR above that. Okay, this is for the airway management, because CPR is like always connected with airway management. So when we build the VR for the CPR, then we need to build PR also for airway management, because it's like in one process. One publication from Scandinavian journal said that CPR training using VR is a feasible and effective training methods. And however, for teaching technical skills, a classic training is still superior to VR training. Yes. On the other hand, considering the overall learning gain, VR training is superior to the classic training in most items in a comparative self-assessment. So they perform self-assessment, and they still want to perform the classic training. So therefore, future BLS or basic life support course format should consider the integration of VR technique into the classic CPR training. So what is the pitfall of VR in medical education? The VR should not replace clinical educators. So clinical educators are the best teacher for medical students. They can give feedback. Some educational opportunity are not suitable for VR training, such as we cannot replace abdominal palpation by using VR, for example, and we cannot change like something that really need the touch of the patients with the VR. And the complexity of language processing and facial expression are at the present, and it's best covered by a human rather than the virtual patients. Such as we cannot replace breaking bad news to the patient with VR, because we need the patient's or the family's expression and how they deliver the words and the language. Whilst there are a number of different applications of VR, in this pandemic, the biggest barrier to its adoption are the associated costs. Even though that this is even cheaper than training in simulation, however, it still have software to develop, and it still needs the device, the VR device, and the hesitance to change among the faculty members. Some of us said that this is a game, not an education. So the time, anytime, anywhere aspect of VR offers an exciting opportunity actually to keep students on track to graduate, no matter what this virus disruption takes them. And VR is already transforming our medical education. Many VR related to medical educations all over the internet, the applications and whatever. It is helping to free learning from the classroom and allowing learners to apply their knowledge to practice and learn from the mistakes. We even have VR for like bronchoscopy or esophagoscopy, etc. VR for CPR can be a valid and acceptable tools for training programs. It addressing general population, school children, and healthcare professionals with a gamification approach. It focuses on improving competencies and places the emphasis on autonomous blended learning, which is expected from the learners of today. So this is as a closing. So learning is an active process. We learn by doing. Only knowledge that is used stick in your mind. If knowledge doesn't use, it will flow away. Thank you very much.
Thank you, Dr. Ade, for a very clear and comprehensive talk. And we will proceed to the QA session for the question and answer. For your information, now we have around 376 participants join for this hall to attend this session. I believe it is quite large participants, and we are very glad that they can hear a very integrative and also comprehensive talk from all speakers. So I would like to ask several questions. Probably start with Dr. Arta. The first question, Dr. Arta, do you have any recommendation for the medical teacher or also for the healthcare personnel from hospital or healthcare institute? How can they start creating a VR module? Actually, what is the step? Is it the materials or starting with creating the team or the tools? Probably you can give tips for the medical teacher and also healthcare personnel. Thank you, Dr. Arta.
Okay,
that is the first question. Probably you can direct the questions first. Thank you.
Okay, Dr. Imelda, thank you. So yeah, it's quite a hard question. I think what you need first is yeah, you need to have a aim. The first thing is aim. What do you want to make? What module do you want to make? Such as like me, I am expertising in resuscitation because I'm in a medical emergency team. So that's why I want to make a module about the CPR. So you need to know what is the objective of the module first. And after that, you need to find a developer that can use operate and make the module. As right now, I think there's might be quite a lot of developer because right now the most of us we can use Oculus Quest. Oculus Quest is available. You can search it in Wikipedia, in Tokopedia, and then so I think because of the widespread use of Oculus Quest 2, so a lot of people and programmer are can develop a lot of module with that. And then after that, yes, you need to make sure you have a good communication, and then with the developer, and then how do you want to make it, and then how can how precise, how detailed that the thing that you want the learner to learn is achievable by the program. So I think that's all. Just don't make it complicated. Just make it very simple first, and after you've done that, then you can add a little by little. So you have to fragment your what do you want. So just one by one. I think that's all, Dr. Imelda.
Okay, thank you, Dr. Arta. And related with these questions, I believe that the next questions can be answered by Dr. Aida and also Dr. Ade. Probably the first one is about if a faculty or institute wants to create or to prepare the VR in their simulation center, what important things that they need to prepare or they need to settle before they create a VR module and then implement the training using the VR. Probably Dr. Aida and Dr. Ade can give clue or tips to create or settle the simulation center. Okay. From me, from what I know, that we can start it simple. So, of course, there is a wide range of virtual reality that can be performed, from the very simple one, just using a headset, and then a CPU that maybe we can, if we want that the learners walk, we just put it in the backpack, and then, of course, the developers who can develop the programs. But if we plan to, in the next step, to build a reality lab that's full of device that our student can learn a lot and can play a lot there, so we must make maybe a timeline where we can build step by step until we achieve a good and a big virtual the good reality lab. But I do believe that the technology will become cheaper and cheaper in the next few years, just like smartphone becoming more cheaper and becoming cheaper. So the technology, of course, the virtual reality becomes cheaper, and we can create a more sophisticated virtual reality lab by a lower cost. I think that's all for me. Maybe Dr. Andi Ade can add more information.
Yeah, thank you, Dr. Aida, Dr. Imelda. So, in my opinion, the benefits of VR, of using VR for medical education, it's like more about how to put it in the simulation way, right? So it cannot, the VR cannot replace the hands that touch the patient and cannot replace the hands that touch the mannequin. So maybe we can optimize the use of VR for like some things that we need them to do like several times repeatedly, or maybe until they can be more skillful with that technique, or with that critical pathway or whatever. But if we do VR in the simulation room, it just like adding the environmental what is it? So it makes them like more realistic by using VR, but they still need to perform the skills in the mannequin. So they need to sharpen their arms and their skills to perform the technique, or for the task trainer. But with VR in the simulation room, then it will adding value for the simulation room itself. That's my addition.
Thank you, Dr. Ade and Dr. Aida. And I think the last question can be answered by all speakers. So regarding the question previously, so in your opinion, which one is better for the implementation, of course, of VR module in training, especially the medical training? Is it just using the VR module, headset, or glasses, or combined with tools such as mannequins or the static models for body part, for example, or the mannequins that usually used for some kind of procedures? Which one is better? If we want to implement the training using the VR, is it only using the headset and also the VR, or better to use other tools such as mannequin? Probably all speakers can give their opinions regarding the experience of doing the VR training. Please.
May I answer first?
Yes, of course, Dr. Ade.
Yeah, it's depend on your purpose of learning. If it is a task training, then you need something to make their hands work. But if it is just like you need them to think in the simulation, I mean, you need they are more putting them into situation, into environment, then you can use VR. Such as you want the students like performing physical examination and make a decision about the patient, and make diagnostic, or make a decision for the patient, and make plan for the patient. Then you don't need that kind of mannequin. But if you just want them to see, this is like I have one application about performing bronchoscopy or fiber optic intubation for patient, and it's a VR. So it is not, we don't use the bronchoscope. So no hands, just phone, and just the VR. But they tell us, the program tell us, you already into the carina, you already into the main bronchus, you already into that's all. But not the task training. If the task training, you need a mannequin. Thank you.
Probably next, Dr. Aida or Dr. Arta want to add something? Yeah, I agree with Dr. Andi that it depends on what we want to teach our students. So, and what kind of sensor we need to so we can know the progress of our student as a learner. The more sophisticated one, like the one that we can use the eye movement tracking. So we know that when eye movement tracking can teach us many things about our students, like is he feel panic or not, is he see the right things or not, and then maybe we need the tactile sensor like the gloves data if you want to know is their finger is in the right position, or maybe something like that. Or maybe we can change it from the virtual reality to the augmented or maybe mixed reality if you want to see that he can feel the when the force, the resistance, or anything that make it more immersive, like the real condition. But I do believe that we don't need to force ourselves to achieve that that sophisticated device, but we can start it with what we want. We start it simple, and then we can increase it to a more sophisticated one. This from me. Maybe Dr. Arta can add more.
Thank you,
Dr. Aida. Probably Dr. Arta can add something.
Thank you, Dr. Aida, Dr. Imelda. I think I have the same answer like Dr. Ade and Dr. Aida. So we can we can make a module of VR based on how the level of the modules, such as in my presentation. If it's only level 1, only the knowledge, then I don't think we need anything for it. So just the visual one. But after, if we want to make a very specialty, such as laparoscopy or something like that, so we need the very highly sophisticated hand movement, motoric, a good fine motoric. Then we need to have a good sensor and also a good mannequin. So it depends, and of course the price will be higher, and also and it will be more difficult to make that kind of mannequin or that kind of module. But I think it will be possible in the future. Thank you.
Thank you, Dr. Arta. Since the time is already finished, allow me to conclude this session. And thank you for all speakers. From this session, we can learn that the VR training is an immersive learning experience that can recreate the real life settings and also simulates the work challenges. And it gives the medical student and also healthcare personnel the chance to gain on-the-job training in a risk-free environment where they can learn by doing. And why do we need this VR? Because it is the needs are increasing, and it is an integrated simulation-based, and the scenarios are repeatable. And it really encourages engagement and autonomous learning. And especially for the learners, they can make mistakes safely. And to end this session, for all medical teachers and also learners, don't make it difficult. Start simple, do more innovation, and dream high achievements. And I would like to say that this Saturday evening, together with excellent speakers for the day, really encouraging and challenging. And for all speakers and participants today, thank you for your attention. Stay healthy and have a great evening.